Good morning. We're very excited to have you here. My name is Julia Siufi, and I'm the editor-in-chief of a law journal. We're very excited to be hosting our fall symposium this morning and this afternoon if you're staying here. Please feel free throughout the day to go to the back, get some coffee, other refreshments, some food. Restrooms are on the back to my right, your left. Feel free to leave if you need to. We're very excited to have you here. This topic is very important, and we're very excited to have a lot of our speakers today. And without further delay, I would like to welcome Dean Kelly to the stage.
Thank you, Julia, and welcome everyone to the University of St. Thomas School of Law. My name is Dan Kelly, and I serve as the Dean and Mengler Chair in Law here at the Law School. A special welcome today to all of our guests and visitors, many of whom have traveled from across the state and across the nation to be here for this important symposium. I also want to give a special welcome to all of our students, especially those on the Law Journal, for all of the work that you have done and are doing to make this symposium possible. The University of St. Thomas Law Journal is the school's flagship law review. It seeks to embody the school's unique mission by publishing excellent legal scholarship that promotes ethical actions, the integration of faith and reason, and social justice. Its editor-in-chief, Julia Siufi, is here with us today and has done a great job leading the Law Journal. Also want to give a special shout out to the symposium editor, Mason Rademacher, and all those editors who have made this symposium possible. Also a special thank you to Professor Mitchell Gordon, who serves as the faculty advisor of the Law Journal, and especially want to thank Professor Mark Osler, who's the Robert and Marion Short Distinguished Chair in Law here at the Law School, for his help in organizing and making this symposium possible. So let's give it up for all of them. Law reviews and law journals all around the country are hosting symposia on important topics of law and policy. But I am hard-pressed to think of a topic that is more timely, more grave, and more significant for the future of our country than this one. Fentanyl, Tragedies and Solutions. Our distinguished speakers and panelists will explore today's topic in detail, but I just wanted to give brief background on the topic. So a few facts, and most of these are according to the United States Drug Enforcement Administration, the DEA. So fentanyl, a synthetic opioid, is a Schedule II controlled substance, similar to morphine in some ways, in providing pain relief, but about 100 times more potent. However, and this is quoting the DEA's website, illicit fentanyl, primarily manufactured in foreign clandestine labs and smuggled into the United States through Mexico, is being distributed across the country and sold on the illegal drug market. Fentanyl is being mixed with other illicit drugs to increase the potency of the drug, sold as powders and nasal sprays, and increasingly pressed into pills made to look like legitimate prescription opioids. Because there is no official oversight or quality control, these counterfeit pills often contain lethal doses of fentanyl, and there is a significant risk that these many other illegal drugs have been intentionally contaminated with fentanyl. Because of its potency and low cost, drug dealers have been mixing fentanyl with other drugs, including heroin, methamphetamine, and cocaine, increasing the likelihood of a fatal interaction. 2 milligrams of fentanyl can be lethal, depending on a person's body size, tolerance, and past usage. And the DEA has found that counterfeit pills ranging from 0.02 to 5.1 milligrams, which is more than twice the lethal dose of fentanyl per tablet, Indeed, 42% of pills tested for fentanyl contained at least 2 milligrams of fentanyl, considered a potentially lethal dose. And drug trafficking organizations typically distribute fentanyl by the kilogram. And just to give you a sense, 1 kilogram of fentanyl has the potential to kill 500,000 people. It's also possible for someone to take a pill without knowing it contains fentanyl, or to take a pill knowing it contains fentanyl, but with no way of knowing if it contains a lethal dose. According to the CDC, synthetic opioids like fentanyl are now the primary driver of overdose deaths in the United States. And just to give you a few statistics on the negative impact, both nationally in the United States and statewide in Minnesota, and these statistics are based from a published website by the Addiction Group, as well as the Minnesota Department of Health. In 2021 alone, which is one of the last years that we have reliable statistics, over 107,000 Americans died of overdoses, the highest total ever recorded. Fentanyl and other synthetic opioids are overwhelmingly responsible for this catastrophic loss of life. Indeed, nearly 71,000 of those 2021 overdoses involved synthetic opioids, primarily fentanyl. In Minnesota alone, in 2021, there were 1,286 overdose deaths, including 924 due to opioids, which was a 35% increase in just 1 year. And most of those opioid overdose deaths involved synthetics, once again, like fentanyl. Estimates suggest that in the 5 years between 2019 and 2023, in Minnesota alone, opioid overdoses, mainly through fentanyl, killed more than 4,000 people in the state of Minnesota. Importantly, no demographic is immune to fentanyl's devastation. Deaths are spiking among various racial groups, younger populations, including high school and college students, and older adults. The crisis cuts across state lines and impacts both rural and urban areas alike. Similarly, in Minnesota, the issue is affecting all racial groups, with especially devastating impacts on Native Americans, as well as several of Minnesota's immigrant communities, including immigrants who are Somali. In sum, because this issue is so important for both the state of Minnesota and our nation, and because it intersects with so many key areas of the law, from immigration law to criminal law and law enforcement to public health and health law, it is especially fitting that the University of St. Thomas Law Journal is hosting this symposium. So this morning and this afternoon, we'll bring together a diverse group of experts to share their insights. We have an emergency room doctor who will give you firsthand experiences of what's happening in hospitals. We have panels including law enforcement and law professors. We have a lunch keynote with Minnesota State Attorney General Keith Ellison. And we have panels this afternoon on people who have felt the firsthand effects of fentanyl in their lives, in their family lives, and in thinking about treatments and solutions to this important problem. So thank you for coming. Thank you for your concern for this issue. And with that, I turn it over to Professor Mark Osler. Mark.
Thank you so much, Dean Kelly, and welcome to all of you. My name is Mark Osler. I work here, and this is going to be quite a day, one I've looked forward to for a long time. Our first speaker is Dr. Chris Johnson, and this is, I heard Dr. Johnson speak several years ago, and it had an incredible impact on me. What we're dealing with fentanyl didn't arise out of nowhere. It arose out of a larger opioid epidemic. And as an emergency room doctor, Dr. Johnson was on the front line of seeing what the impact was on people of that opioid epidemic as it grew and changed over time. I've been looking for a way to bring him here to speak to us for a long time, and today is that day. Dr. Johnson.
Good morning. Thank you, Professor, for inviting me here. I'm delighted to be here and speak to all of you today. What a terrific turnout this morning for a topic that has been very important to me and has actually kind of been my mission over the last almost 20 years since I've been practicing here in Minnesota. This is actually the third time I've been invited to speak this year after about a 4-year break. There was another public health issue that kind of took the headlines in this country starting in about 2020. But this problem is still here. And in fact, COVID has taught us a few things about addiction, what drives it, and has had direct impact on the opioid crisis specifically. And I'm going to talk about that during the course of this talk. So a little background on me. I'm an emergency medicine doctor by training. I'm actually not from Minnesota originally. I trained at the Medical College of Virginia in Richmond, Virginia. And then in the year 2000, I matched to do my residency training at Hennepin County Medical Center because, you know, I was wondering where I could find 5-month winters. And you can find them in Minnesota. And so I moved here in 2000 to do my training here, and I never left. So I've been here for the last 24 years. And my introduction into the problem of substance use began here at Hennepin County Medical Center. It is an academic teaching hospital, and many of you know where it is. It's just up the street a little bit. And the truth is you can get a bit dismissive about substance use working in a county hospital and dealing with a county hospital population, which often has social pathologies that we say, well, that's not surprising. Kind of addiction goes along with that, substance use, things like incarceration, criminal history, family structures that have been disrupted, employment problems, if they're employed at all. And so, so a lot of them do have substance issues. And I didn't think too much of it during those years from 2000 to 2003. However, in 2003, I graduated from my residency program and went to work at Methodist Hospital in St. Louis Park, which, as we know, is a fairly nice suburb of Minneapolis. And what I saw there in the first couple of years of my practice staggered me. I was seeing the same issues with opioids in that patient population that I was seeing in the Hennepin County population. Patients coming in sometimes with a pain exacerbation, and they're on high dose opioids, and they've run out already. It's like a week before they're supposed to get their refills, and it was it wasn't a fracture. They maybe just strained their back lifting something. Sometimes they came in fully unresponsive, not breathing, and sometimes I could revive them with Narcan. Sometimes I had to put them on a ventilator. Sometimes they died. And it got to the point where I couldn't go a shift without seeing an opioid-related problem. And that's when I began to suspect there was something bigger going on. It wasn't just the county population. This is everywhere. And that began my investigation into this in the year 2005. So goals for this talk. The problem. Again, COVID took the headlines, but the opioid problem is very much still here and is in many ways worse than ever. And we're going to talk about those numbers. How did it happen? Okay. No one should leave this talk thinking this was just good intentions gone awry, that it was somehow an accident. It was not an accident. Now, the parties and stakeholders involved may not have intended to cause this epidemic of overdose and death, but they definitely had an agenda, and it was not the health of all Americans. Okay. Now, why did it happen here? Now, these pharmaceutical companies, and again, we're going to talk about their tactics in a bit, they sell all over the world. It isn't just the United States, but uniquely, this crisis happened in the US. But people are on opioids in Germany. They're on opioids in Japan, and some of these companies have seen increases in their rates of addiction and overdose, but nothing comparable to what the United States has experienced. So we're going to talk about what is it about the United States that has made us vulnerable to this. What can we do about it? I'm going to talk about treatment of addiction, both in terms of an individual illness as well as a social illness, because both are involved, and I'm going to show you evidence of that. Finally, I want to make it clear that all opioids are heroin, and all humans are on opioids. In fact, probably all mammalian brains are on opioids. And addiction is not about morality. It is about physiology, and it is about public health, and it needs to be treated as such. So the problem, what are opioids and why are we talking about them? Well, a brief history of opioids is the use of opioids to treat pain as a medicine goes back basically as far as we have written history. The use of this as an analgesic, we have records of that from Assyria and Egypt and Greece. And the traditional way of harvesting opium to treat pain is, this is the seed pod of the opium poppy, Papaver somniferum. And what you did was you made a little slice in this seed pod and collected this milky substance, and that contained your active ingredient, which we later called morphine. Okay. Now, as many of you remember, it's named somniferum because after the Roman god Somnus, which was the god of sleep, which first appeared in our literature in Ovid's Metamorphoses, which was the 15-volume epic poem in Latin detailing the history of the world to Julius Caesar. And I thought the first 10 volumes flew by the way. But the last 5, as I get to the Rubicon, and what you did was you dried out this milky substance, and that's apparently what it looks like. At least that's what the internet says it looks like. So I'm good with that. And raw opium contains about 12% morphine, and morphine actually comes to us from mythology as well. Morpheus was the Greek god of dreams. Now, how opioids treat pain, and I'm going to give you an oversimplified mechanism for this. If there's any physiologists here, I apologize. But opioids treat pain in a couple of ways. One is that there is some inhibitory action in the dorsal root of the spinal cord to inhibit or reduce the nerve signal that conveys pain up to the brain. But more importantly, for our purposes, opioids make you feel good. And it does this by increasing the amount of dopamine in your reward system, and thereby change your emotional state and affect your experience of pain. And pain is an emotional experience, kind of like all of life is. And your emotional context dramatically affects how you experience pain and the amount of suffering it produces. My mentor at Hennepin County Medical Center, who studied pain extensively, was Dr. Jim Miner, and he gave the example of something simple like stubbing your toe. Okay, and in one instance or scenario, say it's early in the morning and you're late for work and you're rushing around trying to find your keys, your laptop. Maybe you've been up all night. You've got a 1-year-old who's got an infection and they're crying. I don't have children, but I've heard of them. And your sleep is not high on their list of priorities. And in the course of trying to find your work belongings, you kick the coffee table and you just let loose a string of profanity, and that will likely affect the rest of your day. And contrast that in another scenario where you're out with dinner with friends at a restaurant and you're having a relaxing time and you get up to use the restroom and you accidentally kick the chair heading that way, and you don't notice it until the next morning when the toe is black and blue and you go, wow, I guess I hit it harder than I thought. So how you feel dramatically affects how you experience pain. But opioids, we know carry risk, and in high enough doses, they affect the respiratory centers of your brain and can slow or stop your breathing. And if something doesn't happen within a few minutes, you will have brain asphyxia, your heart will stop, and then you will die. Why are we still talking about this? The United States has about 4.5% of the world's population, yet we consume about 30% of the world's opioids. We consume about 3 to 5 times as much as the typical European. And it wasn't always like this. This epidemic reflects a dramatic change in the last 20 years, from the late 1990s to the 2000s. Starting in the late 1990s, opioid prescriptions tripled from the year 1992 to 2012. And it wasn't just that the number of prescriptions increased, the size of the prescriptions increased. That is, the amount of opioid in each pill dramatically increased. But then in 2010 and again in 2015, we developed new phases to this opioid crisis. Heroin and fentanyl, okay? As the prescriptions became harder to come by, a number of patients turned to illicit sources to get their opioids because they developed dependence, okay? And this led to what we call the phases of the epidemic, okay? But I want to strongly remind you, 3 out of 4 users of these illicit opioids began with prescriptions. That is still the gateway, okay? And they were exposed by the millions. The consequence of this increased exposure is a tragic and dramatic increase in overdose deaths. I think the latest chart I was able to get was from 2021. Over 80,000 died from all opioids, synthetic, from heroin and fentanyl and prescriptions. And again, we're here talking about fentanyl, but again, these other causes of opioids have remained at just, crisis levels. Fentanyl is by far the deadliest substance, but we still have significant amounts of deaths from prescriptions as well as from heroin. In fact, the amount of deaths from prescriptions is still around 14,000. That is the same level in 2012 when we were calling the prescription the crisis. So all of these are contributing dramatically to unnecessary loss of life. Since the opioid epidemic began, we have lost over 500,000 Americans to this crisis, almost 85,000 in 2023 alone. And in case you're wondering what 85,000 looks like, that's 28 World Trade Centers, okay? When I gave this talk for the first time back in, I think it's 2011, it was just, I can't point. It was just 6 of these. And I thought that was outrageous. And like, we went to war over one. Okay, but here we are. Little did we know that 15 years later we would look at 6 World Trade Center deaths as like, oh man, thank goodness we're back to that. But that's where we are right now. 500,000 is the number of U.S. soldiers lost in World War I and World War II combined. So how and why did this happen? We've lost celebrities and musicians, artists, athletes, maybe the most prominent faces of this, but we've lost Americans in every neighborhood, and some in the audience right now may have a family member or a friend of a family member who's been lost to this crisis. That's how common it is. Well, I know this is a talk with a lot of legal professionals and aspiring professionals here, and I'm going to be very frank and say that I have not been impressed with my profession over the last 25 years. American medicine has changed dramatically, and the pharmaceutical industry and its influence over the medical profession has increased, and corporate imperatives dramatically affect how care is delivered and what kind of care is delivered, how much care is delivered. The industry goals of the late 1990s, specifically the pharmaceutical industry goals, was to change the culture around prescribing of opioids to favor its increased use. The message that we were getting as physicians was that chronic non-cancer pain was an undertreated epidemic causing needless suffering, and our aversion or caution about opioids was misplaced, that they are far safer than we were led to believe. And the pharmaceutical industry used 4 primary tactics to accomplish this goal to change prescribing patterns. Number 1 is they recruited pain specialists. These are the academic leaders. These are often chairs of prestigious universities and departments. And they were there to act as the spokespeople for the pharmaceutical industry to convince us regular, everyday physicians like myself, I'm not a chair of anything, that these opioids could be prescribed in much greater numbers. They were safe. And we trust our faculty. We as and yourself, you can't go back and reduplicate all of the studies that have led to the breakthroughs in medicine that we've had. We're not going to go back and retest insulin to see does it really lower blood sugar and treat diabetes. We have to sort of trust the information, and that's true with the pain specialist. We look to them to They're at the forefront. They're the ones following the studies. Are they giving us accurate and ethical information? One of the most prominent industry leaders or pain specialists that became one of the champions was this doctor, Dr. Russell Portnoy. He was the subject of the Wall Street Journal article, Pain Drug Champion Has Second Thoughts. This was 2012, so some years ago. His mission was to rehabilitate opiophobics, about the safety and utility of opioids. And he was the president of the American Pain Society. Now, he was also a palliative care doctor, and he worked with a lot of cancer patients. And he began his career, and I would say very reasonably, like a lot of cancer patients suffered needlessly at the end because people were cautious about opioids, when in fact, in hospice patients, that shouldn't be your primary concern. And if someone becomes dependent at that point, they have bigger problems. They have more important concerns at that time. But then he expanded to say, well, if they're suffering, if these cancer patients can be treated this way, could we use it for other conditions? And that's when his sort of academic track, in my view, got off the rails. Okay. Now, he was the president of the American Pain Society, and they're the ones who came up with the idea that pain was a vital sign, the fifth vital sign, after, blood pressure, heart rate, respiratory rate, and temperature. And these levels that patients were reporting were to be taken as seriously as these measured values. Okay, but again, there's a difference between a reported number and a measured number. Okay, and I can't tell you the number of times a patient would tell me their pain is 100 out of 10. In 1996, he authored a position statement that was published in the Clinical Journal of Pain, saying the risk of addiction was less than 1%. And less than 1% sounds pretty safe, okay? Now, where did that less than 1% statistic come from? It came from a study in the New England Journal of Medicine published in 1980, okay? Now, that should raise a little bit of a red flag. So a study saying that, the risk of addiction is less than 1%. Now, 16 years later, you're publishing this. So we're going to look at this study, and if you'll, in the next 5-10 minutes, I'm going to go through some statistical charts and methodology and peer review, and I'm just kidding. You can read the whole thing in 90 seconds. This is it. This is the study. It was a 5-sentence letter to the editor. This isn't a study, okay? Actually, when Dr. Aaron Krebs, one of the medicine doctors at the VA, I was involved in with ICSI in a group trying to come up with sort of prescribing solutions. I asked her to send me the study, and she sent me this, and I'm saying, no, I don't want the summary, I want the study. He said, that's it. All that Porter and Jick said in the New England Journal in 1980 was that they observed these 11,000 patients who were in a hospital and received at least one dose of opioid for an acute injury. Okay, and that few in that circumstance very few developed addiction. But it only discussed the use of opioids for an acute injury in the hospital. It said nothing about the safety and efficacy of opioids prescribed outpatient indefinitely for long-term conditions. Nothing. And this is where I really hold my colleagues up to the fire here. This was a huge failure of medical ethics, okay? Because what Dr. Portnoy's case studies with his cancer patients and the New England Journal article, those are what's called observational studies, okay? That's at the beginning of the scientific process. You observe, okay? Then you generate the hypothesis and the question. Then you test it, all right? You do the study. You do a randomized controlled trial. You double blind it. You follow it not for 2 weeks or a month. You do it for a year, 2 years, then 5, okay? This study was eventually done, 25 years too late. I'll talk about that later. So what does he say now about opiates? Well, he said in an interview in 2010, I gave innumerable lectures about opiates that weren't true. If I had an inkling of what I know now, then I wouldn't have spoken the way I spoke. It should be noted that Wall Street Journal discovered millions in payments to his clinics during this time frame when he was talking about the safety of opioids. And his viewpoint on that was I could have those relationships. They would benefit my medical education mission, my research mission, and to an extent, my own pocketbook. And that reminds me of this statement by Upton Sinclair, that it is difficult to get a man to understand something when his salary depends on not understanding it. And that when you have a financial conflict of interest, honestly, you've kind of invalidated whatever you're saying can be viewed skeptically and should be. Tactic number 2, target primary care physicians and patients directly. This was never done by opioid manufacturers until 1996, and one product changed all of that, which you're probably all familiar with, which was OxyContin, made by Purdue Pharma as a continuous release preparation of oxycodone, and this was released in 1996. And basically, they came up with OxyContin to replace the product MS-Contin, which stands for morphine sulfate contin, or morphine sulfate continuous, okay? Their patent was expiring on that, and like a lot of pharmaceutical companies, when they've got a big blockbuster profit-making drug and that's about to become generic, they need something to replace it, and this is what they came up with as a way saying this is going to be less addictive because it's released in this continuous preparation, okay? Now, why would you target primary care doctors as opposed to just the hospice, cancer, and pain specialists? Well, they see the most patients by far, okay? Hospice patients is too limited a market. Okay, there aren't that many of them, and then tragically, sadly, they expire. Okay, you can't make billions on hospice cancer patients. You can make billions on back pain. This is from the article Promotion and Marketing of OxyContin. It was a marketing triumph and public health tragedy. From 1996 to 2001, conferences almost every other month about opioids, and they wined and dined and invited everyone in the delivery food chain, from the doctors, the providers, the nurses, the pharmacists, everyone. And Purdue Pharma released a video, gave it to the clinics and gave it to patients, called I Got My Life Back, which detailed 7 patients who talked about their chronic pain and how OxyContin was the answer and allowed them to live a meaningful, relatively pain-free and relevant life again, thanks to that product. And as you, what I have up here is a screenshot from that video saying that less than 1% become addicted. And we've just seen where that comes from, okay? But that statistic was in their promotional marketing. And I actually got this video because Anthony Bourdain did a heroin episode, was released in 2014, and it was I loved that show, and it was it was basically a traveling journal talking about social issues in the context of food, and he goes around the world. And this particular episode, he talks about his own addiction journey, and sadly, he'd lost his life to suicide some years later. But again, they got a hold of this video, and that's what went out to patients. That's went out to clinicians. The patients also got free drugs. This is a coupon for OxyContin that was given out to patients with chronic pain. Now, there was a rule from the FDA that says you couldn't hand out free samples of a controlled substance like you could an antibiotic. So what they did was, well, we're not going to give the free sample, we'll give a coupon. But over 30,000 used this program before it was eventually discontinued. But tell me that's not like the creepy guy outside the high school with a little bag saying, here, try this. The first one's on me. I'm your friend. Tactic 3, influence government and regulatory bodies to, again, make the flow of opioids easier and even incentivized. And one of the primary institutions that they influenced was the FDA, the Food and Drug Administration, which is largely the one responsible for assessing the safety and efficacy of a drug for generalized use by patients and the population, or assessing the use of an old drug for a new condition. The problem is the FDA is now greatly dependent on the pharmaceutical industry to function. And one reason for that is the 1992 Prescription Drug User Fee Act. Okay, now this wasn't done for nefarious reasons. This actually came out of the AIDS crisis, where in the late, some of you may remember the late 80s, HIV and AIDS, where people were dying by the thousands, and there's this terrible plague, and people are like, we need something to help. And so the FDA, being overwhelmed, enacted this so they could get extra funding to do these studies. But as a result, 25% of the budget of the FDA comes from the pharmaceutical industry. We're talking hundreds of millions of dollars per year. Now, it is very difficult for a regulatory body to oversee an industry and say no to an industry that's responsible for their paycheck. And then you have the problem of the revolving door, which is regulators then go to work for the industry that they were previously regulating. This also creates vulnerabilities of financial conflict of interest. One such conflict was this Dr. Curtis Wright, who was in charge of the medical review team that was overseeing OxyContin and determining its appropriateness for use for chronic pain. And he eventually, as they took the recommendation of this group and approved it. 2 years later, he leaves the FDA, goes to work for Purdue Pharma, and his first year's salary was over $400,000, which is more than I've ever made. Tactic 4, blur the lines between advertising and advocacy. Okay, the messaging seems much more authentic when it comes from patients and patient organizations than it does from well-dressed, often very attractive, pharmaceutical representatives. But you need to look very carefully at these organizations. Okay, Partners Against Pain. And you look at the logo, they're like holding hands. So this organization is fighting pain and loneliness. Who would be against that? But if you scroll down to the bottom of the web page, you'll see the Purdue Pharma logo. Okay, this Partners Against Pain is Purdue Pharma, and it's part of what they called their unbranded outreach. The New England Journal did a study. This was in 2017, and it looked at these patient advocacy organizations and found like over 80% of them received extensive funding, sometimes exclusive funding, from the drug and tech manufacturers that were involved in that particular industry for that medical problem. And so you can very easily wonder, are these really grassroots organizations or are they corporate mouthpieces? And some have been shown to be nothing but corporate mouthpieces. For example, the American Pain Foundation was shut down in 2012 after a Senate investigation concluded they're really just nothing but a pawn of the pharmaceutical industry. And the same thing happened in 2019 with the American Pain Society. This is the same society that said pain is a vital sign. Senate investigation showed, yeah, you're pharma. I would like to be able to tell you that these are isolated and rare instances where these pop-up organizations, one disappears, another one pops up with a slightly different name, but the same kind of problem. Unfortunately, I can't do that. The influence of the pharmaceutical industry even goes as far as the American Medical Association. Again, the largest organization representing doctors. This is from their 2019 Board of Trustees meeting where they have a corporate roundtable, and on there, Janssen Pharmaceuticals, Mallinckrodt, Teva. These are companies that have admitted liability in their cause of the opioid crisis and have agreed to pay out billions. Okay, these are on the AMA's corporate trust board of corporate roundtable and corporate partners. Okay. Oh, by the way, I'm not some great internet sleuth. I'm fairly basic. It is embarrassingly easy to find information like that. That is a simple Google search. Okay. Now we talk about that money is speech, but it's a special kind of speech. Okay, because money also buys behavior. Okay. I don't work for free. Okay. You guys don't work for free. Okay. As a patient, you want and trust and you hope that a physician has nothing but your health in mind. Okay. And that's what we take an oath for. Okay. But we have seen that money can change a physician's behavior, and sometimes it isn't even that much. We've had multiple studies on this. This study in 2016 showed that a $20 lunch could change prescribing. Green Mill Pizza, we used to get it at Hennepin County all the time at our resident lunches. We've even seen how this affects opioid prescribing. One of the consequences of the Affordable Care Act was the Physician Sunshine Payment Act, which made more transparent gifts to physicians. Okay, and this study published in the Journal of the American Medical Association Network showed that these researchers went county by county across the United States and looked at gifts from opioid manufacturers, and they found that in counties where there were more gifts, there were more prescription opioids and there were more overdose deaths. And then did people really reclaim their lives with OxyContin? Well, you couldn't tell if you actually looked at what happened to the 7 people in that video because 2 of them died in active addiction. And a third one became dependent on opioids. She's in the top right, but she says she was able to wean herself. And as far as I know, she's still alive. So pharma is the one to blame. I've detailed their tactics. We've seen how they have a corrupting influence. And I do hold them greatly responsible for this. But again, pharma sells all over the world, not just the United States. Okay, this crisis happened to this extent here. In many ways, this is a very American crisis. So why America? Well, this is from my year in performance review in 2012. Those are my arms. I'm very proud. Took work to do that, by the way. That's Chris, we are also proud of the work you are doing with chronic pain, but it's such a fine line between increasing risk of opiate addiction and HCAP scores. And that was from my medical director. Okay. Do you guys know what HCAP scores are? They're your Yelp reviews. Okay. HCAP scores are your patient satisfaction surveys. They go out to a certain percentage of patients after their visits, and they basically ask them, how was your experience? Okay. You should be aware that they don't exist to make you healthier. Okay. They exist to keep you as a customer. Okay. These are the questions you might get. During this hospital stay, did you need medicine for pain? During this hospital stay, how often was your pain well controlled? During your hospital stay, did the doctors do everything they could to make sure your pain was managed? Now, if these satisfaction scores were about your health, then why do drug dealers use them? Okay, this book is some years old, but it was a fascinating read, Dreamland by Sam Quinones, and he talked about the opioid epidemic paralleling, from cartels in Mexico and to communities in the United States, and showed how the cartels in Mexico learned to use service economy techniques rather than just fighting it out all the time, which was sort of inefficient and violent and didn't make business go better. But they would often send to their customers, was your driver polite? If they said no, you never saw that driver again, and maybe no one saw them again. Was the dope good? If the dope, you say, didn't really do it for me this time. An hour later, on knock on the door, this one's on us. Sorry about that. We'll do better next time. The emphasis on customer satisfaction, we call it the patient experience in the medical industry, which is simply just the customer experience, but substitute patient. It's because medicine in America is, in my experience in the last 20, 25 years, a business enterprise, first and foremost. Okay. Every business has as its primary directive, make money for the shareholders, the owners. Okay, this is something we term fiduciary responsibility. And legitimately, and we don't have shares in medicine, but we do have bondholders. I mean, one person's healthcare activity and healthcare consumption is another person's investment opportunity. That is the industry. Okay. For this reason, America is really not incentivized for your long-term health. It is incentivized to keep selling you healthcare services. Okay. But there's a conflict of interest here. Why? Healthy people consume less healthcare. Okay. Now, why would this cause a risk for an opioid crisis? Because a system driven to sell services thrives and does its best business when you are in a state of chronic disease. And this is precisely the model of opioids for chronic pain. This checked off all our boxes. Okay. We expanded the customer base. Okay. It's an epidemic. Now, again, the customers are not just those in hospice with cancer lesions going all over the place. People in chronic pain in the tens of millions, okay? And opioids are prescription only, okay? And they solve the problem. So, it's an easy visit. You have to keep coming back to the doctor to get your prescription. It's not just Tylenol. You can't buy it on your own. And because dependence is a very frequent complication of opioids, you've got a returning customer for years and years, okay? Now, healthcare is expensive everywhere, but this emphasis on it as a business enterprise has real consequences for the nation. I'm sorry, this doesn't really project well, but the lines going sort of towards the top are the other OECD nations, which are the developed democracies: Canada, Germany, Japan, Australia, France, UK. And off to the right, as you see trailing off, is you have expensive healthcare on the horizontal axis and life expectancy going up. So by far, the United States is the outlier in terms of the amount of money we spend per year and the kind of life expectancy we get from that. So what can we do about this? We're going to talk about change, hopefully, okay? And I want to talk about addiction as something that's both an individual and a social illness and should be treated as such. For those who have developed addiction, we treat the individual with best practices, with scientifically shown studies of what is effective, and we want to treat a society that also puts people at risk for addiction. Prevention is the key. All right. We want the providers to stop starting patients on opioids with the intention of going on indefinitely. Okay, opioids have a role. Okay, I prescribe them. Okay, they're best used and indicated for acute injuries, kidney stones, fractures, or after a surgery. Okay, they're also indicated maybe indefinitely for those with those terminal illnesses, cancer, metastatic, where their illness is the reason you want to prevent addiction is because of all the things it takes away. Okay, your ability to work, your ability to maintain relationships and family. Okay, in a person with end-stage metastatic disease, the disease is going to do that already. So dependence is not the main concern, okay? So we need to stop creating new chronic users of opioids, okay? This quote from Desmond Tutu sums it up very, very aptly, which is there comes a point where you need to stop pulling people out of the river and go upstream and find out why they are falling in. We talked about the failure of medical ethics, about not doing the controlled study. Well, it was done eventually in 2018. It was just the SPACE trial by Dr. Erin Krebs, and she did a randomized, double-blinded controlled trial of opioids and non-opioids and found out they do not work any better when measured over the course of a year. And in fact, opioids have higher rates of complications, which is exactly what the public health data showed us. And it doesn't take very long for opioids to cause dependence. This study by the Washington Post Kaiser Family Foundation showed that about a third of patients who began opioids were dependent within 2 months. Now, there is some good news. This chart shows that the top purple line that you see kind of is sloping down. The amount of prescribing has gone down, so that is encouraging, okay? But as you can see, the curve that is spiking upwards is deaths from fentanyl, okay? Now, it should be remembered that, we exposed patients by the millions, okay, back in the 90s and early 2000s, okay? And then the deaths have been in the tens of thousands, which is still awful, but there's still many millions out there that got started and still are on opioids, that still are at high risk of having complications and overdose deaths. Treat the individual, okay? Use best practices. Now, we have effective treatments for those, especially in the early phase of coming off of heroin and opioids, which is medical-assisted treatment. Methadone and buprenorphine both show significant reductions in overdose deaths, okay? This was a study from the Annals of Internal Medicine 2018, which followed over 2,000 patients in Massachusetts after a non-fatal overdose, okay? So there's real benefit to these medicines. But medical-assisted therapy is not a cure for addiction, and there isn't any cure for addiction, okay? But that shouldn't get you too depressed. There's no cure for diabetes either, okay? These are long-term diseases. We manage them and help people live their lives, okay? But the problem is that, as it showed in the Addiction to Medicine Study 2017, once opioid use disorder develops, about 1 in 5 are dead in 10 years, okay? And it isn't just from overdoses. This is all-cause mortality, because those who find themselves in opioid use disorder, probably the rest of their lives, their diet, their exercise, they have other things that are not very healthy in their lives contributing to their early deaths. Narcan, okay? I'm all for making Narcan more available, but we're not going to Narcan our way out of this, okay? Harvard study showed that about 1 in 10 who had been revived with Narcan died within a year, okay? So if you're at that stage, you're at really high risk. And in Minnesota, Prince was revived with Narcan 1 week before he died. That's what his plane drove out of the sky to go get the Narcan, go to the ER after a show in Atlanta, and he was dead within a week. Now, we want to use everything we can to help patients get better. That's where it's psychotherapy, cognitive behavioral therapy, addiction psychiatry, peer support. All of them play an important role in helping the individual recover. But I want to point out that there's limits to the effectiveness of individual treatment, okay? These stats are very compelling. You compare the United States to the European Union, and we have about 10 times the overdose death rate as the European Union, but we have 10 times the treatment facilities per person, okay? We have more peer support organizations, the Narcotics Anonymous, than any other country. We have 40% of the NA groups in this country alone, okay? And we've increased the amount of Narcan 1,300-fold, okay? And the curves continue to spike upwards, okay? So I want to talk about addiction as a social illness, okay? And some other opportunities for intervention here. A very fascinating book was published in the year 2020 called Deaths of Despair. And it showed how the social conditions in this country have not affected populations equally, okay? This was by Case and Deaton, they're economists actually, and they showed that the rates of premature death in this country have been going up for the last 20 years. The graph that you're seeing on your left and the very high sloping, those are poisonings, accidental deaths, opioids driving most of that. But this also details the deaths from chronic liver disease, overdose, and suicide. And the group that showed the most increase over the last 20 years was middle-aged white Americans without a four-year degree, college degree, okay? And they're in the red graphs going up, where the gray, I don't know if you can see it, it's kind of, those are with a four-year degree who have not experienced the same level of increase of deaths, which has increased 4 times for those without the degree, okay? Now, the message of the slide end of the book is not tell your patients or tell your friend, go get a four-year degree and you'll be safe, okay? The message is there's a substantial part of the population that is feeling irrelevant and left behind. And then there was COVID, and what did COVID teach us about addiction? And lessons from the pandemic were very clear. From 2019 to 2021, and I think the dean spoke about this, the amount of opioid overdose increased dramatically. It will increase 50% in 2 years, from 50,000 deaths per opioids per year to 75,000 within 2 years. We'd never seen that before. But alcohol sales and alcohol deaths also went up. So things like food insecurity, housing insecurity, financial insecurity, boredom, you're isolated, you're lonely, you can FaceTime with your friends and family, but it's not really the same thing. We didn't evolve to like, that's what's our interaction. All of these create the risks for addiction, okay? You're feeling emotional distress. Sometimes the distress can be relieved with substances, at least temporarily, but it's a very imperfect and damaging solution. The Vietnam War gives us a very interesting case study of the social contributors to addiction. From 1954 to 1975, the Vietnam War continued, and there was this national worry about an addiction crisis that was about to return home to the United States, and this is during the Nixon administration. And the thing is, it never happened. So what happened was the Department of Defense did a study, and they found that about 20% of U.S. servicemen, while they served in Vietnam, became dependent on heroin, okay? Now, this is like 100 times higher than the rate of heroin dependence here, okay? So what does that tell you? First of all, well, that's conditions dramatically affect your risk for addiction, okay? Because a supposedly random draft got this much higher risky population for addiction, okay? But these people were taken from their home. They had long hours of boredom. They were at risk of their own personal injury, maybe death. They were asked to kill people, some of them, okay? A lot of this causes PTSD. And actually one very interesting study I saw was that PTSD is not simply that you're at risk. PTSD involves this sort of change of like who you believe you are. And an interesting study showed that drone pilots in Afghanistan had almost the same rates of PTSD as infantry, but they're not in danger. But what was it? Because many times these drone pilots were asked, like they were to target a specific household. And so what they did was they circled around this house and they saw the infrared signatures of like children playing in the yard, women, putting up the laundry, but granted also suspected person who hunts Americans, okay? And we can argue, we're not going to argue the rights and wrongs of that. But then one day after weeks of observing this, they were given the order, you drop the bomb now. And that caused a lot of psychological trauma. They had to ask, am I the type of person who bombs a family? Okay. So in any case, when these veterans came home from Vietnam, they found they got better 90% of the time, maybe 95% of the time. Okay. So they were back at home. They had social support. They were engaged in activity that had meaning to them. Okay. Now so once they got over their actual physical dependence, they found they didn't need to go back to that substance. So nothing changes if nothing changes, okay? And sometimes our model here is a bit too, we sometimes put them in a rehab facility that's 30 days or 90 or whatever, and they recover from their physical dependence, but then they go back to the same situation, okay? Same job or lack of job, same social structures with families, and all the things that put them at risk in the first place, okay? And we should remember that addiction kind of flows out for the entire context of a person's life, including their history. Okay, so just say no is meaningless. Okay, it's always been meaningless. Okay, what we do have to do as a society is help them say no. So final take-home points: the American medical system ain't going to get us out of this. We've had this for over 20 years, and if it had the answers, it would have done it by now. Okay, the American medical system also is about the 5th largest economy in the world. We don't suffer for resources. Okay, in fact, the expense of the American medical system takes wages away from people because the cost of insurance goes up, and that puts an added financial stress. And added financial stress is a risk for addiction. As far as the human brain is concerned, all opiates are heroin. Okay. And heroin is actually not originally a street drug name. It actually comes to us from the good people at Bayer Pharmaceuticals. They're the ones who gave us aspirin, and it's a German company. And when they first came up with heroin, which is diacetylmorphine, they tried it on their employees. And they, asked them how it made them feel. And their response was heroisch, which means heroic or strong. So they added the IN ending, so it became heroin, just like aspirin. Okay. But this is the molecular structure of heroin. That's the top middle there. And as you can see, the molecular structure is very similar to oxycodone and hydrocodone and hydromorphone, Dilaudid. These are all prescriptions, okay? So as far as the brain is concerned, all that matters is does it fit enough to go into the receptor? And if so, you've got the same compound, okay? So don't be fooled by the outward appearance of it, okay? So the black tar heroin looks dangerous, it's dark, it's dangerous, it's evil, okay? Whereas prescriptions, look, Vicodin is as white and pure as a snowfall or a wedding dress. It can't be dangerous. To the brain, it doesn't matter, okay? In fact, if you were to go to the United Kingdom, you might get some heroin. If you are unfortunate enough to have an accident and you break your wrist or or an abscess or a kidney stone, you might end up in an ER there and get 2 milligrams of diacetylmorphine, and that is known by here as heroin, and you'd be, thank you, that was compassionate, ethical treatment of pain for this acute condition. And it also, we should bear in mind that the only reason these compounds do anything in our brain is because our brain makes these as well. These are the endorphins we make, okay? Endorphin is a contraction of two terms, endogenous, meaning made from within, morphine. Endorphins, or endorphins, okay? We are all on opioids. They are involved in all of these social interactions and behaviors that we want to incentivize for our survival, the survival of our DNA, like sexual intimacy, healthy social interactions, nutritious food. All of that causes releases in opioids, but at physiologic doses, not pharmacologic doses. Addiction has nothing to do with morality. Okay. And here's where I would have a contention with some of the more traditional treatment paradigms that still use terms like defects of character and moral inventory, which we don't use for any other medical condition, by the way. No one would dare speak of that. Okay. No, tell a person your heart disease is due to, no, never. We have seen addiction and created addiction in multiple other species, okay? Chimpanzees and rats and pigeons, gambling and alcohol. We don't refer to these other species in terms of their character defects, and we shouldn't do it in humans. Or you have an amazing coincidence to explain that at the same time we were increasing our marketing and sales, we had a parallel and proportional increase in the number of immoral people in this country. All right, so I'm concluding with this slide. 1 minute, perfect, okay? This is the painting Despair by Edward Munch. He's the one who also painted something called The Scream, okay? And I use this because as frustrating as sometimes my experiences have been with patients on chronic opioids, how often demanding they were in the emergency department, demanding of me, demanding of the nurses. Life in opioid addiction is pretty miserable, okay? And I am not here advocating for change in prescribing patterns because I want people to suffer pain. I am not here criticizing the American medical system because I don't think there are good physicians. There are, okay? And I want to include myself as one of them. I argue for changes in how we treat pain, especially chronic pain, and how we approach the delivery of healthcare in this system, because this can be a miserable experience for many, okay? And the truth is, we all deserve better than this. And thank you very much. Now, I believe there might be a brief question and answer, or what would you want to do?
We can take a question. Yeah.
Or however you want to do it, yeah. And is there a microphone and people raise their hands and stuff like that? And does someone?
We'll be coming around in just.
All right, very good. And if there are, that's fine. I can go sit down. Yep. Yes, we have seen changes in the profession regarding prescribing. As I showed in that slide, we have seen significant downward trends of like a decline of like 30 to 40%. Okay, now that still doesn't approach what we were back in the early 90s in terms of the amount of prescribing. So it is still too much. Okay, some of it, the truth is, for a number of these patients who have been on these for 5 years, 10 years, they may not be able to get completely off it. And so that their elevated level prescribing may simply continue. But what we certainly can do is not increase it any further. And the nature of these substances is to, the body adjusts. In fact, the body adjusts to opioids very quickly, within weeks. Okay. In a certain sense, you might even say like human brains aren't adjusted or well adjusted to feel like that awesome for very long. Okay. You're more, the evolutionary stable emotional state is kind of meh. Okay. Feeling great all the time is simply not stable. And the brain, once it's on these opioids, begins to push back and stop responding to them right away. And the pain doctor, I don't know if the pain physicians will talk about that, like the actual ongoing use of opioids will actually increase your experience of pain for that very reason. So we have seen a decline in the prescribing, but for some patients, it may simply be we're going to have to just maintain, and then also over time look to see what are the red flags for things of addiction. When you see certain behaviors such as lost prescriptions, failed follow-ups, losing their job, etc., and then get them, once we start seeing that, make sure they get the treatment they need for addiction, because addiction involves more than just dependence. It involves an emotional connection to a substance. And once you develop that emotional connection to the substance, that's when you get the compulsive, dangerous use. Okay. All right. Well, thanks again.
Thank you again, Dr. Johnson. We appreciate those remarks and setting the scene for us here this morning, or the stage for the rest of the discussions that we'll have throughout the course of the day. I'm Mason Rademacher. I am the Symposium editor. So if you've received emails from Mason, that's me up here. Thank you all for being here. We're so appreciative of that. A couple of reminders as we continue going throughout the morning here. We will have a break after our next panel, so don't worry, that is coming. But if you do need to use the restroom, they're back over behind everyone on what would be your back left. Please feel free to get up and go back there. We also have coffee, water, and some morning pastry things left back there as well, so please feel free to grab those. Before I introduce our next panel and ask those speakers to come up, I'd be remiss if I didn't mention our co-sponsors for this phenomenal event, and that would be Law Enforcement Leaders to Reduce Crime and Incarceration. That project, LEL, is the acronym for that you might hear throughout the course of the day. Many of the speakers that we have with us this morning come from them and come from Professor Osler, who's also a member of that organization as well. So if we can just take a second, and we'll thank them again at the conclusion of the event, but just thank them for their co-sponsorship and their partnership in this. And with that, we'll transition into our next panel featuring law enforcement members. And so please welcome to the stage our moderator for this panel, Rosemary Ruby Nadiri, Senior Counsel in the Justice Program at the Brennan Center for Justice at NYU Law School, and former federal prosecutor in New York. And then she also oversees the LEL project that I just mentioned. And then please also welcome to the stage the panelists, Sheriff Kelvin Barrett from Dane County, Wisconsin, Miss Stephanie Morales, who is also approaching on my left up here, the Commonwealth's attorney for the city of Portsmouth, Virginia. And then behind me is Sheriff Dewana Witt from right here in Hennepin County. So with that, I will turn it over to these panelists. Thank you.
Good morning. Thank you, Mason. Thank you, Professor Osler. And thank you, Dr. Johnson. That was a really great context for the conversation that we're going to have here with this panel. I want to first give you a little bit of background on the group you just heard about, Law Enforcement Leaders. So I am a senior counsel in the Justice Program at the Brennan Center for Justice, which is a nonpartisan nonprofit based in New York City, affiliated loosely with NYU Law School. It's an organization that basically works to improve our systems of democracy and justice for all Americans using a combination of research and data, policy solutions, practical policy solutions, and kind of trying to figure out what we can actually implement in today's world to improve our systems of democracy and justice. Law Enforcement Leaders, LEL, was a project that was started by the Brennan Center's Justice Program back in 2015. And it's a coalition of approximately 200 current and former sheriffs, police chiefs, DAs, corrections leaders, and attorneys general from around the country who came together with the idea that it is important for law enforcement, believes that it's important that we focus on both reducing incarceration and reducing crime, and that they are not mutually exclusive, that they are it's actually important for public safety from law enforcement's perspective to think both about how we reduce crime and prevent crime, and also how do we make our systems of justice systems of law enforcement and justice more fair, more equitable, and also how do we reduce our mass incarceration problem. And so that's the project that I manage, and I come from it from a background of over a decade as a federal prosecutor in Manhattan. And so I'm very excited to introduce this panel, which consists of members of the group. And Professor Osler is one of the founding members of the group. Paul Schnell, whom you'll hear from later as the commissioner of the state's corrections department, is also a member of the group, and others. And so what we try to do is to bring that law enforcement expertise to these conversations about public safety without thinking about it in kind of, I would say, the traditional way that law enforcement approaches these issues. So these are people who are trying to think about these questions that we've just heard in, kind of thinking about it in ways that we can actually try and improve the problems and look at it holistically. So with that, I'll introduce this panel, which you've heard a little bit about. So first, to my right, we have Sheriff Calvin Barrett, who was appointed to the Sheriff of Dane County, Wisconsin, which includes the city of Madison, in 2021. And he was elected in 2022. He has a bachelor's degree in sociology and a master's degree in criminal justice. And he also teaches criminal justice at Madison College. And so he's passionate about education, as he was talking to us yesterday at dinner. Commonwealth's Attorney Stephanie Morales, who was the first woman elected as the Commonwealth's Attorney in Portsmouth, Virginia, back in 2015. And I believe she was also the youngest Commonwealth's Attorney elected at that time, and probably still. She has, in the past decade, been committed to seeking restorative justice, correcting the wrongs for members of her community that the system has wreaked, but also creating public safety for all members in her community. She established the Control-Alt-Delete program to foster successful reentry for formerly incarcerated individuals, and has also mentored over 200 students in a program called Future Leaders Initiative. And like Professor Osler, she's one of the founding members of LEL. And we also have your local sheriff, Sheriff Dewana Witt. Thank you so much for joining us, who was sworn in as the Hennepin County Sheriff in January of 2023, and is the first woman and person of color to hold that position. And in just the last, I guess, little over a year and a half, she has created a new auto theft unit to combat historic high numbers of auto theft, reinstated the DARE program to build relationships with the community and young people, and prioritized providing treatments such as Narcan trainings and free Narcan to fight the growing opioid crisis, and also launched a jail data dashboard for transparency. So our goal for this conversation for this panel is to make it a conversation and to really hear from these law enforcement leaders about how they are seeing this problem in their communities and what they are thinking about in terms of trying to address it. I think, Dr. Johnson talked about how the medical establishment isn't going to be the solution to this problem. I think we all come at this from the perspective that while law enforcement may be part of how we need to address it, it also is not going to be the solution to this problem. And so I think a lot of what you're going to hear from this panel is how do we really try and minimize the need for law enforcement to be involved? And how are these leaders trying to think about it that way? So we're going to have a period of question and answer, and then I think about 20 minutes at the end we'll leave for questions. But and I think you have note cards if you want to put down your questions. Mason will kind of organize the Q&A at the end. So with that, let me just first start with all of you. I'd like to ask you each, and I'll just start with Sheriff Barrett, to describe just very briefly in a couple of minutes how you have seen this fentanyl crisis impact your community, and what has been your approach to addressing it.
Yeah, well, good morning, everyone. My name is Sheriff Calvin Barrett, and thank you, Ruby, for the question. It has impacted our community in numerous ways, not only in the urban areas of our city, but also in our rural areas as well. And as we've typically seen with drugs in the past, over the past 30 years in our criminal justice system, typical drugs have been, prominent in certain areas, whether it's urban or rural, but fentanyl is everywhere. And it's connected to so much violent crime that affects everyday citizens going to, coming from work, coming from church, school, and it's affecting us in a significant way. Fentanyl is connected to violent crimes, including human trafficking, sex trafficking, labor trafficking, property crimes, petty crimes, overdose deaths, and it's affecting everyone. It does not see socioeconomic status. It doesn't see race. It doesn't see religion. It doesn't see political affiliation. And it's something that's really taken a stronghold of our community in Dane County, as now we are starting to put a lot of resources into combating this issue. I want to be very clear up front that this epidemic is not a law enforcement issue. It is a social issue. But what society has done is it's forced law enforcement to handle what it can't handle. And we see this in so many different areas that we'll talk about before. I'll be clear again, is that we are not going to arrest our way out of this addiction issue. There are some people out there that think the heavy hand of the law and incarceration is going to help. But I'm telling you, as a sheriff of a very large sheriff's office, which is the largest in the state of Wisconsin, it's not working. It hasn't worked ever, and we have to find new approaches. And I'm excited to be here with my partners here to talk about those approaches and share that with each and every one of you.
Good morning. Again, Stephanie Morales, Commonwealth's Attorney for the City of Portsmouth, Virginia. And I think what my counterpart just said is something that we all feel. So I'm going to take a bit of a different approach. As a daughter of my community, what I have seen is a lot of hurt and a lot of pain. And I think as elected officials, we talk about the issues, we talk about the criminal aspect of it, but sometimes we don't talk as much about the human aspect. And so I've been doing this since I was 31. In the elected since I've been in that office since I was about 27. And I have seen people come through the system who I grew up with. I've seen their family members, and we have just seen loss as a result of this crisis. People are here one day and the next day they are completely gone. And so it has been painful, it has been harmful, and it really has created a situation where as system actors, we have to look at ourselves. And I heard the doctor who spoke earlier talk about his feelings about his profession. And this has been an issue that has caused me, among other things, to look at my profession and see the harm that we have done by just approaching the issue from a law enforcement or a prosecution standpoint. So I've seen the hurt, I've seen the pain, but I also have seen the harm my profession has done. And I also have seen the confusion and the mass pandemonium that we have as system actors trying to work together. I've seen some individuals want to treat this as an issue where we need to be charging drug dealers with murder. And I've seen other people who say that we should be looking at this from a behavioral health standpoint. So I've seen a lot of things. But ultimately, what I come down with is that we all have a responsibility to work together to approach it in a way where we are addressing the issue at hand. And that is the fact that we are losing people. Our communities are hurt. We're experiencing a great amount of loss. And it is our responsibility to make sure that we're not treating this the same way that we've treated a lot of other things and just try to handle it from an incarceration standpoint. And that's one of the things that I've really been proud about being a member of Law Enforcement Leaders to Reduce Crime and Incarceration. It is a long title, but it says the important thing, which is that we're leaders and we are law enforcement leaders, but we want to reduce incarceration because we know that incarceration is not making us any safer. And that is both in terms of violent crime, but also with addiction related issues. So I very much look forward to this conversation. And I will always center the fact that we have to be a harm reduction component when we think about our work.
Good morning, everyone. Dewana Witt, Sheriff of Hennepin County. I actually grew up in this county, in the city of Minneapolis. I want to first preface with saying that I come from a home where addiction ran rapidly and it led to all other kinds of failures within the family. I've lost my mother and I've lost my sister to drug abuse, lost my father to alcoholism. I've been a victim of many crimes as a kid, me and my siblings, because of how it impacts the community. Fast forward here, my first degree is in chemical dependency family therapy, and I practiced in nonprofit working with families who had chemical health challenges as well as child protection cases. So I do not only bring personal experience, but professional experience when it comes to this topic. Fast forward here as the Sheriff of Hennepin County. My first year in office, I had a mother that came to visit me who lived in Bloomington. She wanted to talk to me about losing her son, her 17-year-old son, to fentanyl. She talked to me about how no one's helping her. She talked about the stigma that her son was an addict. He was an athlete who inadvertently became in contact with fentanyl. And as we all know, it does not take a large amount to kill someone. That prompted me having that sit-down conversation with that mother to start a program at the Hennepin County Sheriff's Office called Focus on Fentanyl. Let me say this too, I just got over a cold and flu. This is not my normal raspy voice. I'm not trying to sound all whoosh either. So,
You sound great, Sheriff.
Thank you. But yeah, my husband likes it better too, but yeah, anyways. Anyhow, when you put that personal touch on it and you're actually meeting the families, even at our high elected positions, that's something that has to be done to be grounded, to stay grounded. That is our jobs as elected officials. That's our job as appointed in appointed positions. What I hear here is, and I agree with, collaboration. There's no one entity that is going to get us out of this. However, a part of our focus on fentanyl approach is that there has to be not just accountability, because sitting down with parents and talking about when someone knowingly is distributing it and they lost a loved one, there has to be accountability for that piece. We also need to talk about the stigma that not every dealer is doing it to feed their habit. That's not true in cases, but that brings me to the point where we cannot group any of this together. They're all individual. There's individual components to all of these cases, and I don't think we do ourselves any service to stereotype anyone. Lastly, with our fentanyl focus on fentanyl, thank you very much, initiative. What I learned from talking to another mother who lost her 15-year-old daughter. That mother will forever in her mind wonder if she could have saved her daughter, as she was talking to the dispatcher, and the dispatcher asked her if she had Narcan. And she had no idea what that was. So part of our approach and response from the Hennepin County Sheriff's Office is not just collaboration, not just accountability, but it has to be education. Unfortunately, we still have a large part of our communities that believe that this happens to everyone but them. There's this idea out there that this is a white person's drug. Well, we know in Hennepin County, there is an increase in overdose deaths in the Black community, our Native American community. Education has got to be a piece. When we're talking about prevention and intervention, you got to have the information to do that. As you heard in the bio, bringing back the DARE program. Well, there's a lot of reasons around that. Our children are dying and they don't have the information. So building those relationships with our young people has got to be a component, and it's more than just say no. It's not about that. It's about building confidence, building that stamina where they can feel healthy about the decisions they make as they're facing all this peer pressure. So it's interesting because there's been different ideas about bringing that program back. To me, it's we have to do whatever we can to make the connections and the relationships because, again, education has to be a part of us doing any work in the areas of prevention and intervention. And then working with our agencies like, oh my gosh. Nope, behind you. Fentanyl-free communities and working with them. We mentioned law enforcement, and I'm sorry, I'll just say this one thing. We are not just law enforcement. We're public safety, and we have to stop being pushed and just looking like we're just about law enforcement. That's not true public safety. So it's not about enforcing the law, it's about being a true partner in public safety. And thank you if I went over.
Oh, no, that's exactly what I wanted to just move into is a little bit, we've heard a lot about the problems and the challenges with the law enforcement approach, but I think all of you are implementing initiatives in your office to try and, cut at least pieces of this problem in your communities. And I want to, first turn to, the focus on fentanyl initiative that you just talked about, Sheriff Witt. First of all, let me ask you if you can talk a little bit specifically about what that entails. I know there's the education component with children and, are there other aspects of that you think are important to highlight? And then I'll turn to each of you.
It's putting a face to the stories. It's families talking about about being vulnerable. I know right now our next focus on fentanyl initiative is going to be with the Somali community. As I've spoken with people in that community, and they talk about how it's so shameful for their culture that they don't talk about it. Well, that is any dealers or any community's worst enemy is not talking about it. We have to, again, help get rid of the stigma about this drug and what it does to families. So, in making sure it's culturally that we're being culturally centered as well, because it's looked at different depending on the cultures around the country and in our community. As you know, Hennepin County, Minneapolis specifically, is a very diverse community, and the way that they look at this crisis that we're dealing with, we have to make sure that the messaging is being accepted by the people they trust from within that community. So again, partnering with not just elected officials, not just other law enforcement organizations, but the actual community leaders that have influence. Because there is still that ideal out there that this happens to everybody but me. This happens to other families except mine. And so it's putting a face on it, helping get rid of that stigma. And, in hopes when other people hear that story, they say, it's not just me. This is not just my family. It has to be a part of that collaboration.
And have you heard any, I know it's been probably fairly recently implemented, but have you heard any feedback or responses from people who've been engaged in it?
Yes, we have. And that's that part of that ongoing conversations where people are calling, they're asking questions, they're asking us to be a part of more things out there to help combat this crisis that we're seeing. And again, I think that's great because I don't want us looked at as just law enforcement. We have to be a part of the public safety conversation. It's not just about locking people up. It's about making sure that we have those continued trusting conversations, those relationships, so that we can help be a part of the solution.
And then, so let me just move back this way. CA Morales, in your community and in your office, what type of initiatives have you implemented that you have found to be, whether we can say that they have, had an impact, that you feel that they've had an impact, and why?
So Ruby, you touched on it. You know me well. We've known each other for a long time. Control, Alt, Delete program and Future Leaders Initiative. I started those in 2015, about a month after I took office, and they have grown just like I have. But the purpose of Control, Alt, Delete started off as a mechanism to really try to positively impact reentry. And it started off as seminars in the community. We still hold them, but ultimately we ended up going into the state prisons and engaging with our community members, because they still are our community members who are incarcerated, because we saw that there was a stigma. And whenever we would engage in the community, I had wives, I had mothers, I had loved ones, but I didn't have people who had been incarcerated because they did not want to be embarrassed, but also they did not want to touch a prosecutor with a 10-foot stick. So I said, we're going into prison. And so our first time in the prison, we had 300 people who were incarcerated, engaged with my team. I dragged the U.S. attorney at the time. His name was Dana Bente. I took him along with me and we talked about the things that we wanted to talk about, but then we opened up for a discussion. And that's where conversations about addiction, about fentanyl, about really what was on the minds of the people who were impacted by our actions as prosecutors, they got to have a voice. And I saw it very early on that it was important to hear what was going on from the people who were impacted by incarceration. So this was an issue that came up. It has continued to come up. The conversation has continued to be there. And then with our Future Leaders Initiative, that programming is not about a scared straight situation with young people. It's really about developing the bench for the legal profession and for the prosecution and for my office. And I've had people come through that program who are now assistant Commonwealth attorneys, but I say all of that to say these issues come up in everything that we do. That means that our community has been impacted by this, from our young ones all the way to those who have been incarcerated. And there's an opportunity to engage and there's an opportunity for trust. But more importantly, it has been an opportunity for my prosecutors to learn that these are humans. Everybody who is incarcerated has loved ones. They have families who are impacted by that incarceration, who are impacted by that addiction, who are experiencing things at home. And we have young people who are in proximity. And these young people are brilliant. They must be protected. And we have to ensure that they understand the dangers. And so all of the engagement really serves as a way to inform the community, to educate, and to see how we're treating people and how is this really impacting the job that we're doing. Are we doing it well? And the prosecutors get to see these are not case files. This is not one issue that we treat it all the same way. These people deserve for us to treat them with care every single time. And so what I've seen in practice is in the courtroom, the attorneys after having, because I engage every time we have a seminar, every time we go into prison, every time we go into school, every time we have young people in the office. And we had young people in the office, what is today, Friday? So we had them there on Tuesday. We had young people in the office on Tuesday. So we do this consistently. Every time there is an engagement point, I see my attorneys go in court and act differently. They care more. They understand the humanity. So it is a lot to talk about really quickly. But it's important that we engage at this level, not just so that the community trusts us and we can get the information out, but so that the prosecutors care differently. You would hope that everybody would see the humanity in our community members. I have done everything that I can to staff it that way. My chief deputy is a former deputy public defender. But the reality is that people go to work every day and they can start to treat this just like a meal. And so all of these engagement points have really created that opportunity for the attorneys on a daily basis, not on a global scale, but on a micro level, to do what they're supposed to do on a case-by-case basis, to care about behavioral health and not default to let's just incarcerate, and to not think in antiquated manners like, oh, we'll go and let this person get locked up so that they can dry out, and things like that that we've heard that really aren't true. Incarceration does not fix addiction. Incarcerating one person does not take fentanyl off the streets. So really taking a holistic approach is what it's about.
Excellent. Thank you. I just want to piggyback off of what my partners mentioned in regards to the words, in regards to stigma and humanity in our criminal justice system. One of the first things I did as sheriff was meet with a lot of the community organizations. And one of those groups is called Man Up. And Man Up is a support group for formerly incarcerated individuals that meets Tuesday night in Dane County. And while I was there, there's a good community leader named James who was incarcerated for 28 years. And in our discussions, he mentioned, you know, there are barriers that are in our criminal justice system that get in the way of our rehabilitation and lead us to helplessness and hopelessness. And one of those is being called an inmate. It is a barrier to who I see myself or how I see myself. It is a barrier to how the community sees me. It is the barrier to how my family sees me. So 4 months into my term as a sheriff, we stopped using the term inmate and went to resident or justice involved individual. Now, here we are 3.5 years later, and I still get death threats from people down in the South threatening to kill me for doing something that was right, trying to remove that stigma. But every email I get that's threatening, every threatening call and voicemail I get leads me to know that I made the right decision because the word had that big of a stigma. That means it was the right thing to do. Number two, to help with that rehabilitation process while they're in our custody as a full service sheriff's office, which means we have the jails, the courts, we have over 1,200 square miles of land, 40 square miles of waterways. We do it all from patrol services, including in the jail. And we are a data-driven agency. As a matter of fact, it's in our mission statement that we make data-driven decisions. And so when we looked at the overdose deaths in Dane County, we realized that 93% of the people that have died over the past few years in Dane County had connection or involvement with our justice system. 93%. Now, I looked at that as a sheriff perspective and said, okay, how can we affect? How could we have helped that 93%? And that's where we have to focus on our social services and our programming. We have in our jail a Vivitrol program, which is we fund every year a Vivitrol nurse. It includes the medication and a Vivitrol counselor. We also started 2 years ago our medication assistant treatment program, which continues the use of medications for those that are experiencing opioid use disorder. We looked at it as a community as well. If someone came in with diabetes, we wouldn't stop their insulin simply because they were incarcerated. Why are we stopping that once they become incarcerated? And then what was happening is they would get released, they would go out, they would overdose within a week and die. And then we look at ourselves and say, why is this cycle continuing? So we implemented that medication assistant treatment program. We also have a huge focus on social workers, social services, counselors, but also something that we are now expanding, and that is our reentry coordinators. We currently now have 3.5 full-time reentry coordinators in our sheriff's office because we looked at rehabilitation starts the moment someone comes in contact with our criminal justice system. With our old system, with one reentry coordinator, it took about 3 days for that person to get the general population. And then our reentry coordinator would get in contact with them. Well, again, looking at the data, looking at the numbers, 70% of those that come into our facility are released within 3 days. So we're missing out on 70% of those who we could be helping, but yet we see the recidivism continuing. So now we have in our booking area, the minute someone comes in contact with our booking area, they get booked in, they get assessed, they have medical, mental health, and we immediately start connecting them with what they need out in the community. These are the things and these are the areas to which a sheriff can control and help in that. As my fellow sheriff mentioned, it's a multi-pronged approach to this. There's accountability, there's enforcement, there's resources, but also as the leader of our jail and in control of our jails, this is a way that we can help provide individuals with what they need so that they can overcome that helplessness and hopelessness, which helps with that addiction and focuses, like the doctor said, on the brain psychology and not the morality or the physical psychology.
And I just add something to what he said. So we also have the MAT program, Medical Assistant Treatment Program. There's only 13% of jails in the United States that actually have it, which is a travesty all in itself. It's expensive. It's hard work to do. But the way it needs to be looked at is the jail is an extension of the community. Healthier communities mean healthier jails mean healthier communities. We are a pretrial facility. I could tell you on average, we're treating people going through withdrawals, approximately 30 to 40 people per day. And so making sure that you have programs like the MAT program and then the MAUD, medication opioid use disorder program, is imperative. But there's something else in Minnesota. I'm not sure if you have it in Wisconsin, but something that we've been pushing here, and hopefully this happens in the legislature here in 2025, is the 1115 waiver. Because in Minnesota, when you're incarcerated, you're cut off from medical insurance. We know that continuity of care is very important when you think about people who need medical or substance treatment. But if you don't have insurance, that causes a rivet in them being able to have a chance for a healthier, more successful life. You know, what we're seeing in Hennepin County is trying to get people in a treatment program. Well, now they have to reapply for insurance and things like that. That's something that it affects, again, the ability for people to get better. And, you know, there's a focus on the number of people who fail, right? Who are cycling through or fall off the wagon, if you will. But that's not everyone. And it shouldn't be because the resources are not there. That should not be the reason. You never know when something's going to stick when people are dealing with challenges, chemical health challenges, but we do know that they have 0% chance if the resources are not available to them. So if you hear about the 1115 waiver, that is something that we're trying to get here in Minnesota. I'm not sure if you have it in Wisconsin, but I feel really good about that being something that that we will have, because it's also going to affect our prison systems as well.
Yeah, I just want to amplify what the 1115 waiver is for those who may not be aware. So basically, Medicaid and Medicare services are not, there's an exclusion for people who are incarcerated. And CMS, the Centers for Medicaid and Medicare, whatever it stands for, that operates those systems, has implemented a process over the last few years where states can apply for waivers. And states can apply for those waivers. They have to like set up a certain, they have certain requirements they have to like fill out, and CMS will approve the waiver. And then what the states can do is figure out how to provide access to those services within a certain amount of time before they're released. So you can start getting coverage and applying for treatment and all those things within that. And my recollection is I think maybe about 11 states have gotten it approved so far, and about, a number more are in the process of approval, but it's definitely something that a lot of people who are thinking about corrections and treatment and kind of figuring out how to improve reentry are really trying to kind of put a push on over the next few years, because it could be really important to help to provide treatment, access to treatment, so somebody who's leaving prison doesn't have to leave prison and figure out all the other ways to reenter society, and then also figure out how to reapply for, how to apply for Medicare and all those other things. So it's a really important, and I think Minnesota is awaiting approval. So I want to thank you so much for all of that, that overview. I want to talk a little bit, first of all, about how you partner and whether, let me put it this way, whether you partner, how you partner, and what the challenges are to partnering with public health and community treatment. And then the other area that I want to get to before we get to questions is data and how you evaluate whether you're being successful, and frankly, how you measure success. So let me just start with you, Sheriff Witt, about your partnerships and challenges to partnering with other providers, health providers in particular.
Well, let's start with challenges. Again, it goes back to when I say that we should not just be looked at as law enforcement, we have to be looked at as a public safety profession. And so that means changing those lenses that some of our partners do have. We are here to help. And, I understand that, yeah, we should not be put in some of the situations that we are when it comes to dealing with social issues. But the fact of the matter is we are. So to have those relationships, trusting relationships, knowing that we may have different objectives within our professions, but we all have the same goal at the end. So making sure that when we're talking about collaborating, it's true collaboration, and knowing that means give and take, knowing that you do have the same end goal. We do partner well with the Hennepin County Sheriff's Office, with our community members, our partnerships. We've also added a new position to the Sheriff's Office, our opioid coordinator, JR, wave over there, JR, who's absolutely fabulous, who comes with a great background in regards to substance use disorder and stats. And then when we talk about the data, I think it's also important to say, what are your strengths and what are your weaknesses? So making sure you have the right people in place that are going to get you that true information, and that can follow the data, and that's why we're very grateful to have JR there, because he's schooling me every day on some things, and being able to make sure that it's a continuous reach. With our social workers, our prosecutors, our public defenders, our community. And again, it's okay to have differences of opinion. We should be listening not to just the people we want to hear from, but people that have differences of opinion, because when you're talking about providing services for a county such as Hennepin, 1.3 million people, nearly 1.3 million people, you're going to need different people at the table with different lenses to come up with something that's going to be more holistically better for the community that we promise to serve. And so we don't really have barriers, because I shouldn't say we don't have barriers. As far as collaborations, because we've been open to that, doing things different. And again, not just saying that we are a law enforcement entity, but we are a public safety entity. I believe that that has helped us forge some of those relationships. In regards to other law enforcement agencies, because we've been out there and talking about it on every different level. Again, people have been asking us to be at the table, to be at these meetings. We were just in our Little Earth community about a month ago, because they felt like they weren't being heard. And we heard them loud and clear. And we acted on, again, a culturally specific issue they were having in that community. And frankly, they were quite surprised that there was a response. It's not just about words, it's about actions, and it's about really learning your community needs. And that means you actually have to be there. You have to be involved. You got to have conversations. And again, not with just people that say or think the same way you do, but people that are going to challenge you. I think we're doing good work. Of course, there's more work to do. But, like here, with me, even in my uniform, and I have been asked at certain things not to wear my uniform. And I think that's the wrong answer. If I'm truly trying to show what public safety is, this is my professional uniform. And I think people need to see that the faces with these uniforms, especially when we are truly trying to be public safety providers, not just law enforcement. It is our job to make sure that we are forging that conversation and showing people that, no, we understand now. It's not about just enforcing the law. I want to be a part of the solution. And again, impacted in many ways, professionally, personally, and I'm just going to continue to do that. And it's not something where there's a goal. It's going to be a continuous effort, and making sure that the people in the agency are also following suit with that idea. As a law enforcement leader, recognizing that our profession has not always done great in that area. And so, it's an everyday battle, but we're not going to fail because we're not trying. We're going to continue to try and take the lumps as they come.
So when we think about, particularly about fentanyl, how would any of you talk about what you would consider to be success as you are evaluating approaches that you are thinking about?
So I'll try to weave that into the question, because I do want to speak on the question you just asked. So our major partner that we work with as prosecutors is the court. There are drug court treatment programs that we have. That is a major factor. It's now housed in the Department of Behavioral Healthcare Services. And that has seen major success in our community for years and years. When I was an assistant, I was the liaison. I would go to the drug court treatment program every week when they would show up in court. But those participants would engage every day. They would see their counselors, they would go to group, they would do these things every day. And so there was a big deal about this program because the success rate was so excellent. And when COVID happened, it destabilized that program. And so I took my full staff over, attorneys, victim witness, administrative professionals, to meet with our drug court treatment professionals to try to rejuvenate this program and get participants in place and to relax the requirements. And one of the things that is a barrier is that there is a requirement that there is no incarceration. So regardless of what the guidelines say, we have to agree that there is a period of probation. My office and my attorneys don't have a problem with that. Where we see a challenge is community partners like law enforcement will get upset and they feel like this is contributing to the violence in our community. So for example, I'm gonna be very honest, there was literally this week a forum where a law enforcement partner was asked in a community about what's happening with people who are being arrested. And this law enforcement partner said, we're arresting people and they're letting them back out. Now, I don't know who they is. I don't know if it's the court. I don't know if it's my office, but there was a specific question about a case where something was stolen. And as many of us in law enforcement know, drug addiction issues will manifest in a variety of ways, not just possession charges, but also larceny related offenses. And there was something that was stolen and this person apparently received 2 years and 2 years suspended. And that is very likely what their guidelines called for. But in this community meeting, the ego was such that I just can't take accountability for the fact that we did our job and the court system played its part. But you have to say, well, we did our job and we locked them up and they let them out. Well, maybe letting them out was the right approach. And so for me, these challenges manifest and I hold true to this notion that I have to live with myself at the end of all of this. And if this is something that my community no longer wants, they want everybody locked up, you have to get somebody else. Because I don't worry about whether or not I will be unelected because I'm doing the right thing. And so we constantly engage with the court. I have to deal with my attorneys about ego too. That's another challenge because we show up ready to do the right thing. We show up ready to try to get somebody in a drug court treatment program or on the mental health docket or whatever services they need. And some defense attorneys will see that as an opportunity to try to get it dismissed altogether with no treatment, with nothing to actually assist this person or actually help our community stay on the right track. Then my attorneys get mad and say, well, I'm not soft. You're not about to run all over me because I'm showing up trying to do the right thing. Now let's go to war. So you have all these different factors. And ultimately, it's about the needs of this individual who's showing up before us in need of services. And what does our community need? And ultimately, our community needs us just to get it right at every turn. So those are the challenges. And then on the success side, I do see it as a success. I can't speak enough about how important it is to look at the individual outcomes. And so I do know that when I had that meeting with my attorneys and my full staff and the drug court treatment program in the Department of Behavioral Healthcare Services, where we went to them, when my attorneys came back and they started working to implement the things that we talked about, that is a success. Because we cannot have the same thing, happening that has happened for all these years and we expect a different outcome. The system is really trying to protect itself. The status quo wants to keep the status quo. And it is not a specific look. There are people who look like me, who come from my community, graduated from the same high school. They're a lot older than I am. But they want to protect the status quo. They have made comments to my attorneys about, are you a prosecutor or are you on the defense side? I'm confused. They have said very troubling things. I've heard a judge come back, and I looked at the transcript because my attorneys told me, but I've heard a judge call somebody a junkie in open court. So there are very antiquated thought processes that are working to stand in the way of progress. So when I have attorneys who are willing to push back, knowing that the judges are going to potentially embarrass them in court, accuse them of not doing their job, and they go in and they fight it anyway, I'm proud of that, and I consider that a success.
So, Sheriff Barrett, I want to ask you that too. And I think one of the themes that's coming through is, kind of the question about educating both counterparts within law, like the law enforcement community, courts, et cetera, and also the public about the idea that jails are not necessarily going to be a good aren't necessarily the right solution for every individual, that incarceration itself is not. And I want to get to, at some point, talking about getting at dealers and, kind of how communities, local communities can do that more. But can you talk a little bit about what you have seen as success in terms of collaboration and how you measure success?
Yeah, so I would say from the question in regards to healthcare, we work well with our partners locally, but I think the key is having a full-time medical staff in a jail facility. And with Wisconsin, there are 72 sheriff's offices, and not many of them have full-time medical staff. So being able to establish that relationship while they're in contact with the criminal justice system is important. A barrier is keeping in contact with them once they're released. How do we follow up with them post-release? How do we make sure they're getting to these appointments post-release? And that was just a very short answer in regards to how we work with the healthcare system and kind of some of the barriers. In regards to some of the successes that we've had, we've seen over the past several years a reduction in our drug overdoses. In 2021, we had 166 overdose deaths. In 2022, we had 147. And then in 2023, we had around 140. So it shows that what we're doing is working, but it can be better. One death is one too many, but we'll continue to do what we can to ensure that these numbers and what we're doing is saving lives. I think another barrier that we have too is as a profession, I feel a lot of times we're given the responsibility to be analysts, right? To determine what success is. And that's something that I challenge my staff with. How do we determine success for every program and social service that we provide? What does that success look like? We're really good at collecting data. I got a lot of data, but how do we turn that data into intelligence to help us make informed decisions moving forward? That's where I see as a barrier for us in our sheriff's office. Because I can send you data, but I don't know how we turn that into intelligence. And so that is just one of the barriers that I see with the successes. But I believe with the lives and the reductions that we're seeing over the past several years is definitely a success, but we still can do better.
Okay, so I want to open up for questions, but one last question to the panel is, given the seemingly endless supply of fentanyl into these all of our communities, have your offices been able to impact the flow into it and to prosecute or investigate or stop it at the dealer and distribution level? If so, what have you found to be effective? And if not, what are the challenges? Maybe Sheriff Witt, you want to start?
Well, it actually does go to success. One stat that I used in talking to the public, if you looked at the first 6 months of this year, our drug task force team, our VOTIV team, which stands for Violent Offender Task Force, had confiscated enough fentanyl in Hennepin County that could potentially kill every person in Hennepin County. So when we talk about the dealers and the people that that are helping facilitate those drugs getting into our community. And again, thinking about our young people, this is not an adult problem. We have children dying. We have to make sure that we have that enforcement piece of it, that accountability piece. Now, what do you do with that when you have it? One of the things that I'm proud about the Hennepin County Jail is we have so many different types of programs there. My belief is that jail time shouldn't be dead time. So what resources are you bringing into the facility? That has to be a part of it. And I've taken bricks for that, where people are like, oh, they get more services than the victims. No, again, it's using that lens that your jails are a part of your community. It is an extension. So, I have to find some solace in saying that when people are in our facility, it is not my expectation that I'm going to save all of them. But if I can change the course of one person's life, that has to mean something. When we continue to be out there looking for people that are harming our communities, that are killing our communities, I have to support those efforts. Because victims, it's hard talking to the people who are victimized by what these drugs are doing. And hey, by the way, it's not uncommon for us to find guns, illegally possessed guns, ghost guns, guns with switches. When we find drugs, there's oftentimes guns. And so when you look at the whole approach of it's not just the drug, it's what the other things that are coming with it, the violence, victimizing our communities. You have to have men and women who are out there willing to fight this fight. And then kind of going back to what you said, so once they're in our system, and something that I have to say to the men and women that work at our agency all the time, because sometimes they do feel like, what's the point? Have heard that before too. They're just letting people go. Well, you know what? The other reason we're failing as a system is because there's too much finger pointing. We have to continue to have those conversations. We cannot continue to group or stereotype, like I said, every case. But if you see something, you see somebody has been charged, or not even yet charged, or even arrested 10, 11, 12 times for incidences that are harming the community. Yeah, something needs to be done. But then you know what? That goes on the jails and the prisons too. We need to make sure that those resources are there to, sorry, excuse me, to provide people with with at least a glimpse of hope that they don't have to continue that type of lifestyle. Because unfortunately, we do have people out there that think that that's all they can do. I will acknowledge that. There's also people that are out there just for greed. But, when we see people out here in these streets and our young people are watching again, watching them glamorize this lifestyle, there has to be that prevention piece. And again, this means stop pointing the fingers. Let's work together. Let's not treat every case as the same, because it's not. But also make sure that the resources are going to the places such as jails and prisons to help with some of these things, because people will eventually go back to their communities. And we know that there are people who are not happy that we provide services in the jails. Again, I know I've taken some pretty harsh words for it, but they're people. And the worst thing we can do is give up on people, even those that are incarcerated. And so with that being said, success, that's a big word when we're talking about it, because, when you're saying what's successful, well, then what's unsuccessful? What does it mean to be unsuccessful? So if you have somebody who made their way out and made a better life for themselves, that did actually get something out of it, we have to do a better job of showing people that came from that same walk of life that it can be done. Because without hope, we have nothing. That's just the bottom line. That continuity of care. Sheriff, I'm going to take your ideal about trying to make sure I can get me some coordinators, because going back to barriers, that is it. Making sure that there's that sweet handoff. And again, you don't hear sweet in law enforcement in the same sentence, but it has to be in the same sentence. It's got to be a sweet handoff.
Absolutely.
People fall through the cracks. They don't always get to point B because of all of the other barriers that are in between them getting from point A to point B.
Thank you. And if I want to open it up for questions. Is there a mic? Okay. Is there a question? I think just wait for somebody to come with the mic right there.
Yeah, hello. I'm Dominic Terry. I'm an assistant Hennepin County attorney, and I prosecute drug crimes here. And one of the questions that I always come to think about whenever thinking about fentanyl deaths is the form of use and how that contributes to this, decrease in maybe in fentanyl overdose deaths. And here it seems to be that there's the form of use is from oral consumption to smoking, and I'm wondering if you all are experiencing that same scenario, and whether or not that's also contributing to the decrease.
Yeah.
Well, let's get rid of the idea from smoking, because we know that fentanyl, if it's at a certain temperature, does not have the same effect. But something, and JR, if I say this wrong, I want you to correct me on it. But specifically for Hennepin County right now, what we're seeing right now is an increase of overdose deaths that are related to methamphetamine and fentanyl. There's different theories about why we're seeing those two mixed together. Is it people, is it part of the product? Is it people using one to go up, the other to bring it down? We don't know, but we know that 30 to 50% increase now being linked with between fentanyl and methamphetamine is something that is, I'm gonna just say specific to here to Hennepin County that we're seeing. But then also what we haven't talked about is the social media aspect, where people are thinking that they're buying something else, say Adderall, and it's laced with fentanyl, but it's not smoking it. It's in the pills. It's oftentimes in a pill form, which is why we go hard off of pill pressers. But not smoking. And I don't know if there's anything, if that answered your question, but that's specific to Hennepin County at least.
So I wonder, I mean, it sort of raises the question and your answer also about just the very quickly changing, evolving nature of, maybe that's happened before when I was a federal prosecutor back in, the 2000s. It was the tail end of the crack epidemic in New York. And, we can talk a little bit about how we don't recreate the same problems that we did with that. But it seemed like it wasn't, changing all the time with social media and all those things. How do you find that? Like, and are there ways that you as in law enforcement now are thinking about how do you just keep up to date? And, how do you keep on track with, particularly the science changing and all of that?
Yeah. It's an academic approach. I mean, and I'm an adjunct law professor too at William and Mary, where I went to law school in Virginia. It's really on us to stay educated and informed and to continue to bring that to our staff. But the other thing is just paying attention to the trends. I am on social media, not for that purpose, but I see things. And I have 4 children too, and my youngest ones are twins. They're 11. They're not on social media, but my 18-year-old and my 20-year-old, they're both in college, and I'm watching everything. And they're musicians. They went and performed in Chicago at an alternative concert. And it was amazing, but I saw so much stuff going on around them. I made my husband go. But I was just like, what is going on? And one of the artists who's a major artist, he lives on Skid Row in Los Angeles. And I was just having a conversation with my son about, I just wanted to see what he was going to say. I was like, why is he on Skid Row? And is he on drugs? And he's like, oh no, he's just using alcohol. So there's a naivety. So I'm watching things for several different reasons, but there's a lot of stuff that is mixed up into what we have going on with fentanyl. And it's not just one person selling one thing. The drug dealers are selling multiple things. They're lacing things. There's this component. Also, I don't know what you all are seeing, but in my community, there's a fraud component. They call it scamming, but scamming is tied up into fentanyl and to violent crime. It's all mixed up together. So number one, staying up on the science of it and what's going on, but just the trends and paying attention, being aware is one thing that I've done to try to stay on top of what we have to do in order to approach it.
Yeah, I would agree too. It's funny. Social media is probably the biggest. I've learned more just from being aware of our community and where things are through social media. And here's an example of how powerful social media is. Towards the middle of this year, we had a graduation party on a rooftop of a building in downtown Madison, and there was a shooting on the rooftop. And my daughters knew the type of gun and that they used a switch before we did. And I'm the daggone sheriff. And I said, girls, how did you know that? They said, oh, so-and-so shared it on TikTok and said it must have been a Glock switch. I mean, and that was within minutes of the shooting happening. So social media is big. I also encourage, and what we do and the approach we take at our sheriff's office is ensuring that our training takes place out of the state. A lot of agencies like to focus and get in-state training, local training, but in order for us to grow our networks, in order for us to grow and understand what's going on in the surrounding states, we have to go to different areas. We have to go to the National Academy to get connections in New York and California and Florida and Virginia. And that's where we're starting to see the trends and connecting those dots as we see things moving up towards our way. Xylazine, we were able to get ahead of that very quickly based off of our national connections through trainings and networking, and we were able to kind of start preparing for that before it made its way up to Wisconsin.
Like Wisconsin as well as Minnesota, we're both part of HIDA, high intensity drug trafficking. And that's so important because it's in the partnerships with our federal partners. As we know, Minnesota is a hub for trafficking. not just drug trafficking, human trafficking, but making sure that we have those partnerships, those federal partnerships that can help cross those state border lines to help us continue to try to keep our communities safe.
Are there other questions?
Yeah.
Is there a mic? Oh,
Yeah.
there's a mic.
Hi, my name's Steve. I'm a second year student here. And I just want to share an experience and kind of maybe get your perspective on what a better outcome would be. So last year I did a ride along with Metro Nashville, and we had a disturbance at a residence, you know, a verbal altercation. Woman had obviously just used, which led to the altercation, and the other person would not let him back into the house. We even had a social worker respond, and the woman just didn't, you know, she didn't have anywhere to go. And the solution was drive her a mile down the road and drop her off in the McDonald's parking lot and tell her not to come back. So what do deputies and officers need as far as resources? Because I know specifically in Minneapolis, this is probably what leads to a lot of the issues on the light rail and public transit. What's going to be the solution with those types of situations?
I can tell you, prior to being the sheriff, I was the major over our jail and courts. Let me just say that Hennepin County Jail is the largest, most populated jail in Minnesota. One of the things that I noticed is we had a large amount of people being held at our facility on misdemeanors, and then starting to look into, okay, why is that? You know, and it was not putting transit out there, but it was transit, you know, with people on the trains and using and things like that. And I actually had some conversations with the then chief and the chief of our parks police. I'm like, we can't continue to bring people in on misdemeanors. They need help. They need help. Working with our partners, behavioral and human health with Hennepin County, the hours for one of our resources that we have in our community called 1800 Chicago, where they deal with homelessness, substance abuse, and other types of entities. So again, I was the major then. One of the things we try to push out with our Hennepin chiefs is don't bring people here to the jail for these low-level offenses. They don't have to be there. Take them to 1800 Chicago. That's why the hours were expanded. And we had a lot of resistance from a lot of agencies, you know, well, it's not on the bus line, it's out of our way. And then there's the idea that the accountability piece. Well, you know, as I'm transitioning into sheriff, one of the things I'm happy to say is, like, if you go back to 2019 and you look at now, our people who are in our facility for misdemeanors is never more than 2-3%. But pushing this profession into making sure people have resources or getting the resources that they need, especially for low-level offenses, was imperative. We did have a pilot program where we actually brought a social worker into our intake area. And as people were coming into the facility, that social worker would do his or her magic to decide to say, is there a more appropriate place for this person to be other than jail? But we still made sure, like, we created a expedited booking process, if you will. And but the idea was to get them the help they need, and then they can come to court after that instead of the other way around. So I see exactly what you're saying, but we do need more resources out there. We have to say that too, right? You know, as we're looking at the number of people with mental health and chemical health issues in our jails, and there's no place for them to go. That is a real thing. You know, I know that I have people that have been deemed incompetent and need to be in a hospital by judge's order. And yet I'm being forced to keep them there until those beds open. Again, another thing that law enforcement get pushed into. We're not asking for that. But we need to say, okay, where are the resources? Officers, deputies on the street, we need to know exactly where we can take people instead of trying to be social workers triaging those things while we're out there dealing with the incident at hand. So I hope that answered your question.
I think it's fair to say that that's a persistent problem for, law enforcement across the country in terms of, I think, the question of you're responsible for responding. And, there are a lot of people in the community who probably rightfully are saying, we don't want them in jail, but where can you take them? And I think that's incumbent on communities to think about how can we create the resources to do that. There's a sheriff in Middlesex County, Massachusetts, Sheriff Katusian, whom I think all the sheriffs on this panel know, who actually led an effort in his county to create a resource center. So it's not a pre-arrest or post-arrest diversion program. It is basically a resource center that is open 24 hours, 24/7 and staffed with with resources like mental health, substance issues, et cetera. It took about a decade to get that done in Massachusetts and funded. And I think it's about to get, there are challenges about where do you locate it? How do you make it accessible? And also, not necessarily just locate that in a part of the community that gets all of the, there's always like community concerns about those kind of things. So that kind of partnership in education and funding is a challenge, but it can be done. And there are examples of people doing it.
Yeah, I would just add to what our communities need is, I believe it's in Miami, but there needs to be a one-stop shop facility. Because we're going from ERs to mental health facilities to homeless shelters. What we're trying to build in Dane County is a one place where law enforcement can assist someone so that they come into one door and there is no wrong door. If they need medical attention, they go down one hallway. If they need addiction services, they go down another hallway. If they just need a shower, a nap, and a sandwich, they go down another hallway. That's what we need. But we're constantly using our jails as dumping grounds for the issues that society can't solve. And that's the wrong approach to it. So if we put our efforts and our resources into that one-stop shop place, we can continue to get people the services that they need and keep our peace officers or our officers, deputies out on the street, keeping people safe and not playing multiple roles that we are not typically prepared or trained to do.
So I think we may have time for one more question. Then I want to ask the panel wrap-up questions.
She's had her hand up in the middle for a while.
Hi, Michelle Hine from the Fentanyl Free Communities Foundation. This question is for probably Sheriff Witt, and I'm sure that you others can answer as well, and maybe JR. But with all the grassroots organizations that are on the ground now, especially in Hennepin County, literally out on the streets, all hours of the night, picking people up, helping them out, and it's all born out of our own tragedies or their recovery efforts, and they are trying to get other people to recovery. Where is the data? Where can they call, or because I don't believe they can right now, where can they call to share data when they save a life with Narcan or when they take somebody somewhere, or that data is getting missed? So I believe our data mainly comes from emergency rooms, correct me if I'm wrong, but there's people out there doing the work, and where does that information go?
Oh, thank you, Michelle. And then JR, if you want to piggyback after me. So one of the other initiatives we have is we actually go into the community and we teach people how to use Narcan. I know that there's like vending machines, there's all those things, but I think there's a real important component to making sure you have a back and forth conversation with people as they have questions. Like, for example, I know I was told by one of our local police chiefs, if you administered 2 doses of Narcan, you can kill a person. Well, that's absolutely not true. So there's those type of things that are out there. One of the other things that pushed that initiative to doing that is that, as I'm meeting with community members, our neighborhood block people and things like that, and talking about how often it is that they see somebody who's actively overdosing and didn't know what to do. Again, going back to that mother who didn't even know what it was. But we don't do a good job of collecting that information from the public. I don't know if public health does it, but I don't think there's a place to go. I know earlier hearing about we can't Narcan our way out of this, and that's absolutely true. But the premise is that we do know that some people's wake-up call has come after being used. After knowing that they nearly died. We also know that there's a greater success when people choose to get help versus being forced to get help. But to go back to your question, and JR, if you know something different, I don't know that anybody is collecting the number of Narcan saves outside of our organizations?
I think, I don't want to speak for Hennepin County Public Health, of course, but I think their main sources of data are emergency room visits, specifically for non-fatal overdoses, and then autopsy reports. And that's kind of where the main sources of data are. I don't believe there is a kind of a central hub for processing on referrals to treatment, Suboxone induction, all these different things. So no, I agree.
Can I make a suggestion? I think it's beautiful when we identify a gap. There's often people who are in media who are interested in keeping those stats. I know police brutality is something that I've participated with, and the sources who were keeping track of that data nationwide were journalists. So if you are tracking your own information, and I have a public information officer, I'm all the way in Virginia. But I know she would be willing to see if there are any journalists on a national level who are keeping that information, and that might be a source for you to constantly give them that information. I guarantee you somebody is tracking it.
I think one of the challenges that you've highlighted is that, it's hard to really figure out who tracks like the success of, that it wasn't an autopsy, it wasn't an overdose, it was actually a success, which, often media and others don't cover, and we don't figure out how to collect those. So it seems like something that community and public health organizations should be thinking about.
And then you have to think about the culture specific part. Like, for instance, in the Somali community, you're not going to have the accurate numbers based off of what they believe about autopsies and things like that. They see it as shameful. And that's part of the conversation, again, that we're having with that specific community, because they are acknowledging that people don't know how bad it is within their culture right now, because again, they won't talk about it, and they don't condone the medical examiner doing any additional work on their loved ones.
So let me wrap up this panel with just one last question for each of the panelists, which is one challenge that you want to highlight for law enforcement in addressing this problem.
I would say, number one, we need resources outside of our criminal justice system. We have to address lack of housing, lack of transportation, lack of entrepreneurship, affordable mental health and medical services, childcare. And those are the things that we have to support. That's really getting, like Desmond Tutu mentioned, upstream, right? By the time they get to the criminal justice system, that's downstream, and we're pulling them out. What are the things? What are the root causes of crime? And how do we get to those before they get involved, before they're using, before they're addicted? That's the key. And it starts with those resources. Helplessness, hopelessness, solve those, and that'll really get us in the right direction.
Collaboration and manpower. And so I think, we know what is happening. The reactive approach is a failure. And if we can get people to agree to take a holistic approach and a proactive approach, then we have to have the manpower. If we have the will, we then need the actors. And so for me, yes, resources is always going to be a part of the issue, but we need the people, because even if we don't have resources, if we have prosecutors and law enforcement who are willing to be collaborative and they want to get it right, we just need enough. And they're just as, I know in my office, we've had shortages, and our law enforcement partners, departments, we've had shortages. So people really, deepening that bench and engaging at an earlier time in high school, in college, at the law school level, really trying to get people to understand that they can be a part of the solution has been really important in trying to approach that challenge.
I'm actually going to piggyback off of both of you. Again, going back to what I said, we're not just law enforcement, we are public safety. And I know for me, I'll speak for me in the space that I'm in. I have a true passion to make sure that we're working with our partners. We're losing people because people have the thought that our job starts here and it ends here. We need overlap. We need true multidisciplinary teams to come to the table. And some of those barriers that are taking place for those MDTs are the facts that the lack of sharing information. How can you truly be preventative if you don't have the information? And so one of the biggest barriers is the lack that we can't share certain things with each other, even again, though we have the same common goal. And we really need to look at that, but that also means trust within our various agencies, though. You cannot be preventative if you don't have the information. And that goes from boots on the ground, from law enforcement, going through our criminal justice system to our social service systems. We have to be able to share the information. Unless somebody has a crystal ball out there that just tells them which path to take, we got to be able to have a pathway to share the information so we can really be preventative.
Thank you so much. Thank you all for your attention and your great questions. And thank you to Professor Osler and Mason and Law School for organizing this really important panel and conversation all day. And special thanks to our panelists. And looking forward to the rest.
At this time, we'll take that short break that I promised before this panel begin, and then we'll come back right around 11 o'clock. So please feel free. Water, coffee in the back, restrooms back there, and then a water fountain over here to fill your water bottles as well. Thank you.
Our next panel is a law professors panel, and I would like to introduce our two panelists for it, Professor Osler and Dr. Gillespie. Professor Osler is the Robert and Marion Short Professor of Law right here at the University of St. Thomas. He was also chosen as Professor of the Year in 2016, 2019, and 2022. He teaches criminal law, and he is fantastic at it since I had his class. Professor Osler has written extensively on clemency, sentencing, narcotics policy, and has been published in many notable publications. Professor Osler is a former prosecutor and successfully argued the case of Spears v. United States in the United States Supreme Court, where the court ruled that judges could categorically reject the 100-to-1 ratio between crack and powder cocaine in federal sentencing guidelines. Professor Osler is a graduate of the College of William and Mary and of Yale Law School. Now, Professor Dr. Kelly Gillespie is a professor and director of the Center for Health Law Studies at St. Louis University. Dr. Gillespie is an expert in health law and bioethics, where her experience in the nursing field guides her scholarship. Recently, Dr. Gillespie's work has focused on subjugating effects of harm-inducing laws on people with substance use disorders, chronic pain, and other intersecting, stigmatized, and minority identities. Dr. Gillespie was recently appointed to the National Institute on Drug Abuse Partner Consultation Board for the Long-Term Opioid Therapy Research Network and has co-authored 2 amici briefs before the United States Supreme Court on behalf of the United States Professors of Health Law and Policy in the case of Ruan v. United States. Both Professor Osler and Professor Gillespie will have roughly 50 minutes to discuss their work in this area and explore the dimensions of the fentanyl crisis. Following their remarks, we'll bring back for questions and answers, where feel free to ask questions and we'll have the opportunity to ask them about it. Again, please feel free to jot down questions as they're speaking. You should have note cards and pens in front of you as well. Now, first, Professor Gillespie, would you be okay starting?
All right, good. Still morning. Yes, good morning. I am thankful to be here. I appreciate the invitation from St. Thomas, and it's an honor to participate. Okay, I want to start with this. I don't expect you to read the content of this entire slide, but I'm happy to share my slides with anybody. Language matters, not because I want to be quote unquote politically correct, but because we've got empirical research that shows that the language around substance use disorder can either help or harm people. For example, in vignette studies, just changing the description of the person involved from a drug abuser to a person with a substance use disorder is associated with prosecutors endorsing less punishment and healthcare providers endorsing more treatment, right? So it shapes practice. So this slide has a lot of non-stigmatizing alternatives. Okay. We know we have a problem. This has been covered. And we have continuing mortality from not just fentanyl, but from what has always been a polysubstance use problem involving including opioids. And more recently, the introduction of xylazine has made things even more complicated. And I include the information on xylazine because it's implicated in a lot of fentanyl-related morbidity and mortality. Okay. So besides untimely deaths, we've got a lot of other issues. Morbidity meaning other health effects. We've got non-fatal drug poisonings, infectious diseases, respiratory disease, co-occurring mental health conditions, accidents, criminal legal system involvement, family legal regulation system involvement, and on and on and on, right? It touches every aspect of a person's life. So my approach, I have a background in nursing and ethics. So when I look at these issues, I'm looking at that space where drug policy and the healthcare system and the provision of healthcare intersects, and how in particular laws and policies shape practices to induce harm, and how we can go forward, create different approaches to reduce harm. But to do this, we have to really be mindful and engage in questioning our presumptions and the simple narratives that too often accompany stories of drug-related harms. History is replete with examples, and in particularly this area, we all live and were raised in a culture deeply entrenched in drug-related moralism and punitive treatment, right? A system literally based on stigmatizing and othering people. So we have a lot to unlearn. We have to be conscious to look at what is the situation on the ground. We have to acknowledge and reckon with the law in shaping these harms. We've got to look at data, because this is an area where like our gut or intuition is usually wrong, because we have so much ingrained bias. And we have to think about what is the end goal of policy. This seems like, duh, thanks, Gillespie, like this is really helpful, but you'd be surprised. In the wake of the increasing awareness of opioid and polysubstance use fatalities, sometimes called the prescription opioid crisis, but that's a misnomer. We doubled down on policy and research that didn't ask, are we looking at the overall harms to people? Instead, it asked, are we looking at X fewer prescribed opioids, and who cares what happens to the patient? And that is what a lot of the policies did, which I'm going to talk about. And so we have to work to look at the whole picture from all the angles and see, try to talk to people who see things very differently in order to undo some of that harm. Well, in this area in the healthcare system, a lot of that harm is wrought by history. For over a decade, starting in earnest in 1914, federal law conspired to make sure that the medical field did not and would not see would not see the treatment of people who had substance use disorders as their problem, right? We aggressively, and there's all kinds of historical documentation, and I'm happy to share more via email or what have you, all kinds of historical documentation that we work actively to push people out of medical systems of care and into a place where they could be erased and invisible to us, right? Including into the criminal system. So there's a Harrison Narcotic Control Act or a Tax Act that was passed in 1914 that, as it was applied and interpreted by the Supreme Court, made clear that the treatment, I mean, they said explicitly, the treatment by medical providers of people who have substance use disorders, they didn't use that language at the time, but is not the legitimate practice of medicine, right? And they eagerly charged, prosecuted, and convicted many physicians to the point where they drove them completely out of the business of addiction care. That legacy continued later into the century as we discovered the promise of some medications for opioid use disorder, first with methadone and then with Suboxone. We continued this separation of care, all the rest of medical care, from these little carve-outs that we uniquely regulated at such an intense level that almost no physician or other healthcare provider engaged in the practice, right? And we literally segregated people and patients who needed this care from regular doctors' offices, okay? And so it's no surprise that we're just now trying to claw our way back. And I think it is slowly changing and things are getting better, but it's no surprise that physicians and other healthcare providers continue to avoid patients. It's particularly sad because we know what works, right? Medication for opioid use disorder is one of the most broadly effective treatments in medicine, full stop, right? I don't mean broadly effective for opioid use disorder. I mean broadly effective for a medical condition. And it saves lives. And yet, the vast majority of people who could benefit continue to this day to be denied access to that care. And I include this quote, this is from the CDC publication here, but we can't forget the most important outcome for any effort to treat OUD, opioid use disorder, is survival, right? We want people to survive to another day because they are people, they are humans, and they have inherent dignity, and they should not be treated as less than. And yet, as I mentioned, continuing literature reflects that physicians and other healthcare providers are reluctant to provide care for addiction, and they avoid those patients. And there's also literature replete that shows now they avoid patients who are perceived to have those conditions, such as patients with chronic pain, whether or not they use opioids. So let's talk about what happened after 2013. So this is the curve from 99 to 2021. That sharp uptick is not prescription opioids. The sort of basic red one is prescription opioids. So that's been pretty flat for a while. And in fact, the rate of opioid prescriptions is its lowest rate since the early 90s. And yet overdose deaths continue. So it wasn't just a prescription opioid problem. It never was. I actually dug through that data that the CDC used to begin their campaigns, and they knew since at least 2011-12 that most of these deaths, close to 75%, involved polysubstances such as benzodiazepine and alcohol and opioids. But we didn't get any warnings about co-prescribing for several years after that. Okay. And so it's an example of what often happens in drug policy is that we saw a problem, which was alarming, of course, of untimely deaths, but we approached it with tunnel vision and we clung to thin narratives. And we ignored the fact, and we knew, right, that what we were going to do was create a push down pop-up problem, meaning you can go after really restricting the supply of prescription opioids, that's not going to fix the drug involved mortality, morbidity problems, right? It might decrease the number associated with prescription opioids, right? But you can never address drug problems by looking at one substance or one source, because it's just not how it works. And we've known this for decades, right? But we keep doing it because we have an action bias. And so, of course, and I know you heard earlier, right? There's plenty of blame to go around, right? Plenty of people, pharmaceutical companies, physicians, the lack of social supports and social opportunities, our individualistic based ethos in the United States, on and on and on, all contributed, right? And by the way, with regard to prescribing, that was less than the standard of care, all the way to criminal, we had and have myriad remedies, myriad, state and federal, civil, administrative, federal, civil and criminal, and even quasi-legal removal from hospital medical staffs, from professional organizations. We have lots of ways to punish inappropriate prescribing. We have lots of ways to make sure practitioners never prescribe those again, or maybe don't even practice medicine again, right? But instead of working on enforcing and examining practices based on existing laws, we created a bunch of new ones because we had a hammer and a nail problem, right? Lawmakers, people who enforce the law, we got hammers and we see nails, right? So here are just some examples. I can't begin to go through all of these. I've written about a lot of these in the past. Everything from laws that treated any institution that treated people with pain totally differently and creating additional administrative hurdles, licensure boards, day limits for prescriptions, dose limits for prescriptions, prescription drug monitoring program enhanced requirements, doctor shopping laws that usually just penalize people who are poor. The CDC implemented guidelines for prescribing that were not read properly and implemented in all kinds of perverse ways that ended up inducing harm. We changed payment and insurance models. We increased the funding and the zealousness of criminal investigation and enforcement of prescribers. And we added things like drug-induced homicide laws in many places. Okay, well, here's the real world consequences. Let's just take the many laws, including the implementation of the CDC prescribing guidelines that had dose recommendations, and they had a sort of a top limit at which they said, you have to pay extra attention, really do careful assessments. They didn't say you can never go over it. They absolutely did not say, if your patient is over more than that a day, you have to take them off of it. They didn't, right? But prescribers and practitioners are rule followers, and they tend to over comply. If they hear that something can be a problem or there's a rule against something, they tend to be extra safe, right? And there's real fears to possible limits on their autonomy and their ability to practice medicine. That's understandably scary, right? So we had lots of prescribers in widespread ways that started rapidly tapering and voluntarily tapering people who had been on long-term opioid therapy with no evidence of use disorders quickly and to great harm. And we found that there's increased risk of suicide, significant increased risk of suicide. We saw some of the push down pop-up problem where people switched, they reduced their opioids, but then because we hadn't seen real warnings about co-prescribing, they added benzodiazepines and gabapentin, all that can potentiate and increase the likelihood of overdose up to 10 times the likelihood in at least one study. and more people died. And in empirical evaluations of state policies to see had they helped, had they changed, the answer's like, no, not really. And some of them have really hurt people, including prescription drug monitoring requirements. Okay. So this did prompt real action. The CDC came back and said, whoa, we didn't intend this. This is bad. The FDA put a black box warning on opioids to say, don't discontinue these rapidly. And so there was action, but there are also some promising developments. So I'm just going to list them, and I want to just mention some of the disability discrimination laws, which I think hold particular promise. So what's helpful? Harm reduction laws are helpful, right? Naloxone, Good Samaritan immunity, supervised consumption sites, which are legally complicated. Needle supply and exchanges, also legally complicated because of drug paraphernalia laws in many states. Changing the onerous restrictions on medication for opioid use disorder. This is helpful. It is ongoing, but in the last couple of years, we've seen restrictions removed about who can prescribe many kinds of MOUD. We've also seen a loosening of some of the methadone clinic regulations. And we have seen enforcement of disability discrimination laws, which is great. And then the case that Julie mentioned in the introduction, I think was a helpful change to prosecution of prescribers. So quickly, we have a number of federal disability civil rights laws that can help. They all acknowledge that opioid use disorder and substance use disorder more broadly are disabilities covered by the Rehabilitation Act, the Americans with Disabilities Act. That has been made clear in recent final rules for the Rehab Act, but also in recent regulation and enforcement activities for the ADA. I'll skip the disability definition, and you'll just have to trust me for now that it is. There is a structural barrier in that there's an exception for the current use of illegal drugs in the ADA and the Rehab Act, which can cause problems for protections. But importantly, in my area, there's an exception to the exception, which both the Rehab Act and the ADA say you may not decline or exclude people from health care because of the current use of illegal drugs, okay? Title II applies to state and local governments. Some examples we have seen lately have to do with, this one is an employment case where a sheriff who was on MOUD had been adverse employment action, and that was corrected. And recent settlement with the state judicial systems in Pennsylvania that made clear the requirement that drug courts can't disallow methadone or Suboxone. They just can't. It's a violation of the ADA. I know a lot of them do, but they can't. This is one about Alabama Medicaid that had a sobriety requirement for the receipt of certain services. We've also had lots with states regarding their jail practices. Have to allow throughout the state medication for opioid use disorder. It's a violation of the ADA if they don't. Title III is private entities of public accommodation. That basically means everybody else. And where we're seeing a lot of action here is nursing facilities, hospitals. So skilled nursing facilities refusing to accept patients for, say, rehab after a broken hip because they happen to be on opioid use disorder treatment. Refusal to consider somebody for a lung transplant because they happen to be on opioid use disorder treatment. Refusal to see patients for a back surgery because they happen to be on opioid use disorder treatment. So it's happening all the time, and we can use these laws to protect people. We just need to enforce them. So in closing, I just want to say We need to change our thinking. This is a problem of social marginalization, trauma, polysubstance use, and co-occurring conditions. This is not an issue of tough love and codependence. This is an issue of love. It's not an issue of shame. It's a matter of respect. It's not about self-help and just 12-step programs in isolation. It's about comprehensive professional care and medication for opioid use disorder. This isn't about a surveillance, punitive orientation. This should be about care and well-being and a harm reduction orientation. And it shouldn't be about criminalizing people because they have a condition. It should be about healthcare and community support systems. All right.
Good morning. I want to start by acknowledging my own perspective, which is that I am a prosecutor. I've served as a state and a federal prosecutor. I'm proud of the work that I've done as a prosecutor. I'm proud of the students that I see in the audience today who are now serving as prosecutors, including as narcotics prosecutors. I see Campbell Warner back here, who won an important case in federal court a couple weeks ago. It is important work. And I want to talk about fentanyl. There's something different about fentanyl that creates a challenge for law enforcement. Well, two things, really. One is it's cheap. And the second is that it's small. And these both matter a lot. The fact that it's cheap means that it's widely available. It means that it's the cheapest thing to cut into other drugs sometimes. The fact that it's small means it's extremely hard to intercept. And I know that for some people, one answer that probably won't be voiced at this seminar would be, well, we've got to stop it at the border. Well, think what one of our previous speakers said, that you can have 500,000 doses in a 1 kilo brick. That means that it's extremely difficult to create a net that's going to catch that. We're good at catching drugs that are big and smelly. And that's the thing about marijuana. It's pretty easy to catch. Things that are small, it's very difficult to interdict in that way. So we have that challenge. Now, in terms of it being cheap, I've seen this movie before. I was a federal prosecutor in Detroit in the 1990s for 5 years. And a lot of my cases were crack cases. And the thing about crack that was different, that made it really pernicious and created real social harms, was that it was cheap. It made a smokable form of cocaine cheap by cutting it with baking soda. And that meant that many more people used it. We often don't think about the price of a narcotic as mattering much because it's addictive, right? But think about smoking. When smoking, cigarettes are highly addictive, but when we made them more expensive, fewer people smoked. Now, did it get rid of smoking altogether? No, and that's never going to be a reasonable goal. The best that we'll ever do is to have fewer people do that thing. And so we know that even highly addicted substances are price sensitive. Now, about that time that I spent prosecuting crack, we had very harsh sentences. And someone who had a first offense that had over 5 grams of crack, which is just 5 sweet and low packets, had a mandatory minimum sentence of 5 years. Frankly, that didn't solve the problem, and it created other problems. It drove racial disparities that were recognizable pretty quickly, in which we did not address as we should have. And not only did it create those problems, it didn't solve the problem. Because the thing about narcotics is that it's a different kind of crime than most of the crimes that we usually think about as a template. Violent crimes. No one wants to be assaulted. No one wants to be murdered. But people want to buy drugs. They search around until they can find someone to buy drugs. And so we have a different dynamic in play, that instead of it being an oppositional crime like assault, it's one that's cooperative between the actor and the person who's the putative victim. And that means that what we have entered into is a realm that is controlled by the laws of supply and demand. And if we want to talk about solutions, we have to start by thinking about supply and demand. Now, supply and demand is going to affect price. And we know that. So how did we do that with crack? We did not. The price stayed the same or went down no matter how many people we locked up. Supply was going to find demand as long as the demand was there and once the demand had been created. And crack was incredibly easy to make. I mean, we incentivized going after crack cases despite the fact that that was the very end of the chain, that cocaine came into the country, was distributed throughout the country, distributed throughout a community as powder cocaine. And then at the end of the chain, someone would rocket up into crack, and that's the person that we'd take, the low-wage laborer. No wonder it didn't work. There was an endless supply in Detroit in the 1990s of low-wage labor. So with crack, we managed to both create a problem in terms of racial disparities and a lot of incarceration that was probably unnecessary without solving the problem. Let's talk about fentanyl. Now with fentanyl so far, and we're fairly well into that epidemic, we haven't replicated the problems that we created with crack for the most part. There hasn't been the incredibly long sentences coming out in most places that we saw with crack, or the overreaction that we had with crack, jumping to a putative solution that ended up not working. However, so we didn't make the problem worse. However, there haven't been substantial efforts to address fentanyl through the means of law enforcement. It's interesting. I was talking to Jessica yesterday, and we both looked for big fentanyl initiatives from law enforcement in this country and didn't find them. And part of it is that I think the experience with crack has scared people away from what we usually do, which is longer sentences, more people. And probably we're right to be scared away from that. But we can't back away from this field altogether. So what can we do? Well, first of all, is interdiction of any kind worthwhile? Let's go back to supply and demand. We know that if you manage to restrict supply, then the price will go up. And that's good, but only temporarily, because supply will find demand. It's the iron law of economics. So is it worth the effort to temporarily raise the price on the street of a narcotic? My answer to that is yes. I think it is. Because if we can do that, if we can raise the price, fewer people will do that drug. Now, I think it's wise to try to find a way to do that, however, that's not going to drive up incarceration, not do what we did with crack. And I think it's possible to do that. And here's what I'm suggesting. It doesn't work to sweep up low-wage labor. We tried that and it failed. And it doesn't really work to grab up a lot of product. We can have stacks and stacks and stacks of cocaine and more cocaine comes. We catch about 8% of the cocaine coming into the United States, and it doesn't matter. It's just a sunk cost for the people that are importing and exporting that cocaine. Where we can make a difference is money. After that, the Spears case came down, I spoke about it a lot, and I spoke about it at a Republican club in Dallas. So they're Republicans, it's Dallas, they're business people. And this guy stood up and said, what y'all have been doing, of course it's not going to work. You're never going to close down a business by sweeping up low-wage labor. And I asked him, okay, what would close down a business? And he said, cash flow and credit. And I asked the rest of the audience, well, is that true? And they all said, yeah. And that's the thing we haven't really pursued is, international syndicates, the people who bring it into our community, they don't have access to traditional credit. And so their cash flow is very vulnerable. And so if we want to take strong action as law enforcement, using law enforcement tools, the vulnerable part that can be disruptive of narcotics networks is going to be the cash flow going back to sources. The advantage to doing that as a way of raising the price on the street and having fewer people do fentanyl, first of all, we get to keep the money and we can use it for things like treatment or developing better processes to get more of the money. It doesn't incarcerate anybody necessarily. And it can be, if there is incarceration associated with it, it can be keyed to what gain is gathered beyond seizing that money. And we're able to get money in a way that we can't get product, where it really is going to be troubling, disruptive of the narcotics importers. Now, last year, I took a leave of absence for a year and served as the criminal chief and deputy county attorney here in Hennepin County. And one of the things that I really looked into and pushed for was changing some of the ways that we approach narcotics and developing a way that we could seize funds, that we could get after cash flow. Now, traditionally, forfeiture laws have been used to go after profit in the narcotics trade. In other words, we'll take somebody's car, we'll take their house, we'll take the pile of money they have in the back seat. But that's not cash flow. To get cash flow, you have to track the money as it's heading back to the source, whether it's domestic or international. And we have ways of doing that. In fact, within Hennepin County, we trained someone, and it was surprisingly easy to go after cryptocurrency. There's really three ways that cash flow can travel: cryptocurrency, bulk cash, just bills, and also through bank transactions. And we can track all three if we want. The thing about it is that if you think about a drug coming into the United States, that it is a mass that then disperses to a lot of users. So you've got it concentrated at one end and then dispersing. The money goes the other way. It ends up being dispersed. It's being paid by the users, and then it concentrates going back to the source. And that is a vulnerability too, because if we can take that money, once it concentrates before it goes back to the source, we have a chance of success. Can we do that? Absolutely, if we have the will to try it. Again, I do think that there is a moral imperative to not give up on fentanyl. There is a role for law enforcement to play, and it's an important one. And when we talk about the other things that are necessary, I'm not denigrating any of that or taking away from it. But in terms of what law enforcement can do, we must continue to take seriously our duty to try to solve that social problem through the tools that we have. Thank you.
All right, thank you so much. Now I'd like to open for questions. You see some journal members in the audience, they have microphones with them, but I will kick us off with the first few questions. From a policy perspective, how is fighting the fentanyl crisis different from fighting other drug crises?
Okay, I mean, I mentioned crack previously, and the thing that's different is partly the price. I failed to mention this when I was speaking before, but one of the things that I found last year was that the price of fentanyl in the street has dropped in the past 5 years in this county from $20 to $25 a pill or a dosage unit to $2. Think how that transforms everything. And so its cheapness distinguishes it, the way it's small distinguishes it. But the other thing too that distinguishes it from, say, meth or cocaine is that opioids work differently on the brain. It's not just that it makes you feel good, it's that if you don't have it, you feel bad. You're dope sick. And when we have a cheap way to avoid being dope sick that's on the street, that also kills a lot of people, that is more dangerous than most other forms of narcotics.
Yeah, I would say it is and it isn't. I would agree with everything Professor Osler said. I also think that maybe we can learn some lessons from it. Like, of course, I'm listening to Professor Osler's great talk and thinking, oh, that's great, because then if you can do it with fentanyl, then you can do it with the next thing, right? Because this sort of iron law or iron fist of prohibition is, a longstanding description. And when you prohibit these drugs completely, the incentive is to make them smaller and more potent and easier to transport and bring in. And we see that in action, right? So fentanyl won't be the last one, if all of history, unless all of history is wrong, right? We've seen shifting of substances over time, a memoriam, sort of following that iron law.
And, we heard a lot about like what the community can do, what law enforcement can do, but is there anything that legislators can do? Is there any additional regulation that could be helpful or necessary to fighting the fentanyl crisis?
Well, I'll go right at that one. And this is something where I find myself in conflict with a lot of people who share a lot of my beliefs. And that is that if we are going to go after cash flow for fentanyl, we have to have strong forfeiture laws. And sure, forfeiture, particularly civil forfeiture, has been abused sometimes to, take small amounts of money from people. But what we have to do is not abuse it in that way, and instead make sure that our forfeiture laws allow us to seize that cash flow efficiently and to keep it while still being fair and allowing people due process.
In the areas that I'm knowledgeable about, which is not this, so complete acknowledgement there, I'm very hesitant, especially in the area of healthcare and people who use drugs and the way we treat people who use drugs, unless it's absolutely aimed at harm reduction and making clear that people who use drugs are like human beings entitled to the same rights and care as anybody else. I'm very wary because, as just briefly I showed, I think, the clinical, especially in clinical care, it's just too nuanced for the blunt instrument of the law, and it can often lead to really bad consequences.
All right, thank you. Do we have any audience questions?
I have a law school. I, both as a lawyer and personally, have been affected by the topic we're talking about today. My little brother died last year of a fentanyl overdose. And both as a lawyer and a family member, I've seen, and Dr. Gillespie, this question I think is for you more so. I've seen this difficulty in using the legal processes of civil commitment and other types of civil processes to getting individuals help that are so affected by this disease, they can no longer make decisions to get help. And especially with the advent now of fentanyl, and then the high risk of death for these people that just can't or won't. What have you seen in your work? Are there ways that civil process could be used? I know it's been abused in the past, but used in a different way.
Yeah, that's a great question. And I'm really, really sorry, for your loss. And that's horrible. And there's no excuse. So Leo Beletsky has done some interesting work on involuntary commitment for substance use disorder. He's out of Northeastern. My understanding from the literature I've seen is, and trust me, I understand. I do understand the hope that it works because I have a very close family member who has serious mental illness, and that's been a challenge, that by the grace of God, they are still alive. But so what I'm saying is I get that. At the same time, the research I've seen is that forced treatment is often not successful. And I do wonder, and I don't know your situation, I'm not asking you to share it, but I know oftentimes when I talk to folks, one of the big barriers is the places that folks have access to, if they have access for care, often are not run by healthcare providers. They're often use methods and systems that aren't helpful and are harmful. Like, so for example, using 12-step programs alone for opioid use disorder are deadly. But it's pervasive, right? There are long waiting lists to get help in places that do provide effective medication for opioid use disorder treatment. And there are barriers, recently lifted, but significant barriers. Like, for example, until recently, you couldn't even enroll in a methadone program unless you could prove that you had had the ongoing condition for up to a year in some cases. I mean, it's ridiculous. So like, I kind of feel like some of the solutions are more on the front end, like medication for opioid use disorder, make it broadly available without barriers, right? Let people keep coming back. Understand that having recurrence can be part of the disease. Don't kick people out the minute that happens, right? So yeah, it's complicated and I'm really sorry. And I wish I had like if we did this, that would happen, because boy, that would be great. But it just doesn't seem to be the case for most situations in this area.
So much.
Thank you. Do we have other questions from the audience? All right, I can ask more questions. So given the heightened danger of fentanyl, has there been any discussion about increasing punishment for fentanyl by legislators right now?
That's for you.
Yeah, there has been, and in some jurisdictions that has happened, but we haven't seen the overreaction that we saw, for example, with crack. And the other thing too with fentanyl is that it appears that a treatment approach, particularly for users who aren't also selling, has been favored in a lot of jurisdictions. Some of the things that we heard the sheriffs talking about in the previous panel, and that's a good thing. But one thing about fentanyl is that it already was classified pretty high, so that there wasn't that much to change. And especially at the federal level, they did resist proposals to really jack it up in a way that would have been counterproductive.
All right, thank you. Now, Dr. Gillespie, you mentioned that Supreme Court case about prosecuting drug prescribers. Would you go into detail about that?
Yeah, so that case involved, so sort of, especially after there was a lot of attention to the overdoses in the media. They had started before they started to get a lot of attention, but sort of in response to that, over time, we saw circuits, courts slowly and sort of subtly eroding what had been sort of a consensus about what a prosecutor must show to secure a conviction against a prescriber for a violation of the Controlled Substance Act. So the Controlled Substance Act doesn't have a special part for prescribers. When prescribers are prosecuted, they're prosecuted under Section 841A, which says, except as authorized, it is unlawful to distribute, dispense, manufacture, etc., to knowingly distribute, dispense, manufacture a controlled substance. Okay. So it's difficult with prescribers because we know they're writing prescriptions for controlled substances. We want them to write prescriptions for controlled substances. Like anybody who's ever had a medical procedure, right? Pilots get controlled substances to stay awake, right? Controlled substances are the standard of care, effective treatment for many things. Treatment when you come into the emergency room with chest pain, right? Treatment with the serious respiratory effects of COVID, et cetera, et cetera. So it's not just sort of like chronic pain or serious pain after surgery, a lot of areas. So we want to do that. They know they're prescribing, right? And they have an exception, right? And the exception that except as authorized was sort of the question, what does that mean? What does it mean to be authorized? Well, that's also not in the statutes. So there's a regulation that was implemented decades ago without comment from anyone that's basically sets the authorization as like, you get authorized by the Drug Enforcement Agency, you follow all the basic like mechanical rules for writing prescriptions and whatnot, and you have to prescribe them for a legitimate medical purpose in the usual course of professional practice. Okay. So there had only been 2 Supreme Court cases, only one really in earnest that dealt with the issue. The first one was just about, could physicians be prosecuted under this general drug distribution statute? They said yes. That was an extreme case where somebody was selling prescriptions on the parking lot. And another one that sort of was tangential to the issue of prescribing and that provision of the Controlled Substances Act. At any rate, over time, some of the circuits eroded and had taken the word knowledge, the mens rea, right? Just like basic crim law, they had taken that requirement out of what needed to be shown, but only when it was a prescriber. And so they were substituting a deviation from the generally accepted standards of medical practice in the United States, which is a lesser standard than the standard of care in medical malpractice. And if they could prove that, that was enough to convict, right? And so the Supreme Court issued a unanimous decision and agreed that knowledge that they had to prove, a prosecutor had to prove that a prescriber knowingly exceeded their authorization. Now, people might be like, oh, great, you helped like the pill mill doctors. And that's what a lot of the media talked about. But really, it was bringing us back to the basic principles of criminal law, right? Sure, in some of the cases, could they have shown that? Yes, I think they probably could have. It wasn't about whether they were good doctors or bad doctors or criminal doctors. It was about the policy of it. And should we expect this of prosecutors? And the answer was yes, and I think that was the right answer.
Julia, I want to go back and just add to my last answer about, because you were asking about fentanyl and did the laws increase? And it's really important to talk about race. Yes. In the context of narcotics. And there's a point to be made about race when we talk about fentanyl and crack. Like I said, I was a narcotics prosecutor in Detroit in the 90s. I probably prosecuted 70, 80 people for selling crack. They were almost all Black men. It was really stark. Now, remember, it was white and Hispanic people who were bringing the powder into the United States, white and Hispanic people who were distributing it throughout the United States. It was pretty much Black men got involved at the very end of the chain, the least culpable person. And yet that's who was getting the harsh kingpin sentences. Well, okay, that was then. Now look at fentanyl. Well, fentanyl, that is not something where we see Black defendants predominating. And we haven't treated it the same way. How much does race matter? It's very hard to tell, but it does matter. And it does play into the way we see these things. And we know that with crack, the way that people see Black men is especially threatening played into that jacking up of sentences. In 1986, there was one death that mattered a lot. And some of you all in the back may remember this, but it was a basketball player named Len Bias, played for the University of Maryland. And Len Bias was drafted number 2 by the Boston Celtics. This was 1986, and the Celtics were great. And they somehow ended up there with the number 2 pick, and they pick Len Bias. Goes up to the draft, puts on the Celtics hat, right? Gets a big check. Goes back to his dorm at the University of Maryland and overdoses on cocaine. And that became the face of crack. Now, it turns out it probably wasn't crack that he used. And you contrast that with the other public health crisis that went on at the same time, which was AIDS. And despite it being, perceived as centered on already stigmatized communities, gay men, Haitians, needle users, the public face of that became a white middle school student from Indiana named Ryan White. And that went a very different way. We treated it as a public health crisis instead of as a morality crusade, the way we did against the individual who, where the face was that person we perceived as more threatening. So race is in the background and sometimes the foreground of this, and we have to be conscious of that.
All right. Can I just add one thing really quick? It's also important to know that at that same time, we weren't prosecuting the white people of privilege that were snorting cocaine at the same rates as the Black people using crack. So race is at the center and foundation of everything in drug policy.
All right. Thank you very much. If you could have another round of applause for amazing speakers.
All right. Well, it is my honor to introduce our keynote speaker, Minnesota Attorney General Keith Ellison. He graduated from the University of Minnesota Law School in 1990 and 3 years later became the executive director of the Legal Rights Center in Minneapolis. He served 4 years in the Minnesota House of Representatives and in 2006 was elected to the U.S. House of Representatives and served there until 2018. He was elected Attorney General of Minnesota in 2018 and 2022. And among many other accomplishments, his office led the successful prosecution of Derek Chauvin and 3 other Minneapolis Police Department officers. He wrote a book about it, which I've read and would recommend, Break the Wheel. And he served with a distinctive focus on his job as the people's lawyer in Minnesota. I can tell you too, personally, we're both from the city of Detroit. And I'm from the east side and he's from the west side. And if you're from Detroit, that matters. But I first met Attorney General Ellison at the 331 bar in Northeast. We were both speaking. And I heard something in him. And it's this, that since I was a little kid and I've seen things that weren't right, people told me the same thing, which is, that's just the way things are. And I never accepted that. And every once in a while, I find someone who sees things the same way. Someone else who doesn't accept when people tell them that's just the way things are. Who accepts that things can change and that there have to be people to do that to make them better. And one of my heroes of doing that, and someone who I hope to walk the same path is sometimes in making those things better, is Attorney General Keith Ellison. Keith?
Thank you, Professor Osler. Really kind words, and I appreciate it. And also thank all of you for devoting your time to talk about what is such a serious problem. You may have heard this story. In 2020, Devin Noring, a 19-year-old living in Hastings, Minnesota, went online to buy Percocet to help him deal with ongoing migraines and a cracked molar. This was during the early chaotic days of the COVID pandemic, and his appointments with his doctor and specialist had been postponed. The pills that got Devin turned on to fentanyl, and on April 4th, 2020, he died of an overdose. Now, I don't put that story out there because it's so unique. The sad reality is it's not unique at all, and that's what's driving us here today. If you haven't heard of Devin's tragic story, I'm sure you've heard of others like it, because in the past decade, fentanyl has been the leading cause of overdose death in Minnesota and nationwide. Fentanyl isn't new. It was developed by a Belgian chemist, Paul Hansen, in 1959. And in the 1960s, It heralded a breakthrough in pain management. At the time, it was the most powerful synthetic opioid ever created. And in the decades after its introduction, it became synonymous with fast, effective relief for post-surgery pain and a staple in hospitals everywhere. Fast forward to today, and fentanyl represents something far more sinister. It represents tens of thousands of deaths every year. It represents broken lives and grieving families. Today, fentanyl is synonymous with loss. Once known for its ability to ease pain, now it is a source of pain for communities across the country. Now, overdose deaths from fentanyl surpass those caused by heroin, cocaine, methamphetamines combined. To understand how this FDA-approved, widely used synthetic opioid helped fuel a crisis, we have to look at the rise of prescription opioids in America. And we can't talk about opioids without first reckoning with the human toll they've inflicted on this country. From 1999 to 2021, almost 300,000 people died from prescription opioid overdoses, including nearly 10,000 people right here in Minnesota. That peaked at about 130 Americans every day across our country. As prescription drugs ravaged the country and our state, my office took on the companies who were pushing these drugs on our communities, even though they knew full well how dangerous they were. And what we found was shocking. For years, these companies engaged in widespread deceptive marketing of opioids. They failed to act as suspicious orders of opioids flooded communities. And as the tragic impact of the opioid crisis multiplied year after year, these companies continue to twist the truth and hide the damage that they caused. Insys Therapeutics paid doctors to push prescriptions for a Subsys, a fentanyl spray that was 100 times more potent than morphine. As long as they kept writing those prescriptions, Insys would keep writing them checks. In Minnesota, the only two doctors who prescribed Subsys at any real volume were paid tens of thousands of dollars. Opioid manufacturer Mallinckrodt identified and targeted doctors who wrote outsized amounts of opioid prescriptions and worked to persuade them to choose their drugs, Exalgo, over the competitors. And we all know about Purdue and the Sackler family. Purdue deliberately misrepresented to both doctors and patients the many risks of long-term opioid use. The Sackler family knew OxyContin was twice as powerful as morphine. They knew how addictive it was and how addictive it could be after long-term use, but they still pocketed $4 billion in opioid profits, including $92 million from Minnesotans. These people would make Pablo Escobar look like a street corner hustler. Starting in 2018, the Minnesota Attorney General's office sued Insys, Mallinckrodt, Purdue, and others for their role in the opioid epidemic. And starting in 2021, my office and other AG offices around the country have landed historic financial settlements with opioid manufacturers, distributors, and pharmacies. The value of these settlements for Minnesota alone totals more than $560 million. So now, no amount of money can ever make up for the death and devastation these companies have caused families and communities all around Minnesota. Still, it's been important to hold them accountable and to maximize the effect of these settlements. I fought for a law that guarantees that every last dollar of the funds that my office wins from opioid companies is going directly to treatment, remediation, and prevention. That law passed the Minnesota State Legislature on a near unanimous bipartisan vote. I also led an effort to make sure that these dollars were directed where the pain is. I struck an agreement with cities and counties in Minnesota that dedicates 75% of all opioid settlement dollars that are going directly to local communities for them to spend on treatment, remediation, and prevention as they see fit, because they know best, because the fentanyl crisis hits locally. Today, overdose deaths from prescription drugs are down 15% from their peak in 2017. But people are still dying, and you all know that very well. Now, the crisis that the drug companies got rolling in the early 2000s has taken a new form. People dealing with chronic pain who can't get opioid prescriptions from their doctors anymore are turning to fentanyl because it's easier to get on the street. Young people are turning to fentanyl because they can buy it online and even at school. People struggling with substance abuse are turning to fentanyl because it's cheap, down to only $2 a pill in Minneapolis and St. Paul. And now we find ourselves in another brutal crisis. Fentanyl is the top killer of Americans aged 18 to 45. Last year, fentanyl killed 75,000 people in this country, and no other drug comes anywhere close. In Minnesota, synthetic opioids like fentanyl killed around 200 people in 2018, but by 2022, that number had more than quadrupled. And for every one person who dies from a fentanyl overdose, there are 13 who survive, sometimes with life-altering damage and injury. It's the scourge of our times, but we're not helpless, friends. We're absolutely not helpless. I believe there are lessons in our response to opioids that can help us save lives. Here in Minnesota, responsibility for prosecuting felonies rests primarily with the county attorneys in Minnesota's 87 counties. Under the law, my office can assist criminal prosecutions only when a county attorney or the governor formally directs the case to our office. We do this a lot, and we stand ready to help counties whenever they ask. And when it comes to prosecuting fentanyl-related crime, we've already done a fair number of cases and are ready to do more. We are prosecuted and we're currently prosecuting third-degree murder cases related to fentanyl in Benton County, Pipestone, Pope, and Renville counties, and we've already secured 4 convictions. The rest of the cases are ongoing. But in addition to criminal prosecution, attorneys general in Minnesota and all 50 states have broad authority in civil law to protect consumers and advance economic opportunity. That's a responsibility that goes back centuries. My office uses this authority every day to protect consumers from fraud, to make sure that workers get paid what they deserve, and to help maintain a level playing field for businesses that play by the rule. And even without original jurisdiction in criminal cases, my office uses our civil authority to advance public safety. Any instance of gun crime or property crime or drug-related crime happens at the end of a long chain of events. I found Professor Osler's chain metaphor to be very, very appropriate. Any instance of our criminal justice system tends to focus on the person at the end of the chain, the person holding the gun, the person behind the wheel of a stolen car, the person carrying illegal narcotics. But there are other links in that chain that deserve our focus. If we look in the right places and take the right action, we can prevent crime before it happens. Though some of the individual executives and doctors did end up facing criminal charges, and in our cases against opioid manufacturers, we were only using our civil authority, our lawsuits detail many things that were critical to hold people accountable. For example, these companies' efforts to unlawfully promote their products, their failure to disclose the risks of long-term use, their misrepresentations to healthcare providers about the product's benefits, their deceptive trade practices, their false statements in advertising, and more. Those were the tools at our disposal, and we used them to great effect. And that wasn't the only time we've used civil tools to promote public safety. We're suing a gun retailer, Fleet Farm, for looking the other way and selling guns to straw purchasers. Now, that's people who buy guns for people who are prohibited from owning them due to their criminal records or other disqualifiers. In one case, a gun that was straw purchased ended up being used in a fatal 2021 shooting at the Truck Park Bar in downtown St. Paul. The individual perpetrators of that crime have all been convicted and sentenced to prison terms, as I believe they should be. Ramsey County Attorney John Choi and his office used their authority and the criminal law to see to that. But when my office used our authority in civil law to investigate how some of those guns got to the crime scene, we found 34 occasions, 34 instances of Fleet Farm looking the other way when straw purchasers got guns. So we sued them to hold them accountable. A federal judge has ruled our lawsuit can proceed, and now we're in the middle of discovery. We've also launched a civil investigation into car makers Kia and Hyundai for selling vehicles to Minnesota consumers that lack industry standard anti-theft technology. You may have heard stories about how easy these Kias and Hyundais are to steal because the companies fail to install technology. It's led to a massive increase in car thefts, some of which have led to tragic, fatal accidents involving innocent people. Local authorities are doing what they can to hold individuals who committed these crimes responsible, but at the same time, we can also use tools in civil law to hold the companies accountable for creating conditions that made these thefts too easy in the first place. Kia and Hyundai still haven't taken full responsibility for their failure. I intend to see that they do. So, what are the lessons we can apply to the fentanyl crisis? Of course, law enforcement has a big role to play. The Minnesota Bureau of Criminal Apprehension established the Minnesota Anti-Heroin Task Force to help local agencies address the opioid and fentanyl crisis in their communities. Last year, they seized about 270 pounds of illegal opioids and made 660 arrests. The BCA also works closely with the Minnesota Office of Addiction and Recovery to make sure their approach remains focused on victims of illicit drug use. Overall, Minnesota law enforcement made almost 800 fentanyl-related arrests in 2021, then 1,000 in 2022, then over 1,400 last year. It is crucial that we hold offenders accountable, and law enforcement should be commended for their hard work. But there's another story in those numbers. It's all too clear that locking up a 20-year-old slinging fentanyl on a street corner is just a game of whack-a-mole, unless it's paired with a broader strategy. In neighborhoods where unemployment is high and opportunities are low, there will be another 20-year-old ready to replace the one who just got arrested. So what civil tools do attorney generals have at our disposal to keep people safe, to make the best use of our authority, to help my office has to disrupt things further up the chain, just like we did for opioids, for straw purchasers, for car theft. Let's take a look at that chain. More fentanyl purchased in the United States is manufactured in Mexico using chemicals purchased in China or India. And there's an important wrinkle. Those chemicals are usually shipped first to the United States, smuggled deceptively, marked packaging, and delivered through UPS, FedEx, or other major commercial shipping services. Most of these international packages are never searched, in part due to regulation known as de minimis. The de minimis regulations dictate that the individual parcels of merchandise valued at or below $800 can enter the country duty-free with very little paperwork or inspection. This accounts for 90% of all shipments entering the country. Before 2016, the de minimis limit was 200, until a four-fold increase was signed into law as part of the larger federal legislation. The impact on shipping has been immense. In 2015, 134 million packages entered the country this way. In 2024, that number will exceed 1.4 billion. With the 4 million packages arriving each day, it's impossible for authorities to search them all. The chemicals that make fentanyl used to be shipped in big industrial barrels, which were much harder to sneak into the country without inspection. The higher de minimis limits made it possible for traffickers to put many more needles in an ever-growing haystack. Once the chemicals reach the U.S., they're usually brought into Mexico by private individuals, typically U.S. citizens, who simply drive them across the border. The fentanyl is created in Mexico, then back across the border for sale in the U.S. And if you are looking to buy these ingredients, you don't need to have the wealth or connections of a drug cartel. Over the past year, a team of journalists from Reuters looked into just how easy it is to get your hands on these chemicals. Using just the web and a few messaging apps, they were able to purchase enough of these ingredients to make 3 million fentanyl pills. The cost to them, $3,600. If you're a teenager like Devin Noring, an 18-year-old from Hastings, the young man I talked about when I started, you don't need to hang out on the street corner to get fentanyl. dealers are using common social media apps to make contact with buyers. Apps like Snapchat can be particularly attractive for this kind of activity because of a feature that erases messages after a certain period of time. That's the current picture, and I see a few areas of potential change. On the legislative side, there are already several proposals to cut back the de minimis limit on shipments from China. And as for civil tools, well, what I look for are legitimate businesses that intersect with this deadly trade. Perhaps there are ways to compel our shipping companies to do more to prevent their services from being used to smuggle fentanyl ingredients to suspicious buyers. Social media companies might also deserve more scrutiny. In fact, Devin Noring's mom, Bridget, is one of 64 plaintiff families suing Snapchat for being what they deem to be an unregulated drug marketplace. That case is pending in California courts. So let me just say as I wrap up, this last year, fentanyl overdose declined for the first time in years. It was a small decline, but every fraction of a percentage point represents a life saved, a family kept whole, and a community left intact. Experts point to the rapid increase in the availability of naloxone and other drugs that can rapidly reverse the opioid overdose. The healthcare industry has been a vital partner in making these medications available, and it will take more partnerships like these to get us where we need to be. But here's the deal. To turn the corner on this crisis, we'll need all hands on deck. We'll need law enforcement to keep putting pressure on people shipping, distributing, and selling these drugs into our communities. We'll need U.S. Treasury Department to continue identifying entities involved in money laundering fentanyl profits and tracking transactions involving the sale of chemicals or equipment used to make the drug. We'll need legislators to make it harder for smugglers and dealers to get and sell their product and easier for law enforcement to stop them. We'll need cities and counties to use their opioid settlement funds to advance more treatment programs for people struggling with addiction. And we'll need those people who are on the very front line of helping break that cycle of addiction, continuing to give care to people fighting addiction. And we'll need attorneys general thinking creatively about civil tools at their disposal to put pressure on companies that might not be doing enough to prevent their involvement in this dangerous industry. We'll need cooperation. We'll need collaboration. We'll need determination. The stakes are too high for us to offer anything less. Thanks.
Follow up. So Attorney General Ellison, I'm going to ask a couple follow-up questions. And if you're welcome to it, we'll take questions from the audience. But first, you mentioned that one of the things that your office does directly engaging with cases is taking third-degree murder cases.
Yeah.
Could you talk about a little bit about what those are and what it is that you see in pursuing them?
Yeah, so a third-degree murder case is a case that is written for people who distribute illegal drugs, and the result is a death of a person. The underlying theory is related to this idea that you didn't want to kill the person, but you didn't really care that what you were putting into the stream of commerce very well could kill somebody, and that is what makes you culpable. And it's important to prosecute these cases. It's important for victims' families. It's important to deter people from doing this sale. It's important to take the people off the street who do this kind of stuff. But our office does those, but generally we do them in small rural counties. We're prepared to do as many as are needed. But I will say this to you as I say that we're prepared to prosecute these cases. I am certain that it's better to try to go upstream and cut the supply rather than just prosecute. I don't know if we can actually prosecute our way out of this, though we have to hold people accountable who are distributing drugs that kill people. We got to go upstream.
And the second question I have relates to what you just said, which is that you talked about the important work that your office has done about the manufacturers of opioids. Right. And of course, there's been a narrative arc here in people's lives and nationally where people got addicted to the legal opioids and then the cartels supplied the opioids that kill them.
Right.
your office clearly has the authority to do something about the companies, but limited ability to do something about the larger picture. What do you think your office could do in terms of seeking greater authority or working with others to try to do that? Because one thing I've seen is just a lack of leadership in terms of going after fentanyl and targeting it.
Well, that's why this conference today is so important. This is leadership. You know, Professor Osler, you and everybody here is giving that leadership that you correctly recognize is lacking. So thank you all for being here on that front. There's a lot of, we've come here in part because we don't have all the answers. We're hoping to get some ideas from you, but one of the things we want to do is make the de minimis standard more stringent. That I think would give us put us in a position to be able to investigate and do more cases. I'd also like to really delve into the money laundering aspect of this because it generates a lot of money and it's going somewhere and we've got to be able to put our hands around that. Now, you know, I can tell you that I think we've got to have more scrutiny on Bitcoin and blockchain sources of funds. This is very important. But grabbing that money would be important. I will say this also, distributing the supply, as I talked about in my comments, it's really hard to do given the low cost and the ease which these things are made. But I think it really does make us a more attractive nuisance when you can get a pill for $2. If it was $5, there would be people who wouldn't indulge, right? If we just increase the price on the street, there is a percentage of folks whose lives we could save. And so those are some ideas, but I look forward to hearing from others. I can tell you most of the things that I pursue are not things that born out of my own brain. I mean, you know, it's talking that gets us there.
All right. Well, let's open it up for questions from, can we get a mic?
So my question is, you noted earlier that it's kind of like a game of whack-a-mole and, you know, we're taking down some 20-year-old. You know, my concern is, you know, at what point, you know, we don't want it to get to the point where that 20-year-old dealer kills somebody.
Right.
So what is your advice in trying to decipher, well, when is this 20-year-old someone who should go to, you know, treatment court, or when do we really, you know, go after this individual? Because, you know, if I let him go or take it a little bit easier, his next sale could kill someone.
Well, I agree with you. I think we have to hold people accountable for breaking the law, and that means third-degree murder cases. We're bringing them. I don't know if you caught that part of my presentation. We are prosecuting those cases. But as we prosecute them, we do know that there's a larger problem at work. And so we don't want to lose sight of that. I mean, you really can just process this case, the next case, the next case, and then a year after you've prosecuted a whole bunch of people, you're just going to prosecute that many more than that the next year. So I do think that I'm not talking about upstream versus immediate. I'm talking about we have to do both, right? So now when it comes to penalties and things like that, for me, it all depends. I'm not a fan of mandatory minimums. I think we should let the judge and probation and the defense counsel and the prosecutor evaluate this case, taking in consideration disparities that happen in our criminal justice system. You know, but I don't think that you're doing even that 20-year-old kid any good by just ignoring his case, because I've met more than one or two people who've literally benefited by having a brush with the criminal justice system that made them stop and think about what they were doing and turn things around. I'm not a big fan of, you know, I do believe in second chances, but I also believe in accountability. Thank you for your question. Yeah. No, you're up.
Murder question, I guess, and I'm not from Minnesota, I'm not familiar.
Sure.
But how do you manage dealing with the accountability, but also dealing with the reality that research on whether it's felony murder, like in the state I'm from, Missouri, we don't need drug-induced homicide because any felony and every felony can be the predicate. Or whether it's drug-induced homicide statutes, that the research has shown that even more disproportionately than with regular prosecutions, Black and brown folks are prosecuted for these and then again sentenced more harshly. And in some jurisdictions, it's like the friend who gave their like cousin, a cousin gave drugs and the cousin died, and then this kid's in jail for 20 years. So I just feel, and I know you care very much about racial justice, so I'm wondering how you balance that.
You know, it's an ongoing struggle to balance these important. Here's what I'm sure of. Acting like it didn't happen is not going to save anyone. Taking a 20-year-old who may have really no background in this and then distributes to somebody who dies and giving that person life without, that's probably bad too. So how do we work it all out? I don't know. There is no answer that will fit all cases, but we've got to put a lot of energy in, and we've got to also understand that while this person is doing things that they know they're not supposed to be doing. I mean, I was a criminal defense lawyer for a long time. And, you know, a certain percentage of my clients actually didn't do it. A larger percentage of my clients, they did do it. But the question was, what's going to happen now? And I believe that we have got to create pathways for people to work their way back into society. And just throwing human beings away, I'm not in favor of that. You know, I believe, you know, I'm on we started an expungement. We could do statewide expungements for free in Minnesota. I authored the bill that allowed everybody on felony probation or parole to vote. In Minnesota, if you're out, you can vote. You know, and I'm also on the pardon board, and we've tried to increase the number of pardons that people are applying for. I was talking to a friend of mine last night who is a model citizen in every way that I can see. He had a federal drug case in 1988 and hasn't been in any trouble since. And yet, if he ever wants to apply for anything, here this thing is. I don't think we are the worst thing we've ever done. But as we say that, let us not make the mistake on the other side and say, oh, it's okay to sell dope in our neighborhoods. No, it isn't. You know, you can't do it. And you got to stop doing it, you know? And so that's where we're at. The problem is our pendulum is always swinging one way to the other, and we never really just let it get right here. So thank you for asking the question, because it is something that we are going to all have to wrestle with. I can tell you that the tough on crime narrative, I don't know if that works. I doubt it. And also, this person was a victim of societal racism and discrimination. So we're not going to say, don't do that. You know, there's somewhere in between. I think so. Yeah.
So give me that pardon case.
Oh yeah. Oh yeah. Oh yeah. Oh yeah. We'll do.
All right.
We'll do.
We got another question.
Attorney General, thank you.
Hey, Paul, how you doing?
How you doing? Keith, it's great to see you. I want to congratulate you and one of our board members at Fentanyl Free Communities, Mike Freeman.
Sure.
I know you worked on that opioid settlement agreement. And as you may know, Fentanyl Free Communities is about 1.5 years old, and we're created out of the idea that fentanyl is a unique public health threat. So please stop by. Shameless promotion, any of you, if you're interested. My question for you, though, Keith, is from our initial work on this, unlocking some of the funds from the opioid settlement to directly address fentanyl, perhaps to assist law enforcement, education specific to fentanyl, there's been a lot of challenge to that.
Yeah.
It seems like the agreement really, and I'm not faulting it because the fentanyl crisis kind of hit right about there a little after. But what are your thoughts about unlocking more of those funds specifically to fight fentanyl, and perhaps your advice to us as an organization as to how we best advocate for that?
You know, I think one of the things we got to do, and maybe this would be a good follow-up, how do you access these funds? because we sue these companies, and we didn't just sue the makers. We sued the marketers, we sued the distributors, we sued a bunch of folks. And, we cut the deal that the counties and the cities would get 75% of the money. And yet I've been in at least 2 different meetings today with you and somebody else up in Moorhead who was like, we're trying to get the money out, but it just takes too long and there's too much bureaucracy. That's one of the side effects of making it highly localized. But I think that it's just like any other problem. Let's get together and talk about how to shake that money loose. Some people are afraid that somebody's going to use the money for purposes it's not supposed to, so they get really tight on the money. I'm glad that they want to be mindful and about the public dollar. I also want the money to get where it needs to go. And so it's sort of this problem. I've heard great stories about communities really getting the money and putting it to work, and I've heard some troubling stories. But why don't we just get together and talk about how to shake this money loose? Because I can tell you, you're not alone in being a little frustrated on the speed with which the money gets released and the paperwork and all this kind of stuff. So thanks for raising that.
My name's Steve Middlebrook, second-year student here. I just had a quick question. I know, so we've failed to regulate the cryptocurrency market wholesale in this country, but you talked about going after players that are culpable, and at some point, these transactions are going through a cryptocurrency exchange. And has your office or other attorneys general looked into going after some of these crypto exchanges?
The answer to your question is yeah, absolutely yes. But here's the other sad answer. I don't think we understand it well enough to really get at the root, get at the solution we're looking for. So it's, yes, we've been talking about it quite a lot. And at the same time, we have not done the work that we need to do. Quite honestly, an enterprising law student could maybe help us out on this. I mean, look, how many people in here understand cryptocurrency? Okay, we got one guy, and this is a representative sample, friends. And so we've got to do it because you know who knows how to work cryptocurrency pretty well? Drug dealers. They know how to do it. We don't know how to do it. So let's figure it out. But thank you for raising that. We are working on it. We haven't made enough progress.
Hey, Keith.
Hey, good to see you, man.
How are you doing? In our community, Native American community, we're seeing just a overabundance of fentanyl, and really in the younger population now. I have a outreach team that's out at night from 7 o'clock to 3 o'clock in the morning, and they're seeing girls 14 years old that are going to sleep at home. When their parents go to sleep, they go out a window and they're smoking fentanyl at a bus stop. And so my question is, any way to make the penalty for selling to minors, greater, so that at least it's a way of getting the dealers to just realize, well, yeah, I can't do this, because I just feel it's killing our people, and we get them started at ages 11, 12, and 14, right, just like the Kia boys.
Yeah,
we got 12 and 13-year-olds stealing cars. We got to find a way to get help from them, right, in doing that. So just an idea.
No, I think that's a good idea. I also think we need more people. So like higher penalties is an idea that's worthy of discussion, but also how can we figure out how to how to get at this cryptocurrency thing? Because if the money is drying up, if a pill costs $5 as opposed to $2, some of those kids sneaking out the door ain't gonna, they won't be able to afford it. So your idea, cryptocurrency stuff, dealing with this de minimis issue, that's how we're gonna there's no silver bullet, but accountability for selling to kids is absolutely part of it. Thank you for raising that. That's right. And you could. That's right. That's right. Absolutely. Yep.
Hello, A.G. Ellison. First, thanks for being here, and thank you for taking our questions. I'm back here.
Oh, there you go.
I wrote my question down, so I'm just going to read it. So I've been externing with a judge last semester and this semester. The perks of that is watching whatever's happening in the courthouse on the days that I'm in the building. So between this semester and last, I've watched a lot of sentencings, a lot of folks being sentenced for distribution of fentanyl. But these individuals aren't just drug dealers. They are addicts themselves. Can you talk about the programs in place, not just to rehabilitate the addicts that have committed these crimes, but the ones that could commit these crimes because of their addiction?
You know, that's interesting because we have folks here who represent the recovery community. Teen Challenges here, right? We got anybody else here from the recovery community? Sure. Good. Yep. Do you all have all the money you need to treat all the people who need your help? So we have a resource challenge from up top. All the money my office is shaking free from some of these big companies is got to be part of the solution, but we got to get the money there. We do have diversion programs, treatment programs, but all of them are underfunded. And so this is the challenge in front of us, right? The people can I tell you this about politics? This is a law of politics. This is like a law of politics. No matter how important an issue is, if there's not a constituency pressuring the policymakers to do it, it ain't going to happen. And no matter how frivolous, stupid, and unimportant something may be, if you get a bunch of people to say, we want this, it is going to happen. It's like a law of politics. So we've got an organizing challenge to help fix the problem this young lady has identified, which is that our treatment approach is vastly under-resourced. But you all know how to help people get off drugs, right? Y'all know how to do it. I mean, not everybody, it doesn't work on every single person, but it works on a lot of people, right? We do know how to help people beat fentanyl addiction. What we don't have enough of is enough resource to help them do that. So I'm asking you to be part of that. I mean, what is our legislative agenda for January to tell the legislature we need more treatment money? We should absolutely be there doing that. Many of them are going to be more than happy to increase penalties and stuff like that, which well may be appropriate. But are they going to help people get free from that addiction, which would be better for all of us? So thank you for your question.
I also had a question. Thank you. Could you speak a little bit to what your office is doing regarding restorative justice initiatives? Regarding some of your comments you made earlier on about people getting involved in dealing when there's low economic opportunity, sometimes, well, not sometimes, often criminalization of an activity isn't a deterrent when you're in that situation. If you have to choose between the money and a potential criminal charge. And then connecting back to some of these, we're talking murder 3, young people, you mentioned you don't want to pretend like it didn't happen, while at the same time not trying to start someone within the criminal justice cycle that they're never going to get out of, and further traumatizing them by putting them in jail at a young age. And I think a lot of restorative justice conversations come from defenders and criminal defenders, and sometimes people don't take it seriously because of the perspective, and folks think that it's just sort of a get out of jail card. Can you speak to the legitimacy of the value of restorative justice, and 2, what your office is doing or could do to really bring some legitimacy to those programs rather than it just being a buzzword?
Got it. Well, let me just tell you, my office is not a restorative justice outfit. But I want to be real clear. Restorative justice is extremely important. It's effective. And I'll also add, victims want it. So often in our criminal justice system, let's just say that this guy here sold my daughter fentanyl and she died. I might feel all kind of ways about that. Maybe I'm going to want revenge. maybe I'm going to want to look him in the eye and hear him apologize to what he did to our family. Maybe I'm going to want him to know, here's who my daughter was. She was beautiful. She was smart. She had everything to live for. And you, seeking money, sold her poison and she died. And I want you to know that. I want you to live with that. I want you to sit with that. Victims don't always want a pound of flesh and 1,000 years in prison. They don't always want that. Sometimes they want that. They don't always want that. What restorative justice gives us and a chance to do is really kind of connect that circle. And I'm going to tell you, I've met people because when I was doing criminal defense a lot, we did have, family group conferencing, other sort of programs. And I've had people look me in the eye and say, I would rather just go do my time. I don't want to look at that lady. I don't want to face her. Well, that is exactly what you need to do to change and be different. I think it's important for us to, I'm dreaming of the day when we all can understand that criminal victimization does hurt people, and there's going to have to be truth and accountability and maybe even consequence. But also understand that just sticking it to people isn't going to solve the problem. Again, if you got a neighborhood where 65% of the people are unemployed, and you're gonna have fertile ground for a certain kind of activity. That doesn't make it right, though. But it also means we have to have other responses, not just the big kabam, right? Because even if you get a conviction, why should that conviction stay on your record forever, even after you have 10, 12, 15 years of clean living? But yet that's what we do, right? There's a lot of things that we do need to change this thing. And I'll just say that as we talk about what we're going to do about fentanyl and we talk about criminal justice responses, let's keep victims in mind. Let's never forget the victim's not the enemy of the defendant necessarily. Has anybody ever read Until We Reckon? Anybody read Until We Reckon by Danielle Surratt? I strongly urge you to read that book. A lot of the things you read in that book, you already know, but it might do you some good to know that if you were thinking it and she was thinking it, maybe we should work on doing it. Thank you. All right.
I wasn't going to ask this, but I just keep thinking about it.
Why not?
So here I go. You were talking about third-degree murder.
Yeah.
And I think when you're talking about people who are actually selling drugs and distributing, I mean, that's a different thing. But I've seen lots of folks come through our program who they were just sharing drugs with their friend and that person died. And when we look at the sentencing grid for third-degree murder compared to vehicular homicide, there's a lot of differences between those two things. And there's a culpability that comes with the fact that the person chose to do those drugs, different than someone who died in a car driving down the road. And there's some disparities, racial disparities with who commits those crimes. And so I just wondered if you all, you talked about that you guys charging.
Sure.
Like, do you think about that stuff? Is
Yeah.
that because when we send, like, we had a couple of them that went to prison. You guys didn't do them, but like the counties did.
County cases,
And
yeah.
it gets under my skin that, just the difference in the view of it. And is it the way that judges look at it? Because it could happen to them, or it's drinking compared to drugs, but it doesn't feel fair to me. Like justice isn't served in that way. And so can you speak to that a little?
Yeah, so we have something called the Minnesota Sentencing Guidelines Commission. It's a very important organization. And one of the main things they try to do is work on proportionality, trying to compare like things to like things and unlike things to unlike things and make sure that it's fitting with regard to justice, foreseeability, that it reaches all the goals of sentencing, deterrence, incapacitation, even retribution, things like that. So that's really where that question lies. Whenever our office prosecutes people, and we're getting ready for sentencing hearings, we get a memo from the Minnesota sentencing guidelines and to say how many people were charged with this, what do they get, and just try to get some sense of fairness. Okay. Now, if you have some biases already built into the system, those biases are going to translate into those numbers you just got. But I think it's important that proportionality is key, and it is one of our age-old problems. I mean, why do we have sentencing guidelines? Because when we had indeterminate sentencing, the racial disparities and the class disparities were absurd and off the chart. So we put together sentencing guidelines to try to get some proportionality. Well, we still have this problem. If you want to solve this problem, and you're here, so you clearly do, you're in for a long haul, man. There's all kinds of things that we're trying to fix here, but we are absolutely considering proportionality, fairness. But like I said, I try to just remind people that there's a mom and a dad. They're at a funeral home and they're saying goodbye to their 19-year-old because somebody thought I could get paid by distributing drugs to them. And I will freely acknowledge distributing drugs to somebody and that result in their death, that could be a good friend of yours. You might not have charged him anything. I mean, all these stories are different, are they not? All these stories are different. And that's why it's hard to just have a rule that says, okay, we're going to just do this. I told y'all I was not in favor of mandatory minimum sentencing because the legislature, who doesn't know a damn thing about that defendant, thinks that they're in a position to sentence over and above what the judge, the probation agent, the prosecutor, the defense attorney, the victims, they just jump over everybody and just say, here's what we're going to do. Well, how do you know? I think sentencing should be tailored, but I also think it should be proportionate and fair. So thank you for that. Any more? Or we're good.
I've still got one.
Oh, good. All right. All right.
And it's this, that we're about to have an election. We've got two candidates for president.
I heard.
Well, yeah. One of whom much of her career was spent in criminal law.
Yeah.
The other one, probably the accomplishment he got the most acclaim for universally was a Criminal Law Reform Act, the First Step Act.
Yeah, he did.
And yet, we've had almost no discussion of criminal law or fentanyl other than border issues in this campaign. Why is that, given how important this is?
You know what? All I can say is ditto, man. I mean, when the pollsters and everybody else tries to figure out what are the key issues that you have to talk about in order to win this election, economy always comes up. Abortion and rights like that, they come up. I think criminal justice tends to come a little further down the line, but it is critically important for a lot of people. So I'll say that if we start demanding these candidates get a position on these critical issues we're concerned about, they're going to start trying to figure out how to address our concerns. We are in an inherently political process. That's not a bad thing. Usually when you say something is political, that's a way to say it's slimy or a problem. But it just means that all of us in our individual lives want people in leadership to have our concerns in mind. Now that's politics, right? And how do we get our concerns on their agenda? We push it. It's about lobbying. The American political system is not immoral, nor is it particularly moral. It's amoral. What does that mean? It's not sensitive to issues of morality. It's sensitive to lobbying. That's what it's sensitive to. And if we're willing to lobby, we're going to get some things we want to get. And so let's think about that. I think I got to run to the airport now. Thank you all very much for having me. I appreciate it.
At this time, I would like to introduce our moderator for the next panel with affected persons. We've been talking about fentanyl, obviously, all day, and we'll continue to after this panel. When Professor Osler and I sat down to craft what this event looks like, we really wanted to humanize this discussion as well. And I think that's what this panel will be able to do really well. So we've been looking forward to this one for some time. So Gina Evans, sitting right here to my left, works in legislative affairs at Minnesota Adult and Teen Challenge, who we will hear more from later today. Saul from Minnesota Adult and Teen Challenge is here as well. And Gina here has over 30 years of experience with criminal justice and substance use disorder, both inside and outside of institutions. Gina's work legislatively centers around community alternatives to incarceration, second chance efforts, and changes to the substance use disorder field that ensure equitable access to treatment for everyone. Gina is a founding member of the Minnesota Justice Research Center and is honored to serve on the Community Advisory Board for Hennepin County Sheriff Witt, who obviously we heard from earlier this morning. As an impacted person, Gina believes her life's work is helping others struggling with life-controlling issues and helping them find freedom. I'd also like to briefly introduce our other panelists. We have Ferome Brown. We have Andrew Mazzara, Teresa Egan, and Vanessa Marlowe up on stage as well. So at this time, Gina, I'll turn it over to you guys. Thanks for being here.
Thanks, Mason. Good afternoon, everyone. It's always tough to be the first one after lunch. Thanks everybody for being here. I think after hearing the data, hearing from experts on public safety and the law this morning, now turning to perhaps the most profound perspectives, the lived experience of those whose lives have been touched by fentanyl. These stories remind us that behind every statistic and every case file is a beloved child, parent, brother, sister, or friend. Every person who shares today has shown tremendous strength and courage in coming forward to help others understand the real human impact of this public health crisis. Their stories, though difficult, light the way toward hope and healing for our community. Each panelist will have roughly about 10 minutes to tell us more about themselves and their story. Once our panelists have conducted, we'll open up for the audience to ask questions. And then we'll have a couple folks with microphones moderate the questions. I just want to again thank each of you for being with us today and being willing to share your stories. So we didn't talk about who wanted to go first, but.
I guess me. So hi everybody, how y'all doing? I'm Ferome Brown. I'm the Executive Director of Urban Youth Conservation. I am the lead case manager for GVI Group Violence Intervention and YGVI with Hennepin County. So my story's, I don't know. So it's kind of, it's weird because when Professor Osler, he's one of the most intelligent guys that I think I've ever sat down and had conversation with. And he's talked to me about different things he's actually done by clemency, and he's been really instrumental to a lot of things that I've been trying to do. But when they asked me about this, it was kind of weird because I was like, this has touched me so much to where I don't even know where to begin at. Like, first off, it's a really close member of my family, OD, and she is 69. And North Memorial said she was the oldest person to ever come into the hospital in an overdose, and they saved her. Another person that was very close to me was I had a client of mine, and so everybody that gets funding here knows that we go low on funding, and sometimes you might not get your funding when they say, hey, you're going to get funded again, so you have to wait, especially anybody that's had funding from the city of Minneapolis know what I'm talking about. So I had a guy that called me. He was like, Ferome, I'm really, I've been doing good. I haven't used and this and that. And I'm like, you know what? Just try to hold on. I said, even if I have to take it out of my check, I'm going to make sure I help you with your light bill. That night, him and his significant other got into it over the bills, and he went out and did fentanyl, and he died over OD. So this hits home, and there's so many different stories that I could tell that more than you really realize. And I can tell you, how they say crack kills. I don't know no crackheads that's died. Like, honestly, like this has affected our community. I live in one of the worst neighborhoods that there is over North Minneapolis. I still live there to this day, born and raised over there. But the neighborhood I moved to is where my wife had lived since 2000. is a brand new home. And this actual block was the worst block for crack selling. And these guys that sold crack, I grew up with. And so I told her, I said, give me 3 to 5 years, I'm gonna clean it up. And she was looking at me like this. And I remember as me being young, this was always the block. Even when we was kids, this has always been the block. I did the first national night out on that block. No one's ever even attempted to do a national night out. And I'm thinking to myself, how no one's ever did a national night out on this block? Like I'm just, so when I did it, all the drug dealers, gang members all came like, oh, what's up, bro? I'm doing this here. Can I eat? I'm like, yeah. So we talk, I'm like, y'all, I'm gonna clean this up, man. Y'all gonna have to find somewhere else to go. I said, I live here now. And I'm not finna get shot coming out the door. You know, I've been shot 13 times. I'm not getting shot 14. So it's over with. So to make a long story short, I cleaned that whole block up. There's not any more drugs dealing that. But the significance that what I'm saying about that is the ones that used to do crack started doing fentanyl. And at least 65% of them passed away from ODing. I've never seen a drug like this in my whole entire life. And the more Keith talked to me and Keith is real close since I was a kid, Keith Ellis, I'm glad we got him here. And the more I listened to those statistics and just how it came from China and what Osler said about the crack epidemics and that epidemic, it's just really crazy how people of color, us, got caught up in the mix of getting umpteen years for that. And then this is like, oh, well, you know, we're not going to do it. You know, we already did that at one time, so we're not going to do that again. It's just tripping me out that we sat here and we listened to that. And it's like all the guys are still locked up for drugs, 20, 30, 50 years, you know, and I guess I feel like, I know we're doing as much as we can and this and that, but it doesn't feel like there's going to be a lot of people left doing drugs because this drug is going to kill. It feels like everybody, and everybody's going to be extinct. So I don't know. I'll pass with that.
Okay. Hi, everyone. My name is Teresa Egan, and I lost my son Riley to fentanyl poisoning in January 2022. And he was only 26 years old at the time. I'm able to be here today because I volunteer with fentanyl-free communities, and that has helped me, what I like to think of as save lives. That's our mission. And we go out and spread the dangers of fentanyl to families. So for me, that helped me get through my grief. And so that is why I'm here today. And I want to talk about Riley. He was more than just his substance use disorder. He was a wonderful person, very compassionate, kind. He taught me so much about caring for people that were homeless, that didn't have anything. He had friends, you know, that were also had substance use disorder. So I learned a lot through him to be compassionate. So that was the gift he left me. And to start from the beginning, I'll just give you a brief story of how he got where he was. Riley was, I would say, kind of categorized in as a normal childhood growing up. He grew up with 2 loving parents, his dad and I. He was our firstborn, and he had a brother. He had doting grandparents that loved him very much. And he thrived. He was in sports. He got good grades in school. And there were a few things that really, I would say, rocked Riley's world. One of them was when Riley was 9. We lost my dad, his grandfather. They were best friends. And so that was very traumatic for Riley. And then a year later, Riley's dad and I divorced. So those couple of things started Riley on a path of, I would say, being a little bit troubled. We got him through some counseling. He seemed to be doing fine. Riley was liked by most people, by all of his friends. And so he always had friends growing up. So fast forward through middle school, again, being in sports, having friends around him and a loving family. We get into high school and Riley always had a couple of really close friends, and one of his friends started dating someone and then was never available for Riley, would cancel on him. So Riley found a new group of friends, and I was a working full-time parent. I had a demanding job. I was in a leadership role in finance at a large company at the time, and I could see, Riley was struggling, but then when he found some new friends, he seemed happy. He had a long-term girlfriend. But I did notice he was starting to party, and my husband and I talked to him since he was very little about, the issues you have with alcohol, drug use leading to substance use disorder. So we thought we had equipped him with plenty of tools and many examples of addiction on my side of the family. So when I saw this going on, I questioned Riley, and he goes, "It's okay, Mom. I'm not going to be an alcoholic. We're just having fun." And as time went on, Riley graduated. He also had another traumatic event when he and his girlfriend broke up after seeing each other for a year. Very troubling. Riley, I could see going into a deeper place at that point, kind of feeling lost. And he was going to college at the time, living at home. And he wouldn't speak about it. He was kind of a private kid. He would talk to his friends, but not his family. Although we told him we would always be there for him and we would always help him through things. He had a very good support system as far as family went. Anyway, it ended up that he was arrested by the police. He had Xanax in his pocket. He did not have a prescription, so he ended up in jail. So his dad and I got him in a treatment facility, which he spent 5 weeks there. And when he came out, he was clean for 2 weeks. And then he totaled his car. He ended up in a ditch. Luckily, he was wearing a seatbelt, and he came out with some scratches and bruises. And that was somewhat of a wake-up call for Riley. He came to me and just said, "I'm so sorry for what I put you through, what I put my family through." And it is really a family thing. It tears families apart. He and his brother, younger brother, were best friends. And then when Riley was using, he would be so hurtful to his brother. And actually, it ended up that they never did reconcile upon Riley's death. They never reconciled. He reconciled with most people, but not his brother. So that's one of the sad things that came about. So during this pattern of using and being, trying to get sober and being in recovery for a few months, I had to make a decision at that point. And, seeing my child suffer like that, I decided to leave work. I wanted to be there for support for my family, for Riley, and that made all the difference in the world. We got him sober again. He was sober for 2 years. That was the best decision I had ever made in my life. Riley and I traveled. We had so much, and I learned so much from him about why he did what he did, what had happened. And a couple of takeaways from that were, I just said, "Well, why did you use in the first place? Because you knew all the consequences. We talked about it all the time." And he said, "Well, Mom, when people are drinking, you get pulled over and you get a DWI. But if you take a pill, then, you're not going to get caught." So they started using Xanax and painkillers. And so Riley's problem was he got addicted to opiates and by taking painkillers. And the other thing I learned is that that is very difficult because of the physical withdrawal. And he was always afraid of physically withdrawing from that. So I remember just hearing when Dr. Gillespie was speaking about using Suboxone. Well, it took us a while, but he finally got to use Suboxone, and that's what kept him clean and sober for 2 years. Riley ended up after 2 years, he was in between jobs, and he decided that he wanted to try and taper off of the Suboxone. Well, he was going a little bit faster than what I'm sure the doctor recommended. And with the stress of trying to find a new job and anxiety mixed in with the tapering off of Suboxone, he ended up finding something on the street. And the most ironic thing ever is that he knew that he did not want to have the withdrawals of going with the opiates again. So he actually went and he purchased meth, and that was laced with 2 types of fentanyl that killed him. And peace I get in knowing is that now Riley is free from his addiction. He's in a happy place and he's with his best friend, his grandfather. So those things keep me going, as well as trying to help others be educated on fentanyl and saving lives.
Thank you both for being willing to share. I know that that's hard to relive and talk about, and thank you for being transparent and sharing. Andrew, do you want to?
Yeah, absolutely. I am Andrew. I'm an undergrad student at Augsburg University. I'm also a recovering opioid addict. My drugs of choice were Xanax and heroin, fentanyl, basically the same thing at this point. I come from a similar background as Riley. My mom is a pediatrician. My dad was in banking. I had a good childhood. Things started to go off the rails. My parents got divorced when I was 12, started smoking weed at 13. And at 14, I tried painkillers for the first time. It was oxycodone prescription. It was given to my sister. I can't remember. I couldn't find weed one night, went through the medicine cabinet, found oxycodone, and I tried it. And it felt like I had found my calling finally in a weird way. And after that, there was, I think, about 30 pills in that prescription. I went through it in about 2 days and started going way out of my way to seek out more, which was surprisingly too easy for a 14-year-old. I was a bit connected in like weed and psychedelic circles, but very quickly I found people willing to sell painkillers to me at 14 years old. Fast forward to 15, I tried Xanax for the first time. It was that same feeling, like my calling had been found. So that combination is extremely dangerous. By 16, I was having seizures from Xanax withdrawals, and I entered Hazelden for treatment for the first time. I was there for 4 weeks, and it was a great experience. It was, I think, all that can happen in 30 days, but I was just not ready at 16. I thought I knew more than the world. I thought I knew more than the doctors at Hazelden, which is pretty crazy. And another big problem was I got out and I went right back to the same neighborhood, the same people, all the same things that I was getting high in. So shortly before I went to Hazelden, I tried heroin for the first time, and I got out, and that was my relapse drug quite quickly. I was smoking heroin once again. 17 years old, I had my first actual overdose. It was sold to me as heroin, but it was white powder, which usually it was tar, so I'm sure it was fentanyl. And after that, coma for a couple days, and I went straight into a wilderness therapy program, which they have a certain reputation. The one I was at, I actually have nothing but good things to say about. It's called Open Sky out in Utah. I was there for 13 weeks, which is a very long time, but I think truly it did save my life. And I got out, didn't repeat the same mistake. I went to Arizona for aftercare. I'm from Milwaukee, I forgot to mention that. So I got out of the Midwest, went to Arizona, and I stayed clean from 17 to 21. I had probation motivating me, keeping me afraid of failure. But also, I think a big key was seeing that there's other young people that also want to be sober. Like I wasn't this freak that had this problem surrounded by normal people. I think to find others that had the same issue was really huge. Also, in that 4 years, completed probation, completed high school, started taking classes at community college, lived not on my own, but not in sober living, on my own, away from my parents for the first time successfully. And after 2 years of community college, by that time, my mom and sister had moved to Minneapolis. Both of them went to the University of Minnesota, and I got into the University of Minnesota. So I was done with probation, so I shot my way back up to the Midwest. And I made a very, very bad decision. I decided I could start drinking again. Casually was my thinking. I thought I had matured enough, that I made mistakes when I was young, and that I could drink with friends and such. That progressed quite quickly to smoking weed casually, using cocaine casually, using Xanax casually. And shortly before COVID hit, January of 2020, my girlfriend cheated on me. And things got really bad from there. I think COVID hitting, classes online, all that stuff came together to form what was probably the worst time of my life. Let me think where I'm at. There was several overdoses in there. I can't really keep track of them. Honestly, one of them I overdosed in the bathroom, which was locked because I thought I was hiding my use from my roommates. They heard me hit the floor, kicked the door down, called the police, that whole thing. My next treatment was at 22. I went to Lodging Plus at Fairview, another fantastic program. I have nothing but good things to say. And I was already on Suboxone, but they switched me to the Sublocade injection, which is personally, I think, a miracle medication. It's made all the difference. It's instead of the strips, you get a monthly injection and it slowly releases 24 hours a day. I also went to Elite Recovery after inpatient treatment, and that is a program where they pay your rent while you're going to treatment. So essentially, you don't have to worry about anything other than staying sober and going to group and all that stuff. And yeah, that pretty much brings us up to now. I'll get 2 years on November 1st, which ironically is like 6 days from now, I think. Thank you. Thank you. Yeah, that's all I got. Thank you, everyone.
Thanks for sharing, Andrew. Vanessa, do you want to? Sure.
Hi, my name is Vanessa Isaac Marlowe. Last week, October 17th, was 4 years since I got the terrible phone call that no parent ever wants. It was my 40th birthday. My husband had a surprise party for me, and I waited for the phone to ring all day. My 21-year-old daughter was traveling with her friends, but she always called on my birthday. So at 9 o'clock, the phone rang, and I answered the strange number in anticipation that it was my Drew calling, but it was a detective from Arizona saying that they found her lifeless body in an Airbnb with some blue pills on the nightstand. My world burned down that day. The pain was so heavy that even walking was difficult. I carried that tremendous weight of guilt, shame, rage, and deep sorrow. I had some of my best friends and coworkers come to visit me, and they prayed over me. And God gave me a vision of Drew in heaven, and she was whole, and she was healed, and she was home. Ever since that vision, I've had peace about her death, but that vision has also given me a mission. I've started the Drew Isaac Foundation. My purpose is fentanyl awareness and advocacy against this terrible drug. Fentanyl is tearing apart families and building encampments of unhoused people. It's driving up the crime rates and devastating our communities. Fentanyl is a weapon of mass destruction and an equal opportunity destroyer. It is the #1 cause of death for 18 to 45-year-olds in the USA. Taking steps to curb the distribution of this drug is in everyone's best interest, especially the precursor chemicals. I believe that getting the precursor chemicals out of distribution would make the biggest impact. Harsher laws for people that distribute fentanyl, and allowing advocacy groups to go into schools elementary schools, middle schools, high schools, to educate the children about fentanyl is really important. The Drew Isaac Foundation aims to do this and much more. I give out free fentanyl everywhere I go. We just held our first fentanyl awareness event in September in Maplewood. It was a great event. There were a lot of people there. There were a lot of children that came with relatives because they had lost a parent. So that made me think about all the kids that need mentoring and need somebody to talk to about the loss of a parent so that they don't fall into the same trap of substance use disorder. So that will be my next venture, is mentoring kids in the community. Thanks for listening to my story.
I admire you so much. Thanks. Thank you for sharing, and thank you to all of you for being willing to share your stories and like help the next family or the next person. We'll open it up to the audience now, if folks have questions. And while you all are thinking of questions, I'll kick it off with the first one. What do you think the public misunderstands the most about fentanyl addiction and its consequences?
Well, I think if you don't have personal contact with anyone that has died of fentanyl, there's still a misconception that it can't happen to me, it can't happen to my family. I know I felt that way, just with all of the education, and you just don't know what's going to happen. And so if everybody knows about it and is aware of it, whether you've lost someone or not, I think that is true with any drug, but particularly with fentanyl, since one pill can kill.
I think people don't understand substance use disorder itself. They don't understand how easy it is to fall into the trap of using drugs and becoming addicted, especially to something like meth, fentanyl, heroin, opiates. You use them one time and you're hooked. You're in there, and it's no fun from there on. A lot of people think that it's a choice. It begins with a choice, but it becomes a disease right away. So I think that's a misconception that a lot of people have.
I remember a conversation I had with Riley when he was in that 2-year recovery period, and he was really opening up with me. And, I was asking him again, why did you start in the first place? But I also asked him, like, hey, that you can always call us. You have people that you can rely on. And he said, Mom, when I was with somebody or I met a friend and then I realized they were using and I saw it, it went from thinking about that drug to then I was high. I don't ever remember the steps in between. And I think that's the chemical imbalances and things going on in the brain with the disorder. And I can't say for myself, but he told me that it would go blank and he would remember thinking about it and then he was high.
I can only speak for myself, but I think in my experience, a big part of not opening up to people about addiction was knowing the stigma. I had only heard the stories. I hadn't experienced it myself yet. And I think Minnesota handles that really a lot better than the other states I've lived in, but it still exists. And I think just events like this, spreading knowledge of the disease model of addiction, that's the only way we can approach getting full empathy across the board.
It's a good lead into one of the other questions for the panel is about like, how do we foster empathy about addiction, and especially regarding stigma around fentanyl use? If anybody has any additional thoughts on that.
I think it's personal stories. I think it's connecting with people and being able to relate to people's stories fosters empathy.
Is there any questions from the audience?
Sublocade. It's I think there's another name for it, but yeah, Sublocade. It's currently quite expensive. I'm able to get it on state health insurance, so I'm guessing others can as well. Once a month, yeah. It starts at 300 milligrams, so 10 milligrams a day, and then you can go down to 100, and I'm currently at 50, which is about half a milligram a day, something like that.
I don't, well, it may be just a question for you, I'm not sure, but what do you think the biggest misunderstanding is about medication for opioid use disorder? And I guess it could be for everybody, it doesn't have to be just a person who's on it, but just in general.
Yeah. I think before I was on it, I had heard the stories of getting off of it and how it's worse than getting off dope. It's basically talked about even in circles of users, like getting off of it is the worst thing that you can experience. And I haven't had that experience at all. So yeah, that's another good point. Yeah. I think the horror stories affected me. There's also an even higher amount of stigma, I think, on methadone, which for some people, I'm lucky. Suboxone has been enough for me. It's worked perfectly, but it's just not enough for some people. So.
It's kind of a follow-up to that question. Wouldn't be shocking to you, Andrew, to hear that the controversy around medications in the recovery community, and that's, I think, saddens a lot of us. Have you experienced judgment around your being on medication from other people in recovery, and how do you manage that?
I don't know if judgment is the right word, but there is certainly heightened suspicion in certain sober houses. There's AA sober houses and non-AA sober houses, and bringing medication for opioid use into AA sober houses can cause more intense room search, more frequent medication checks, stuff like that. So I guess that's a form of judgment, but I've definitely experienced that. Well, I moved to a different sober house eventually. I mean, thankfully there's a bunch of options for the program I was doing. It was definitely extremely stressful though, especially I think I was 40 or so days sober at that point. There's still a lot of stigma surrounding it, even in sober houses, which is crazy to me.
And I'll speak up to that too. I think Riley had stigma around that as well, and that's why he wanted to taper off. He thought eventually I need to get off of this. I had the opposite thought because people take medication for diabetes, for all types of things. This is a medication that can help keep you alive and also blocks any type of opiate. So for me, I love the fact that he was on it, and so I think he was facing that stigma, but didn't know how to express it, especially in the workplace, people he knew, that type of thing.
Question back here. I want to thank you guys again for sharing your stories with us. These are the stories that we need to hear, especially when we're talking about a topic as heavy as this, and very appreciative. And my question is going to be a bit heavy because, well, I don't know what each and every one of you are feeling from a parent standpoint or as an addict in recovery. I know what it feels like from a brother standpoint. In November of 2024, I lost my younger brother, or in November of 2020, excuse me, I lost my younger brother who had reached a point in his life too, where he thought that, or felt that substance use was the only way that he could kind of grasp on to what was happening in his world. And one night he went out on the streets and he bought marijuana. It happened to be laced with fentanyl, and he died that night. Accidental overdose from it. So, well, I don't know what it's like from a parent perspective. I know what it's like from a brother perspective to lose a younger brother in that instance. And that's part of why I'm so happy that we were able to have this conversation today. And Teresa and Vanessa, I'd love to hear from your perspective as a mother going through that. I watched what it did to my mom. I also lost my mom just about a year and a half ago, 2 years ago. And I think a lot of her loss came from losing my younger brother. So what kept you guys going as you were dealing with the rippling effects of losing your child? And how did you handle the blame that you maybe did or didn't put on yourself, or the blame that you put on other people? Because that's something that I know myself, I had to work through a lot of. I know my parents had to work through that. My family members had to work through that. So if you can just talk about some of those angles, we'd really appreciate that.
You want to go first?
Oh, sure. You talk about blame. Boy, does that hit home, because you think about all the different things that happened and, well, what if I wouldn't have gotten divorced and stuck through this marriage just for the kids? What if I would have recognized that Riley had anxiety? I didn't grow up knowing what anxiety was. If you had a problem, you talk to your parents, whatever, you fix it. I was a fixer. I was a fixer in my job. I worked with a lot of people, leading people. And so to me, I didn't really know the term clinical anxiety, or that it was like a medical problem or something like that. So if I had only read more about it, so you can beat yourself up to death on this. And I finally had to forgive myself. And the thing that really kept me going is I knew that even though he was gone from me, part of him was still with me in all of the memories, and that he was in a better place. He's with family members right now. And it's interesting, as time goes by, I recognize certain things happen. I see something, I feel Riley all around me. And so now I feel love. I feel his love around me in a different way, but it did take a while to get there.
First of all, I'm really sorry what happened to your brother, Mason. That is really tough, especially with marijuana. I work at an adolescent boys facility, and there's a lot of people that do not even believe you can die from fentanyl through marijuana. So you should really tell your story, because that story can really, really help some people, especially these young boys that I work with, who are in denial that can even happen. So as for Drew and her passing away, I am so blessed that I went through the program Minnesota Adult and Teen Challenge, and I met Jesus there. So I'm a woman of really strong faith. He has carried me through losing my daughter. I don't think I would have lived through it if I didn't have that faith. Her dad died 5 months after Drew died. He did not have the faith and the resources and the support. They said it was from sleep apnea, but I truly believe it was from a broken heart. She was his only child, and it was bad. So yeah, and making the Drew Isaac Foundation and working in the substance use disorder field and helping others recover is what has helped me get through this, because without that, I don't think I couldn't even get out of bed if it wasn't for those things.
One of the things that you all really spoke to, from you talked about building community, and that's the way that you work to eliminate drugs in your community. You talked about Riley and his lack of community being a trigger for him. You didn't talk about it. You talked about it at the table, but like collegiate recovery and that community, like bonding you. And Vanessa, you just spoke to it really clearly about how your community is what kept you strong, right?
Mm-hmm.
And so can any of you speak a little bit more to like that importance of community in fighting this crisis?
Yeah, so while everybody was talking, I had forgot about something that just happened to me. So I go to shoot review meetings every Thursday, city Minneapolis, and we talk about different people getting killed, different people getting shot. And on my way there, I was downtown, and I happened to just look because I'm constantly still in street mode. I'm always looking around who's around me. Just some personal crazy stuff. But I looked to my side and I seen a guy just kind of dancing around and, you know, acting real like I knew he was high off drugs. And I kept looking at him like, man, I know this kid, but he looks so far gone. I mean, to like he had been on the streets forever. So I'm looking, I'm trying to put and I'm like, it looks like this person. So I go to the shoe review meeting and I'm like, oh, this was, I think, the probation officer. So I asked him like, hey, is this true about that? Because I think I just seen, he was like, yeah, he's really going off fentanyl. And I mean, y'all, that really hurt my heart. I mean, because he was one of those kids that would come to my house like, man, Forum, I need help, man. I need to get a hotel right now. I need to get off the streets, this and that. And we always just had talks, you know, and to see him like that was heart-wrenching. It's like I don't think he would have ever did that off weed or, you know, and I'm not trying to say one for the one, but just off fentanyl, it just was, you could tell he was really far gone. And it really hurt my heart. So yeah.
Yeah, you reminded me, I totally skipped it in my story, but I'm part of the collegiate recovery program at Augsburg called Step Up, which is basically anybody that has more than 6 months sobriety gets certain scholarships and special housing and such at Augsburg. So my whole floor and the floor above me is all Step Up people. So it's very unlike a usual dorm. There's no drinking. I mean, there's cigarette smoke pit, of course, but other than that, it's all sober people, and it's very wonderful it kind of just teaches you how to have fun and without drugs again. And that's a lot easier to do when everyone around you is doing the same thing.
Yes. So I think the recovery community, I'm also in recovery from substance use disorder. I'm 7 years substance free. And just the recovery community and having someone to talk to about everything, not only the losses, the wins, the losses, everything that goes on in your life is just huge for people recovering from substance use disorder. And I think it makes a world of difference. They say that the opposite of addiction is connection. And I truly believe that, especially when you're leaving the addiction world, you're an outcast. You have nothing. You have no friends. You're lost, and you need another community to walk into. So it's really nice that there are a lot of recovery communities. They're all over. Every city has them, and they'd be really helpful in helping the fentanyl epidemic.
Congratulations to both of you on your sobriety. Any other questions from the audience?
I was just curious, from your guys' perspectives, and obviously hindsight is kind of 2020, but is there anything that you've maybe learned along the way that we can help protect kids and young people growing up with us right now, to maybe help prevent this in any way? Or do you see any trends or anything that we can help implement so maybe this doesn't happen to somebody else?
Say check their social media.
Mm-hmm.
Social media is like the deadliest drug, I believe, on the market, because it's easiest way to get whatever you want.
And as a parent, you should trust your instincts. I didn't act on mine enough because I wasn't sure. I was busy at work, and there's guilt behind all of that too. But I thought, I trust my kid. He has the tools. We gave him the tools, but always trust your instinct. It's better to ask questions and have it be okay than not.
I personally think it would have helped me if I'd been told honestly about drugs. Like my parents' generation was a DARE generation, so they kind of fed me you smoke weed, you'll die, or whatever you're taught in DARE. So being given honest information about how addiction progresses and who's more prone to addiction, that sort of stuff would have helped me a whole lot.
I think it's important for kids to see good mentors and see positive people in their lives, especially when they come from a broken home. when there's a loss of a parent or a divorce or whatever's going on where they don't have a two-parent household. It's really important that they see somebody positive that is doing good things in their life, like going to school or getting good jobs. When you don't see those things, you don't become those things. So I think that's important.
Vanessa, you talked about earlier, handing out free Narcan. How many folks in the audience are, trained to administer Narcan?
That's
Great.
awesome. So
And
much
so,
better.
for the rest of you folks, there's Narcan back on the table. There's videos online about how to administer it. It's very easy, to give somebody, and it really can save someone's life. I've seen people like on the side of the road or in their car, like turning blue, and somebody saved them with Narcan. And I know folks that do that work. My friend Randy Anderson, like he gets calls quite a bit about that Narcan you gave me and then the story that they share. And so I think one of the things that we can do to help young people understand is to get trained ourselves on how to administer Narcan, and then be honest with our kids about what it's for and like what a great visual of the danger of it, right? Is showing them like the reversal drug. And so just encourage everybody to get trained. You could save a life.
Also, about Narcan's like not a drug that you can get high on or anything like that. All it does is knock the opiate off the opioid receptor. So when you give it to somebody, it's not like they can get high or somebody will get sick. You can Narcan anybody and they're not going to get hurt or anything like that. So if you see somebody that's passed out, Narcan them just like an ambulance would.
With you, Andrew, when you said you were 16, you kind of got into treatment, I guess. And you said you kind of felt like you didn't have to listen because you knew it all. You felt like you knew it all. Nobody could tell you nothing. So how do you reach a youth that's in that state of mind?
That's a tough one. I would say you have to start at their level and you have to be persistent. Like it might take a very long time for them to let their walls down, but everyone does eventually if you stay with it. Yeah, that's about all I got.
Kind of piggybacking on that, for you all as parents, and I think you as well, Vanessa, as a person in recovery, what kinds of supports do you feel like were the most helpful, like during that recovery journey? And what advice and what resources do you feel like were the most lacking?
I would say faith was the biggest thing. Finding a higher power and being able to communicate with that higher power, getting divine assistance. And then also just a recovery community of people that are sharing struggles that you can relate to, where was the biggest help for me.
For me, I was told early on by someone in IOP to take what I like and leave the rest. So for AA, similar to you, it was higher power, and I still have the same sponsors 2 years ago. For NA, I liked the NA text a lot better than AA because I could understand a lot better. And I basically took different things from all kinds of programs, merged them together as it worked for me. And that would be the approach I would recommend.
All right.
Oh, I just have a quick question. This is for Andrew. I just wanted to ask, like, how being a college student, you deal with like other temptations or stigma around college. I also went to Augsburg, so I'm very familiar with the Step Up program. And, you know, being on the campus, I remember we all knew that the building was especially for Step Up program. And we all knew that the people in the dorm were people that were having those type of problems or dealing with that. So if there is a stigma, how do you deal with that as a college student? And also just other tensions in general, like parties involved or like, you know, game days, just things in college in general.
Yeah. Well, for like on-campus stigma, this isn't great advice, but I just don't really care at this point because like everybody knows, and I'm mostly just tell people right when I meet them because they're gonna find out anyways. Parties, that one's actually still kind of hard for me. As part of my job, we have like victory parties at the end of elections and such. And my coping skill is cigarettes, honestly. I buy a pack of cigarettes and then I have something to do with my hands and I have a reason to go step outside, and that helps a lot. And also talking to my sponsor, of course.
So we heard from a law enforcement panel, we had a bunch of law enforcement people speaking. What do you think law enforcement should be doing differently from your perspective?
That's a hard one. Working on stigma, working on not viewing people that are in addiction in a negative way, which I'm sure is difficult given their jobs and what they see every day. But I think it's really important because they perpetuate the stigma, and like a lot of us do. But I think it's important that law enforcement is arresting the people, holding them accountable, doing what their job is, but also with compassion and empathy.
So I'll speak to this a little bit, Mark. Part of the work that I do at the Council of State Governments is kind of mentoring states on how to integrate behavioral health and criminal justice in better ways that lead to changes in their data. And so, and one of the things we talk about with law enforcement is like, while external pressure on people can lead to changes in behavior, I would say that for me was part of my recovery journey was I was sick of going to jail. Like I just was tired of strip searches and people telling me when to make my bed. And it wasn't the only thing, but it was part of it, that external pressure. So while law enforcement is like part of the solution, it's not the solution. And I think Keith Ellison really hit the nail on the head when he said we can't prosecute our way out of the crisis. And so looking at law enforcement and programs like LEAD, officer-led, alternatives, it's an alternatives to incarceration that starts with law enforcement instead of after adjudication. It's like before, and really helping them to see that they have alternatives, right? Because we talk about criminal justice reform and we talk about changes, but we don't ever give another alternative, right? Keith talked about that pendulum back and forth, and we need to give law enforcement another alternative. And I think the other thing that we think about, and I think Minnesota doesn't do this as much as other states do, but if the only place somebody is really getting quality treatment is while they're incarcerated, judges and the criminal legal system is going to incarcerate them with this idea in their mind that they're going to get the treatment that they need there, when really they need to be out in community and receiving treatment. Sometimes, you know, the best thing for them is a culturally specific treatment that they are only going to get out in the community. And so I think helping law enforcement understand that they're not the solution, but they can be part of the solution. And then to give them something other than the hammer to use is key for states and for Minnesota.
Is there something specific that someone did, whether it was while you were working through your community, working through loss, working through addiction, that made your day a little bit better, that maybe we as community members can replicate to make someone else's day a little bit better?
I think it's empathy. Not saying, oh, I want to avoid this, I don't want to talk about it. Embracing it, saying, are you doing okay? How are things going? It's again, the communication, the connection that Vanessa mentioned. That's what it's all about.
I'd say empathy and affirmation. And then also if you know someone who has lost someone like myself, don't be afraid to talk about that person that's lost. Like they want to talk about them. I love my Drew and she means the world to me. So when people mention her, I love it.
I would say, I think everyone kind of has this process of unseeing when it comes to people on the streets using fentanyl. So when I was at that point, it was little things like someone offering me a cigarette or someone just like talking to me like I'm a person. Yeah, those made my day a little bit better for sure.
Thank you to our courageous speakers who shared their experience, strength, and hope today. Your openness helps break the silence and stigma that too often surrounds this crisis. Thank you to folks that showed up today to learn about this important issue. Together, we can transform pain into purpose and hope into action. At this time, you guys have like a 15-minute break or whatever, and then come back for the final panel of the day, which is treatment. We're going to have some treatment folks talk about strategies for recovery. So thank y'all. Thank you all.
All right, everybody. At this time, we are going to kick off our last panel of the day with these distinguished panelists next to me. I'll let them talk more about their work as we go, but at this time, I want to introduce you to each of them very briefly. Immediately to my left here, we have Commissioner Paul Schnell. Commissioner Schnell became the Commissioner of the Minnesota Department of Corrections in January of 2019 after his appointment by Governor Tim Walz. Commissioner Schnell brings with him more than 30 years of public safety and corrections experience to his current role. Commissioner Schnell's experiences began with an internship supervising adult males at a St. Paul halfway house. That experience led to a 10-year stretch of work in a variety of community-based correctional programs across the Twin Cities. Since then, Commissioner Schnell has worked with youth at the Carver County Court Services. He has been a deputy sheriff also for Carver County, and a member of the St. Paul Police Department, and then served as chief of police for the cities of Hastings and Maplewood, as well as the chief of police for the city of Intergrove Heights. To his left, we have Saul Selby. Saul serves as the senior vice president of clinical services for Minnesota Adult and Teen Challenge, which provides care to over 3,000 clients annually. Saul is a licensed alcohol and drug counselor and has over 40 years experience in the addiction and mental health field. And Saul is a published author and a national trainer as well. And then last, but certainly not least, on the far left or my left of the table, we have Dr. Kevin Doyle. Dr. Doyle serves as the president and CEO of the Hazelden Betty Ford Graduate School in Center City, Minnesota, a role he has held since 2022. Prior to this role, Dr. Doyle was the chair of the Department of Education and Counseling and a professor in the counselor education program at Longwood University in Farmville, Virginia. Dr. Doyle is licensed as a professional clinical counselor in Virginia and Minnesota and has a doctorate in counselor education. So with that, I've asked each of them to talk for a few minutes, a little bit more about their background, the work that they do. Then, as we've done with all of our other panels, we'll come back for some audience Q&A, and then I've got some here as well that we'll continue to navigate through. So with that, Commissioner Schnell, I'll turn it over to you.
Thank you. Thank you. It's really a pleasure to be here today just to talk a little bit about this. I come from, as was mentioned, being in this spot of talking about this through the lens right now in my role today of working in corrections. And one of the things that I think is a bit unique is the fact that Minnesota Department of Corrections is really the state's one of the largest treatment providers in the state. And I think that in itself is, I think, a troubling statistic in many respects. The fact that we're trying to meet this need while people are incarcerated, I think, especially in light of the previous panel and some of the discussions around community-oriented focuses and treatment-based programming really becomes a challenge. And so, for us when you have people coming into the system, we're really focused on first, can we meet the needs of people? And I think one of the things that we have to recognize is that, people don't come in pieces. And so while there may be, this fundamental addiction issues and fentanyl may be the bottom line, but when you look at our population and see the number of co-occurring disorders that people have, and trying to address a range of the traumas that have also been talked about before, these become major challenges, and especially when you're bringing people into environments that are really themselves can be very challenging, very challenging. And so one of the things for us is, as we look at how do we address fentanyl specifically, but even more broadly, substance use disorder and the range of issues that people come into the prison system with, is how do we do that most effectively? And if we are truly going to be committed to fulfilling the mission, which is really grounded in correction and transformation and rehabilitation, then how do we accomplish that? And I will just give you a little bit of a sense of the fact that while we provide a large number of treatment beds in the Department of Corrections, we do not meet all of the need that exists. We have people who come into the system and with a need for treatment and leave without having that need addressed. And so we can talk as we go about some of those challenges. But I think as it relates specifically to the issue of fentanyl, one of the things that was a growing concern for us and really across the nation was the number of people who were, walking out of correctional facilities like Minnesota's and very quickly dying as a result of a fentanyl overdose. And while we want to be highly focused on recovery and treatment, we also have to be realists about recognizing the fact that many people are going to be leaving these correctional facilities. They may have experienced and had a good experience in treatment. They may have even a high level of commitment to sobriety going forward. And yet they find themselves in really difficult positions when they return to their communities or people that they come into contact with that can really create some challenges. And so oftentimes very quickly after release, we would see people both relapse and number 1 and 2, in some cases, experience fatal overdoses. And one of the things that's caused us to do is really think about how do we set people up to leave. And certainly our goal is to try and make sure that they have support. And, a lot of work being done in the peer recovery space and those sorts of areas, including in our prisons. But we are also heavily focused on harm reduction. And, More recently, we've started to release people from prison with kits, especially people with opioid use disorders. And, that those kits include fentanyl test strips, letters of support, resource lists, antiseptic wipes, gloves, Narcan, and educational materials on how to use this stuff. And that really comes up against a lot of people's view of what should happen. You're supposed to send these people out better, fixed, so to speak. And the reality is that we have to, we could not stand by and let people die. And that becomes a higher priority. And so we know, and we've heard from family members already, and some people who've left, that giving these kits to people have saved lives. It may have saved the life of the person who left the prison, but in some cases, it saved the life of one of their family members or their parents or their loved ones or their friends. And we think that has a value as well. And so with that, I'll turn it over to my other distinguished panel members.
Thank you. Again, my name is Saul Selby. I work at Minnesota Adult and Teen Challenge. I'm originally from New York City. I came out here as a result of my counselor. I was going through treatment in New York. She had trained at Hazelden, and she said, boy, you might benefit from another month of treatment. And that was 43 years ago. So I'm not done with my treatment yet. But that was a joke. Nobody laughed. Okay, fine. Okay. So in any case, I came out here to Minnesota, and I got into a recovery. I went to the Hazelden primary program. I went to their halfway house. Lived in Minnesota for 7 months, decided it was a better environment to be in, and I began my recovery here, and I've been here ever since. And, from a personal perspective, my drug and alcohol addiction, which included opiates, was horrible. It was awful. It was terrible. And I'm sure everybody in this room knows somebody that has suffered with addiction, and maybe you're personally affected by it in one form or another, and you can concur that it's horrible, awful, miserable, and terrible. So working in the field of addiction can be painful because you hear about failures, but it can also be extremely rewarding because you see people like Gina and other people who begin to radically change their lives and have a significantly positive impact on family, on friends, on community, etc. I worked at Hazelden for 18 years. I was the clinical director there. Then I did mental health counseling, some product development, national training for the last 12 years. I worked at Minnesota Adult and Teen Challenge. Some people may be familiar with it, others may not. The name is a bit of a misnomer. Most people think, oh, you're working with teenagers. Well, we have one program that specializes with adolescent boys. They have about maybe 25 to 30 clients, but statewide we have about 1,200 beds. We typically have about 800 to 900 clients, adult clients in our beds. We also have a women and children's program in Garden City, south of Mankato, and we treat a lot of people over the course of the year. We treat at least 3,400 people a year, and there's a couple of things that are unique about Minnesota Adult and Teen Challenge. One is that we have the capacity to keep people in our system for up to 2 years. So if somebody comes into our program and they say they want to be there for 3 weeks, fine, you're here for 3 weeks. We do the best we can. We send you on your way. We connect you with outpatient resources. But if you want to spend a year, we have a year-long program. If you, after that year, want to spend another year here, we have the ability to keep you for two years. And when we talk about fentanyl, these clients, look, addiction is addiction in many ways. And I guess let me kind of backtrack a little bit when I talk about the concept of addiction. Why do people use addictive drugs? The simple answer is they work, right? They make you feel better. They give you some functionality that you're striving for. So, if you're a 15-year-old and your girlfriend just broke up with you and you're feeling sad and somebody offers you a joint, if you're not familiar with that, that's a marijuana cigarette. So you feel better, right? And then, if you're studying for the LSATs and you need energy to stay awake all night and you take a stimulant, It keeps you awake and maybe helps you with the test. I'm not sure whether it actually does or not, but you think it does because you're staying up all night and studying. And so what happens is people begin to use drugs or alcohol because they have a level of functionality in their life, and then they keep using it because they don't want to let go of it. And then the drug turns against them and their life gets worse and worse, but they don't want to give up the drug or they can't because they're physically addicted. And fentanyl is usually, it's not the first stop. It's usually, for many people, like the last drug they use, but it's the most powerful, the most addictive, and the most deadly. And we have, I don't know, on average, maybe 40 to 50% of our clients that come into Teen Challenge have used and are addicted to fentanyl. And, we have MATs available to them. Maybe 30% of our clients are on Suboxone when they start. And, we have a special track specifically designed for people struggling with opiate addiction. And that track, includes medical services, mental health services, but also what we do is we have a lot of staff who are in recovery. And we have a lot of clients that are maybe 6 months more advanced than the early on clients. And we demonstrate to them that they're capable of recovery. And one of the challenges, and I don't want to ramble too long because I don't want to take up too much time, but one of the real challenges when you try to treat addiction is that, people talk about denial, and denial has a lot of causes, but one of the primary causes is cognitive impairment. So if you're using a toxic drug for years or decades, it starts doing cellular damage in your brain, which affects your ability to understand things well. And we may have a client that, it's just obvious their life is awful and every element of their life is destroyed because of their substance use, but they don't see it. And that's not because they just have a psychological desire to keep using the drug, which they do. It's partly because their brain has been so radically impacted by their addiction. And what they need is time. They need time to heal. And for some people, the time might be a month, but for a lot of people, it's more than that. And we try to create a nurturing, supportive environment where they want to stay, do the healing they need to embrace the recovery principles. And we do a lot of mental health work. A lot of these clients have trauma in their life. They gravitated to drug and alcohol use to manage the psychological distress associated with trauma. They need help to figure out ways to manage that distress without drugs or alcohol. So I, just out of respect for the rest of the panel, I will just pass to my left.
Thanks all. Good afternoon. I'm Kevin Doyle, and really fortunate to be in the role that I am as the president of the graduate school at Hazelden and Betty Ford. I have a few things I'd like to share as well before the question and answer period. First, I want to thank a couple of folks. First, thanks to St. Thomas for hosting this. We had a cannabis summit this morning hosted by our graduate school. So I went from the cannabis summit to the fentanyl summit. And, that might seem depressing that we have to have these summits, but I actually think this is encouraging that we're bringing brain power together to talk about these things and solutions and look at this stuff from different perspectives. So there's hope for me just in the fact that there are this many people on a Friday afternoon in particular in this room talking about this. So thank you for that. Thanks to the previous panel as well. I think people who have the courage to share their lived experience are just invaluable to this. There was a question about that. And so thank you all. I know not all of them are still here, but thank you for sharing your stories. That's how we all learn. And that's actually what attracted me into this field was stories like this. Some of the most powerful advocates, just talking about this with someone last night, are not necessarily people for whom there's been a positive outcome. Donors, friends, people who start foundations are often folks who have been affected by this with a tragic outcome. And moms seem to do this amazingly. Dads, I suppose, too, but moms in particular just are amazing advocates. So I want to acknowledge you all. And I also have to say that my friend Mark Osler, Professor Osler, is here. He and I went to college together. So students, I have all the dirt on him if you need any. Just come see me.
We'll be getting into that later.
Yeah, he probably has more on me, but at any rate, Mark and I reconnected recently after many years of not really being in touch unless Facebook counts. So at any rate, Mark, thank you for the invitation to be here. A couple of things I'd like to talk about. One of the things that I think about a lot is workforce. Who's going to do this work? And have you ever been in a job where you feel like, this is just the perfect fit for everything that I've ever done in my life, because that's how I feel. I was a counselor on an adolescent treatment unit, my first job out of my master's program. I was back when treatment was done in hospitals for 28 days or longer. That was how it was. And then I became a supervisor and administrator and worked in nonprofit world, primarily as a counselor and an administrator for almost 26 years, I think. And then moved over to academia. And now sort of on the back end of this, I get to see the counselors of tomorrow. I'm in an administrative role, but that's my discipline too. And it's really encouraging to see the people who will do this work going forward. And that's kind of what keeps me going, because people say to me and have said to me over the years, and I'll talk about my personal story in a second because it's a little different. What you do must be really depressing. And you alluded to it, Saul. Yeah, there are depressing and discouraging outcomes, but there are also tremendously inspiring outcomes too. And we heard some of that earlier as well. So to have some small role in that is just incredibly, I think the word you used was rewarding, and it's really true. And I get to see that every day. We have master's programs in counseling. So Hazelden at the time, called Hazelden, now Hazelden Betty Ford, had one of the world's first, maybe the first counselor training program in the 1960s. And in 1999, through a long series of events, we became a graduate school. So this is our 25th anniversary year that we've been celebrating. We award master's degrees at the 60 credit level, which matches licensure requirements in most states, both in an on-campus program in Center City with some components in St. Paul and through an online program. We have about 200 students currently. So our students' average age is about 43. So often these are people with pretty amazing life stories, many of which were informed by their own treatment and recovery experience, but not all. I am not a person in recovery. And I started my career in 1986. And back then, I felt like I was the only one. And in fact, there were times when I said, wow, I feel really left out. I kind of wish I was a person in recovery. And because of all of what you just said, Saul, people, the same thing, people would say, no, you don't. You don't want to have gone through what we went through. And so part of the message that I try to share with people is that we're tremendously grateful and indebted to the recovery community because they've staffed the treatment programs for the last however many decades. And yet there's still a misperception out there that that's the only way you can do this work is by having that lived experience. And respectfully, that's just not accurate. And I think we've moved past that to some degree, but that's more of sort of a, cultural notion that you have to have had this lived experience. I am really fortunate and blessed that not really affect my life very much personally. A lot of professional experience in that area, of course, but no one really in my family dramatically affected by addiction. I have a nephew who's in recovery for 3 years. He's got a great story, but it wasn't somebody I was close to growing up. And my point is to both express gratitude to people who have lived experience, and there probably aren't a lot of potential counselors here, but I'm always in that recruiting mode for students. But there were a lot of undergrads at the Cannabis Summit this morning. So, but just to say that if you think that only someone in recovery could become an effective counselor, you're ruling out 80% of the population, or whatever the number is, at least 80%. So we have to be open to that idea that this is something that you can learn how to do effectively, and combining the lived experience and the passion that people in recovery bring, and the knowledge base that those of us who are not in recovery have learned about how to do this, I think can produce incredible outcomes. The last thing I'll say is that having said all that, I'm fortunate to have all the letters after my name and all that stuff, and very privileged. Great graduate schools and doctoral programs. My dissertation was about collegiate recovery, so when Andrew was talking, it was relating to that. But probably the best learning experience for me was in that first job, counselor and adolescent program in the Washington, D.C. area. And some of you who might have had a treatment experience will remember the van driver. I was the van driver, and what that means is a lot of programs allow the patients or clients to go out to meetings as part of their treatment. It's not all done on site. And I would drive the vans, and we rotated through weekend work. And I'd be listening to these kids talk about the meeting we just took them to. And it was fascinating hearing their reactions, 14, 15, 16-year-olds, not many of whom were really enamored of the idea of being in treatment, but they were there. And we went to these meetings and we'd be driving and they'd kind of forget I was there because I was just driving the van, and they would say, that was the most awesome meeting ever, and I would try to figure out why are they saying that? Partly because there was a lot of cursing at the meeting. It was that seemed to be what they loved. And I was thinking that meeting was terrible. I don't know what but again, you meet people where they are. And then they would say, that was the worst meeting ever. And I thought, wow, there were so many amazing insights, but I was just sort of thinking that through. But hearing their perceptions made me a better counselor. But I was listening in those AA and NA meetings, 12-step meetings, and the wisdom of people's lived experience was far beyond the knowledge that I was getting in my graduate programs. Back then, there were more generic counseling programs. There weren't many people who knew a lot about substance use, really, to be honest. So I don't have lived experience as a recovering person, but I've been in a lot of recovery meetings and learned a lot from the wisdom of people who figured this out one day at a time and have just amazing stories. So that's part of the experience for me as well. So I'll stop there as well. Appreciate the comments from the other panelists, and Mason, I guess you take it from here.
So we will open it up for audience Q&A, but I've got some more specific follow-up. So I think you all still should have some pens and some note cards on your table. Please feel free to jot those questions down so you don't forget them as we continue going through. We'll open it back up in a few minutes here. But after each of your remarks, I just jotted down some questions that I want to follow up with you on. And Commissioner Schnell, first to you. You talked about how people on the outside of the prison system view your role, or the role of prisons, is to set people up to leave. How do you, to do that, you need to be able to identify people that are coming into your system and what their needs are. So what does the process for that look like? So for example, you might have someone that gets picked up on a gun charge, is sentenced to a 60-month mandatory minimum sentence if they're a felony person in possession, all of those types of situations. But the underlying issue that they really have is a drug addiction issue. How do you go about identifying that at the onset of when someone enters your walls, so to speak?
So I think it's a great question, and I'll just be really honest that I think we have learned a lot just over the years, and I think over the last 5 or 6 years now, we've been really focused on this because one of the things, as I mentioned, if people don't come in pieces, then you need to be thinking about what are the range of underlying issues that that creates this connection for the reason that they end up being in the criminal legal system. And I think what has always happened when you get off that bus from whatever county you're coming from, and you come into, in our case, if you're a man, you're coming into St. Cloud, you get brought off that bus, and from there begins this whole processing orientation that includes everything from medical evaluations, dental at some point in time, mental health, substance use, education, all of these things that if you were to go out and try to buy on your own, would be very, very costly. And yet I think historically we did all of that, but we never really brought it together in one package to say, how do we go about addressing the range of issues? And I think this has become one of the key focuses, is how do you ultimately get very targeted? We know that, for instance, people may have different degrees of need for treatment. Somebody may have come in to our prison system having just gone through a very extensive period of treatment at Minnesota Adult and Teen Challenge. And they did that really in part to hope to avoid being sent to prison. And they may have done that and maintained sobriety for a chunk of time. And lo and behold, they get to court that day and you're on the bus to prison. And so what ends up happening is that person's treatment need may look very different than the person who has never had any treatment exposure or no real interventions. And so the question really became for us historically, the Department of Corrections provided two types of treatment, long and very long. And I think, what ends up happening now is we're starting to get to this point where we start to want to look at what does the person truly need? And how might that treatment need that they have, that fentanyl addiction, be informed by the underlying traumas that they're trying to mitigate some of the pain they're experiencing. And then how do we sequence that in the most effective way? And then finally, how do we support that? And so I think right now we are in this process where we have really changed the way we bring people in and assess people and then develop individualized plans. And the key emphasis there on individualized, because what I need may be very different than what somebody else needs. And so we want to make sure that we're targeting that. And then on top of that, we are also looking at how do we incent people to do the good stuff, to take advantage of the good stuff. And we believe, and the data tells us, that if you provide good and meaningful interventions that culturally appropriate, relevant, and all those sorts of things, and you provide incentive at some level, that actually can help create better outcomes. And so these are some of the things that we're really heavily focused on in the Department of Corrections now, is to take all of that assessment and addressing the needs that a person has, treating them in a sequential way that makes some sense, and then finding mechanisms to both incent them to stay engaged in that, number one, and number two, to support them as they go forward.
It sounds like a lot of the work that you're doing right now, especially in the prison system, might be very different than how other states or other people that hold a similar role to you view their job overseeing a prison system in a different state. So are there other states that are doing this type of work particularly well? Where are you learning from, or how are you continuing to learn and adapt your strategies as you continue to go down that path that you were just talking about in terms of the holistic person treatment model?
I mean, I think we are looking at what some other states have done, but specifically when you look at things like medication-assisted treatment, this has been one of the areas that for prison systems has long been a real challenge. We're not going to do medication-assisted because we're providing some level of the medication itself in a correctional setting, security setting can become a challenge, and yet you have states today. Look, it's no secret that we've been having a massive challenge with synthetic drugs coming into the state's prison system, and really across the country. This has been a massive issue. You can go buy a sheet of this synthetic paper that looks just like a regular piece of paper, and then cut that up, and people will smoke it or use it in the prison system, and people have been dying from it. We've had people die in Minnesota prison systems because of it. So there's no secret about that. And then the question becomes, we spend a lot of resources trying to chase this, and we have to take, I think, reasonable and meaningful steps to try and keep it from coming into the system. At the same time, one of the things that we've been having some conversations about and looking at some other systems, Maine being one of them, where they pretty much, if you have an opioid use disorder, you're going to get Suboxone, period. And everybody is getting it. And what was the objective? Which was really, for me, it was a little bit like, everybody? And part of the reason that they did it was to reduce the demand for contraband synthetic drugs that was coming into the system. And so, it really, in some respects, goes contrary to what some may think. And yet at the end of the day, they have very few problems comparatively with people accessing and using this stuff, because they are addressing and reducing demand by using, in a far more progressive, liberal, whatever word you want to use, way medication-assisted treatments to try and mitigate the demand for this. And so, we want to continue to learn from that and research that, and because what we want to do is at the end of the day is help people be better. And even if that means doing things in ways that, have never matched up with what we would have necessarily thought, we need to do that. And so I think, those have been some of the focuses. And then I think, second of all, I think, I'm really proud of some of the work that's being done here around incentives and the ways that incentives will ultimately support intervention programs like treatment and both on the inside when people are in prison and when people get out. And to me, that's going to be an amazing opportunity for folks in the system. And I believe we will produce better outcomes as a result of it. Last thing I would say is that, look, we also know that, we're never going to be able to meet all the demands. We're going to have to be in a place where we're going to have to rely on community-based partners in order to meet the needs of people in our system. It's just the reality. And how do we creatively do that in a way that meets that across the state? That's another challenge and another conversation. But that gives you a little sense of what we're trying to do.
Saul, this next question for you, following up to what you were talking about as it relates to Minnesota Adult and Teen Challenge and the work that you do there. If you can just give our audience maybe a little bit more background on what some of your programs look like, what you guys offer for the 3,600 patients that you guys serve in a year, then maybe more specifically, how do people take advantage of your services if there's a family member in need or a loved one in need or someone themselves in need? What does that process look like for them to take advantage and use the services that you guys offer?
Yeah, thank you. So maybe the very front end of our process is our assessment team. People talk about interventions. I used to do interventions. They're expensive. They don't always work, but they can work. But one of the most least invasive and most helpful ways to really begin a process for somebody is see if you can convince them to sit down with a professional for an hour and a half and talk about their history of substance use or abuse. And then that person can make a recommendation that you can choose to comply with or not. And we have a very robust assessment team. So anybody in this room, if you have a person you're concerned about, you can, go to a phone and make the phone call and say, let's schedule something either face-to-face or on a call or online, a Zoom call, whatever the case may be. That's a very easy way to start a process. And typically people are quite a bit less defensive than when you put them in a room with 7 other people that might be hostile and say, you need to do this or else we're not going to do that. So that can be a helpful way to start the process. A lot of people know that, Teen Challenge has basically 2 primary reputations. One is that we have the capacity for a long program, and we're also faith-based. So those are 2 elements that are probably very helpful to people, but not everybody is excited by that. So, one of the things and let me kind of just back up around the faith-based piece, because people don't necessarily have to embrace faith to recover. But I was thinking about a great Minnesota philosopher. I'm going to check your knowledge level. Who said, let's see, what is it? When you ain't got nothing, you got nothing to lose. Anybody know? Bob Dylan. There you go. All right. Thank you so much. That's the one person that was kind of a contemporary of my age, and he laughed when I said that. Bob Dylan, in one of his more famous songs, like a Rolling Stone, says, when you ain't got nothing, you got nothing to lose. Now, I don't know exactly what he meant when he said that, but I'm thinking about our clients, right? So a lot of our clients come from the correctional system. They may have had a very dysfunctional, traumatic early life. Their addiction has estranged them from all the key people in their lives. They may not have much education. They may not have many skills. The only thing they know is that when they take drugs, they feel good for 2 or 3 hours. And now, what are you going to do to convince me that I shouldn't take drugs? So like one of the things we try to do is we try to love clients. Not physically, we try to, in a very intentional way, make them feel welcome. We try to help them recognize they can be part of this community. It could be up to a year if they want. Then when they leave, they can be a part of an alumni association. And if they are able, nobody is compelled to participate in any kind of faith-based activities, but we expose them to that. We optionally encourage them to consider that. And if people are able to connect with God, I know not everybody believes in God, but if they can connect with God, what does that do? It does a lot of very powerful clinical things. It helps eradicate shame. I might think I'm unforgivable, but now all of a sudden I'm connecting with a God that is willing to forgive me. I may think I have no purpose, but now all of a sudden I'm learning God may have a plan for my life, and that plan may be a wonderful thing. And I might feel estranged from everybody in the world, but now I realize there are a lot of brothers and sisters within this community that I can connect with. And so instead of having nothing to lose, now they've got something to lose if they go back to their drugs and alcohol, and it inspires them, encourages them, and motivates them to move forward. So like when they come in, you know, we try to be nice to them. It's a good way to start. We try to be nice to our clients. We don't always succeed, but we really try. And then, you know, we try to convince them to, if we think clinically they need another level of care, we'll introduce them to that level of care. And of course, we've got programming all over the state. We just opened up an unbelievably gorgeous center on a lake in Alexandria, and I want to go there. But they won't let me. I don't meet the qualifications. So, you know, we have a lot of different programs across the state. People can select what part of the state works best for them. We also, you know, like I talked about trauma, a lot of our clients, if we can give them hope that they can get their trauma mitigated and addressed, that also inspires them to get sober because they're trying to treat their trauma with drugs. So, we have trained a lot of our therapists in ART, which is accelerated resolution therapy, and it's a very dramatic and quick intervention to help people get past traumatic issues. But I think the one thing that really engages people the most as time goes by is the connections they create with other clients. You know, because they feel like, okay, here's somebody I care about, they can relate to me, I can relate to them, and that motivates them to move through the process.
Thank you for that. Dr. Doyle, next to you with a specific follow-up regarding your background, and I appreciate you talking about that here. And I'm curious how, back in your counseling days when you were doing that full-time, how you felt that you were able to connect or maybe struggled to connect with individuals that you might have been counseling that had substance abuse disorder or substance abuse issues, but you yourself had never kind of walked that same path as them. Talk to us about how you were able to make that connection and still get through, even though you might not necessarily feel what they're feeling.
That's a great question. A couple things come to mind. First, I have to say, since Saul mentioned Bob Dylan, it just triggered this experience. I was walking down the street in St. Paul last year, and I was looking at coming upon this family, and the kid was saying something to his parents. He looked like he was about 8 years old, and I didn't know what he said. And as I walked by, I heard the dad say, "No, that's not Bob Dylan." It's like really? I didn't think I looked like him, but anyway, sorry, I just had to say that. It was a weird experience. You know, I've been the beneficiary of some great training as a counselor. They teach us things like not being judgmental, you know, and there's a lot of judgment around substance use. And I don't even use the word addicts and alcoholics anymore, you know, but there are a lot worse words than that. But so I think there's training in the helping professions, which are typically thought of as counseling, social work, psychology, for example, that translates really well into working with people with substance use. I also think there can be problems with boundaries. And so and the kids would always want to know, of course, so they'd ask you, and so you come up with the standard answers because you really shouldn't be disclosing a lot of personal details. That's not what treatment or therapy or counseling is about. In fact, it's really counterproductive. It's not about you. It's about this person in front of you. So I would try to have fun with it. And, you know, they would ask if you're a person in recovery. And I would honor the question by saying, well, those of us in recovery don't typically share whether we are or we aren't. And then they think, oh, he said those of us. And then I said, and those of us who are not in recovery don't typically share that out of respect for the people who are, because that's their privacy. But what I would say is 40 or 50% of the staff here are people who have personal experience with this. So if that's important to you to know that there are people who understand on a personal level, that's happening here, but it's not my place to disclose who is and who isn't. And by that time, a 15-year-old's kind of like, whatever, you know, they don't really want to hear that. But I do think it's important to honor the question, you know, because it comes from a good place. Can anyone understand what I've been through? And of course, I was the van driver. So we were taking them to meetings where that's the role, that having that peer connection. Now we have peer recovery support specialists, things that we didn't really have back then, a role for people with lived experience to play. And that's not to say someone in recovery can't get a doctoral degree too. I mean, they're not just peer recovery specialists, but that's part of what the recovery experience is like, is making sure that those connections are happening. But it's probably not my role as the counselor or therapist to do that, because those are people that you're sharing phone numbers with, you're going to meetings with, you're getting rides with, you're hanging out with. You might even get into a relationship with them. I mean, all that is part of the peer-to-peer experience, or can be, but not the professional relationship. And so I sort of relied on those tried and true principles from my training, but also knew that making a connection, that's what they teach you in counseling school, by the way, is how do you build rapport and make a connection with this person in front of you who's going to tell you things that you might find offensive or repugnant or unbelievable, and not react to that. Because someone disclosing that kind of thing is what's supposed to happen in the counseling session, that says they feel comfortable and safe telling you something that they may not have ever told you. So having good boundaries is a really important part of that, whether you're a person in recovery or not. Some people in recovery, again, said with all due respect, and I think Saul would agree, over disclose that. That's not a counseling technique. Some people, that's the only technique they have. And that's not effective in and of itself. Now, I'm not saying those of us who at dinner last night, I was saying the terms they call people like me, they being people in recovery, earthlings, normies, muggles, whatever the term is, I think those are terms of affection, actually. But so I'm not saying we have the corner on the market either, but so it's that combination of people from different backgrounds, different skills. But the self-disclosure, overuse of self-disclosure can be problematic. And the last thing I'll say on that is I've served on the licensing board in my home state of Virginia for 4 terms. And I've seen the trouble that counselors can get into, just like medical doctors and physical therapists and social workers, psychologists, every profession, lawyers, we all of our professions have that small percentage of people who have difficulty with boundaries or their own substance use, whatever those issues may be. So I've seen the damage that inappropriate relationships can have among licensed professionals and their patients or clients too. And so you're always sort of thinking about that too. Is this a professional relationship? Because ultimately that's what it is, but it has elements that feel like a personal relationship because of things like rapport and connection. So how do you balance those things? So I hope that got at your question, Mason.
Absolutely. And so at this time, we'd love to open it up to audience questions here. A couple of fantastic journal members who've been running around all day for us with those microphones are back out in the audience now. So if you do have a question, please raise your hand, wait for that microphone to come on over so everyone can hear. I see one right up front here. Go ahead once that microphone gets there. Thank you.
This question is for Saul. So like the 2-year track period for the treatment that you provide, how successful are the clients going forward? Are they able to maintain abstinence for a long-term period? And do you gather that data?
We've worked with the Wilder Foundation, and I think the data we've gathered has been based on people that complete the 1-year program. And I don't really, off the top of my head, remember exactly what the data reflects, but yes. I mean, and all the research suggests the longer you stay engaged with a client clinically, the more success they're going to have. So, yeah, I mean, off the top of my head, I think we only follow, and there's a lot of, I'll just kind of qualify this. There's a lot of challenges when you try to do follow-up data with people post-treatment. Okay, first of all, you're not able to connect with everybody, so now you're just making a judgment on the group of people that you've actually been able to connect with. And then some people lie, so, but I can tell you this, that after 6 months, I think like 70% of the clients that we were able to connect with told us that they were in recovery, drug and alcohol free after a 1-year program.
Just as anybody, I just questioning whether you're seeing any real change in the clientele with the fentanyl that we're seeing throughout the communities, and what changes have you had to make to your programming to address that?
So one of the changes we've made is like we've integrated MATs into our program. I started working at Teen Challenge about 12.
Oh, can you explain what MAT means?
I think that's a good idea. Okay.
Thank you.
Yeah, medicated assisted treatment. So there are I think only three approved medications right now to treat opioid addiction. One is methadone, one is Suboxone or buprenorphine, and the other is Vivitrol or naltrexone. And they act a little bit differently. And two of them are, one's a full agonist, one's a partial agonist with an antagonist, and one's an antagonist. I'm not sure we want to go into all the details. But for a while, Teen Challenge has really grown quite a bit, become more sophisticated. Every client that steps into our residential program is seen by a physician who evaluates withdrawal needs and psychiatric needs. And if they need withdrawal medication, whether it's for alcohol or benzodiazepines or opiates, we give it. People are, like I said, about 30 to 33% of our clients are on Suboxone, meaning they've had a history of opiate use and the Suboxone is being used to treat them. A lot of our clients over the course of a year or two come off of it. Some of them don't. And yes, a lot of those clients are living just vital lives. I mean, a lot of them do get transformed and some of them leave and they're not transformed. I mean, it just varies from person to person, but we have seen a lot of success.
Any other questions in the audience? Yeah.
My question is for Mr. Schnell. I'm just wondering with, the one example you gave of sending people out with kits, and we talked a little bit about the different ideologies, approaches, mindsets around what it looks like for someone to leave, be set up for success. Have you received, and if so, how have you responded to any pushback within the workers and the work culture of the folks that are enacting those policies? I mean, there are a lot of folks who work for Department of Corrections who have a range of different beliefs around what community safety, justice, treatment look like. And I can only imagine that there's kind of a host of reactions to that. And have you received pushback? And if so, how do you handle that?
That's a great question. The short answer is yes. Pushback, and pushback comes in a lot of different ways. Certainly, it can come from people who work in the system around what they believe should happen, and there's people who really feel strongly that us giving Narcan to people when they're leaving is just an invitation to use, and have been very outspoken about that. But I also am really mindful of, we have the added dimension of being in a political environment. And there is a range of response also because we're controlled, regulated, funded by the legislature. There's a lot of different feelings that exist there. So we not only have to manage the issues within our workforce, and that is the cultural dynamics and really focusing on what works, as opposed to what has historically been an orientation toward punishment, is a big challenge for everyone. I think we come out of a system, and for many of us, the belief that the harder we make it on people, the less likely they are to do it, and we see that certainly among some in our workforce. But we also see that in the community environment. We also see it in the political environment, and we're trying to manage that from a variety of different perspectives. And so I think what we have to do is do a better job of convincing people. One of the things that I think we have to remember is that if you're working in one of these prisons and you see faces over and over and over again, there automatically becomes a shift in your paradigm around the fact that you believe that nobody is making it. And that just happens, right? Because there's nothing to judge that or compare that against. And yet when we start to show them the data that yeah, we do have about 35%, 35 out of every 100 people that come through are going to come back again, and some of them repeatedly. But we forget about the 65 who don't. And those are the stories that I think we need to tell for a host of reasons. And I think that's the benefit of the stories of system-involved folks and people who came through it, is the fact that there's exemplars of success in a variety of different ways of getting there. And I think we have to do, we're focused on this. We just had some people who've gone through the system and have met with some of our staff for that very reason. Because I think many of them never heard that, never believed that they made a difference, and the difference was not in the control that they had over the person who was incarcerated. The difference was made in the connection that was created with that person, the support, the expectations, standards, the belief that they could do well. And those are the stories we need to do, and that's not easy. We certainly have to set clear behavioral expectations of our staff, but then beyond that is how do we bring about shifts in beliefs and attitudes.
We'll go back to audience questions here in just a moment, but Dr. Doyle, I wanted to follow up on something that you had said in your opening. You touched on the workforce issue a little bit. Can you dive a little bit deeper into that and specifically talk about how the fentanyl epidemic has impacted workforce?
I don't know if I can speak specifically to fentanyl per se, and I don't know if there are data out there that would be relevant for that. So more generally, I would say I think it's a difficult workforce to recruit to. It's hard work. We don't pay very well. You might have to work weekends. You might have to work overnights. And I joke about it, but that van driving was on a weekend that I would do that. So patients or clients aren't always nice. Love is in our mission statement too. Saul said that, so trying to start from that, but you don't always get that in return. I think some of our students, we were talking about this the other day, they do internships and practicum placements, and law students do some of those too. And, you might be cursed at, or someone might throw something at you, or might not be treated very respectfully. That's not a function of fentanyl only. Now, no one should have to work in that environment necessarily if it's consistent, and yet those things could happen. I was talking to the CEO on the treatment side the other day, and Dr. Lee, and doctors and nurses have people vomit on them. I mean, these are hard jobs, and do we value them? I mean, talk to teachers, right? They have experienced a lot of the same things. So I would say probably fentanyl doesn't make it any easier. If you have people overdosing and dying in correctional facilities, and they do in treatment programs too, by the way. So, who wants to go through that? It's really hard. And yet, as Saul said, it can be really rewarding work. So I don't know there's anything specific, Mason, that I can point to other than saying it's not making it any easier. It was hard already, and it's probably even harder is what I would say.
Yeah, I want to follow up on that, maybe get each of your perspectives on this, and we can go down the line there. The work that you do is hard, and I think we've heard that all day, especially just the comments you made right there. What keeps you going? What gives you hope? What provides that drive for you to keep doing what you're doing, or to continue to, I hate to say fight back, but a little bit fight back against maybe traditional approaches that don't actually work, and as you try to change things to adapt to what actually does. So what keeps you going? What gives you hope?
Well, hear from them first, because this is great.
It's a great question. Thank you for asking it. I would say three things. One is, I don't think I was burned out, but I moved into a different role as a supervisor, administrator, and now an educator. And so I don't know if I could work with young people anymore. I remember when I knew their movies, I knew their music, I knew their slang, I knew all that stuff. I don't know any of that anymore. Maybe my skills would come back. So recognizing that maybe your gifts and talents need to be in a different role, all of those things are needed. We need accountants, we need human resources people, we need facilities people, to work in treatment programs too, and not necessarily as a counselor. Secondly, there are unbelievable stories of the things that people have overcome. It's hard to put them into words. And so I'll occasionally go to an AA meeting, by the way. I'm not a member of that fellowship, but if you've never been to a 12-step meeting, these are not down in the dumps, depressing gatherings of people. They can be hilarious and grateful, and it gives you hope. And so finding ways to expose yourself to those kinds of things, I've worked with the last clinical experiences I had was in a private practice with doctors, nurses, dentists, healthcare professionals who were smart, motivated, amazing people who got sucked into this too, often through access through their medical practices and veterinarians. And to see them and to see them become advocates, for recovery in a way that was maybe somewhat risky to them if the community knew their stories, and yet some of them would do that anyway. So those things keep me going. And then the last thing I think is to see what people in recovery can do. And that's where there maybe are some differences with some mental health disorders. The chronic mental health disorders, there are going to be some folks who are really going to struggle with this, but for the lifespan, if someone gets into recovery, regardless of whether it's an abstinence-based recovery, although that's kind of what I'm imagining, and they come back to work in the field and give back, and it's become a little more acceptable now to disclose that in high places, I probably shouldn't say that, but just about someone publicly, but I'll let that person share their own story. But it's I don't want to say fashionable, but acceptable and inspiring now, where people will share, and our some of our panelists today. But some of them become leaders in treatment programs and in advocacy movements, and occasionally, if you had a role to play in that person's recovery, there's no better positive reinforcement than that. So those are some of the things for me. And I've had to answer that question a fair amount from people who say, I don't know how you can do what you do. And that's what I try to share with them is, yeah, you have to go to funerals too. I mean, that's hard, but there is that other side of it. So.
For me, I know there's a lot of stress associated with the work we do, and some people find it more challenging than others. I've never done anything but enjoyed it. I haven't been a clinician for a while. I've been in leadership for a long time. People treat me pretty nice, so there's not a lot of incentive to quit right now. Tell you a quick story. My wife and I lead a nonprofit. We kind of recruit volunteers to go into county jails to put on religious services. And we got struck by lightning. Our house was struck by lightning, and we lost pretty much all our computers. And we have been, bought new computers. We're trying to get the data back up and running. Neither my wife and I are particularly proficient in IT stuff. And I've bugged my director of IT in the past to help me with like personal IT stuff. I'll pay you. And I said, is there somebody in your department that could help us? And we will pay them just like, little moonlighting work. And he came back to me and he said, well, Bridget can help. And I'm not sure I knew Bridget, but I said, great. And he said, Bridget will call me. I said, great. In the meantime, we just opened up a new program in Alexandria, and I was going up there. I took my wife with me to meet the director there, look at the new facility and figure out what we need to do to make it, work effectively and who's working up there. But Bridget, my wife had already contacted her. So she's the IT person at that place. And it turns out, that Bridget is an alumni of the program. Her husband's an alumni of the program. We go out to dinner and I hear their story. And so this is a lovely couple. They're both professionals. They're both well-educated, sophisticated people. She, for a period of time, was living on the streets. She had children, and she was estranged from her family entirely. They were divorced. And, she was obviously not very responsive to her kids while living on the streets. When you look at her, it's hard to believe. It's hard to believe this person was actually living on the streets. But now she's drug and alcohol free, has a professional job, married, being an effective parent. And that's all a byproduct of the work that we're involved with. And, I can't think of anything else I'd rather do.
I think, for me, it's been a journey. I started out as a social worker, became a cop, saw way too much, really horrible stuff. People who, did terrible things to other people. And at the same time, realized that, just the objective of just locking people up really wasn't very satisfying when you were thinking about the fact that that resulted in tremendous amounts of harm as well. And so it's a bit ironic that one, I was a cop, and two, that I'm now running the prison system, because I struggle with what we do sometimes. And at the same time, I think, just like everybody talked about here, if there's one thing that keeps me going, and there's been many dark days, I think in part because of the really challenging environment. You can't work in this system, and any decision you make is going to make some people happy and other people not happy. And you experience that in very real ways, especially as it plays out in politically and at the legislature. And so that can really make the job a very different experience. At the same time, being able to see people come through, and I think I just can't imagine. I was thinking about like the people that are here that are law students, and that this is what you want to do, and really being able to make arguments to get people to what they need. I think there's a tremendous opportunity and tremendous honor in being able to serve in those roles, despite the fact that you're not going to win them all. In fact, it's the ones that you don't win that are going to hurt the most. And I think, but I think being able to sit back and celebrate, just seeing that panel before, or going into a correctional facility and hearing people who are serving life sentences talk about what they see as the potential for their own lives, despite the fact that some of them aren't going nowhere outside of that environment, that community. And I think that's where I think where the honor is, and the belief, still maintaining a belief that people can and do change, and that's the objective for all of us at some level. So I really, I'm inspired by what I see people do, people who work in this really hard environments, and people who come through it and get through it, and sometimes very different circuitous kind of routes, but they do, and I think that's exciting and great to just to be a part of, to lift up, and to speak to, as that's what the system should be involved in. That's what's been, I think, the most inspiring thing for me to stay engaged.
Time has absolutely been cruising by here, and we probably have time for one more question from the audience. And then I've got one last follow-up or wrap-up question for the panelists up here. Anyone in the audience with a final question for our speakers? Also, I've got plenty more up here, but want to make sure that we get your questions answered out there as well.
Friday afternoon.
Yeah, I know. Everyone's looking at the clock, but just a couple more minutes here. We can wrap up with this. If each of you want to talk briefly about what additional resources do each of your organizations need to continue to make an impact in the lives of so many? And what can we as community members, or even the broader community, do to help?
I'll take a crack at that first, if I may. So, one of the things that's interesting, is that prior to COVID, it seems like, I know that there are a lot of imperfections in the correctional system, but I think there's a lot of good that comes out of focused correctional engagement. A lot of times people are not necessarily motivated to go to treatment. They're wrapped up in their addiction. Their thinking is not very clear. And now all of a sudden the correctional system says, listen, you can go to prison for, X years, or you can go to treatment instead. You've got the choice. They come to treatment not necessarily because they want to, but because they don't want to go to prison. And in many cases, that really does help. Somebody earlier said, people being compelled to do something isn't necessarily helpful. I don't think that's entirely true. I think, again, coming back to the cognitive challenges that people with addiction have, they're not thinking very clearly while they're in the middle of their addiction. If somebody can force them to be in a space for a period of time where their head clears, their thinking is clearer, they can be more aware of their problems, their needs, and responsive to treatment. The reason I'm saying this is because there seems to be, since COVID, the correctional system is much more reluctant to direct people in that way. Maybe and additionally, if they do direct them, they allow the person to go to whatever level of care they want. They may really need 3 months of residential care, but the client says, well, I want to go to a sober house. And because that gives me more freedom and I would prefer that level of care. So that it would be helpful if we kind of went back to giving people more direction and more leverage around getting the level of care they need. The other thing I would say, and I know that that probably Paul and Gina and other people are working on this legislatively, is that, because Medicaid dollars are not readily available to people in jails, people are not able to access resources that they should or could in jail regarding addiction and treatment, mental health, medication, whatever. And then they come on furlough to our program. And because they're on furlough, they still can't easily access Medicaid. And therefore, the client may need a lot of mental health services and, who's going to pay for that? So I know there's people working on that, but those are a couple of things that I think would be beneficial.
Dr. Doyle?
Sure, I'll try to both be brief and answer in a couple different ways. So see if I'm up to the challenge on a Friday afternoon. As a graduate school, the first thing we need is students, obviously. And so we have almost 200 students, which is very small. That's our whole university or our whole college. Pretty big program per se, but so we need students. And so what goes along with that then, of course, is how do students pay for it? And so our biggest competitor as a graduate school at the Hazel and Betty Ford Graduate School is, do I go to graduate school or do I not go to graduate school? It's not another institution usually. For us, it's yes or no. Can I do this or not? Remember, I said the average age is 43. So these are people with families, jobs, roots in the community, a lot of obligations. And so one of the things that they also often have, though, is undergraduate debt still. And so for us, scholarships are really essential to help people with this. It costs about $50,000 just on the tuition, 60 credit program. So we're kind of in the middle. So it's costly. So the donors who support scholarships for our students get a great return because the students write incredible notes of gratitude about this enabled me to pursue this work that I really have been wanting to do. So recognizing that there is a big financial obstacle, and I don't have to tell the law students that too, and you have to deal with that same question. So scholarships are incredibly helpful for us. And then the last thing I'll say is to finish a counseling program and become licensed, you have to have done typically a 700-hour internship. Well, who can do a 700-hour unpaid internship? The answer is typically people of privilege, right? And so more institutions like Saul's, we place students there too, are accessing paid internships, but that money has to come from somewhere too. And so money doesn't solve every problem, but it sure does help. And so for us, the scholarships and paid internships and things like that are often the difference between I can go to grad school and I can't, which translates into workforce. So that's the first thing that comes to mind for me, Mason.
I would just say that I think we need people to care about the issue, to be strong advocates, to lift up the exemplars in the system, because I think that helps us on so many fronts, both the people who are in recovery, people who need it, and the systems that are built to support it. And then, I think as we are seeing, I think opportunities emerge, whether it's, as Skull talked about this need for this 1115 waiver, which is really having Medicare, Medicaid really cover the costs of some of that while people are still in custody and when they transition, so that there's a more seamless connection between what happens when people are incarcerated and when they come out into the community. And then I think, just looking at the ways of creating opportunity for people who deal with and live with the struggles of recovery and addiction, or who have system involvement. When we can address some of that better, and I think be better providers of good care and advocacy for those. And I'm not minimizing the importance of accountability, because there is a key and critical component of that as well. But I think those are the main things we need. And I'm just inspired by the fact that there's a group of people who would sit here for a day on a Friday and talk about and think about this issue, because it's necessary, and we're in this together. And we don't know, we haven't kind of figured out exactly what the perfect solution is. And the reality is there won't be one. And it's going to come about because of people sitting around on a Friday afternoon or Friday, learning about, talking about, and thinking about how do you make a difference with this. And the people in this room, everyone in this room can make a difference as it relates to this issue and all of the related issues that go along with it. So I just want to say thank you for being here and giving some thought energy to this issue.
Well, we want to say thank you. I think that's a great way to conclude our discussion here this afternoon. Very appreciative of your time, for spending the afternoon, the day with us, for bringing your thoughts and sharing those with our audience today. Very, very grateful. So let's give our audience a round of applause and thank you guys very much.